Bismillah wa salatu salam ala Rasulullah. We'll start our second day of the annual SSBMT meeting along with the annual Hematology Oncology Nursing meeting, which will start this afternoon. Again, it's a pleasure to have you, and again, thank you for those early bird who's attending with us this morning. So yesterday, because of the crowded program and we had to finish before the Jummah prayer, we had to delay some of the items. So it's my pleasure to introduce the president of the EBMT, who is joining us, although not live, but with his words, which we will have it played soon. Dr. Ibrahim Yaqub Agha, who is the new president of the EBMT, and I would like to thank the previous president of the EBMT, Dr. Anna Sureda, who has been with us over the last 4 years, attending physically with us almost every meeting. So, pleasure again to introduce Prof. Yaqub Agha word and remarks for this meeting, and after it, I would like to call upon our chairs immediately after the remarks of Dr. Agha. Please.
أصدقاء الأعزاء, it's a great pleasure and an honor to be here with you today. And I would like, first of all, to thank the organizer, especially Dr. Ahmed Alaskar, for the kind invitation and the warm welcome. I would like also to congratulate them for the excellent program with high quality topics and outstanding speakers. I would like to take a few minutes to introduce the Saudi Society of Blood and Marrow Transplantation, the SSBM. And as the current president of the EBMT, I would like to highlight the importance and the potential of international collaboration between SSBMT and EBMT. The SSBMT is a national professional society dedicated to advancing the field of hematopoietic cell transplantation, as well as cellular and gene therapy in the Kingdom of Saudi Arabia, of course. It brings together physicians, scientists, nurses, pharmacists, and allied health professionals who share a common goal: to provide the highest standard of care to patients with hematological malignancies, inherited blood disorder, immune deficiency, and other complex diseases and beyond. Over the past years, transplantation and cellular therapy programs, as you know, in Saudi Arabia have expanded rapidly, both in volume and in scientific sophistication. SSBMT plays a central role in supporting this growth by promoting education, research, quality standards, and collaboration among national transplant centers. It also serves as a platform for professional development, mentoring, and knowledge exchange for the next generation of transplant specialists. However, as we all know, blood and marrow transplantation and cellular therapy are global disciplines. Progress in our field depends fundamentally on collaboration beyond borders. Through shared data, joint research, harmonized standards, and mutual learning. This is why collaboration with international societies such as the EBMT, is of particular importance. The EBMT has developed over decades a unique ecosystem combining a large international register, strong scientific working parties, educational programs, and evidence-based guidelines that have shaped clinical practice worldwide. A closer collaboration between SSBMT and EBMT offers multiple opportunities for all of us. For example, participation in international registries and benchmarking of outcomes, joint clinical and translational research, shared educational activities and training exchanges, and the adaptation of guidelines and best practices to regional context. Such collaboration is not a one-way process. The experience, expertise, and patient populations represented within Saudi Arabia and the broader Middle East region bring extraordinary scientific and clinical perspectives that can enrich international research and ultimately benefit patients globally, of course. In an era marked by rapid progress in CAR T-cell therapy, gene editing, and personalized immunotherapy, it is more important than ever that we work together, align our efforts, and build durable partnership. At the end, I would like to congratulate the SSBMT on its vision and commitment to excellence, and to express my strong support for continued collaboration with the EBMT and other international partners. Together, through shared knowledge and collective effort, we can continue to advance transplantation and cellular therapy for the benefit of our patients. Thank you very much for your attention and enjoy the meeting. Hopefully next year I will be with you in Saudi Arabia. I promise you I will be there, inshallah. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. I'm Ayman Saad, consultant hematology, King Faisal Specialist Hospital and Research Center. I have Dr. Hussam Al-Saadi with me, consultant in Al-Haras Al-Watani, Riyadh, who will be chairing this session. So, Dr. Hussam, you want to start?
Okay. Assalamu alaikum warahmatullah. Good morning, everyone. It's a pleasure today to welcome you all to SSBMT meeting here in Riyadh. And our first speaker, my honor to present our first speaker, is Prof. Antonio Rizitano. Prof. Antonio Rizitano, he's a director of hematology and hematopoietic stem cell transplantation at Aaron San Giuseppe in Avellino, and he's a professor of hematology at Federico II University of Napoli. After his education at Federico II University of Napoli, Prof. Rizitano spent 3 years at hematology branch at the National Institute of Health in Bethesda, where he dedicated to experimental work on pathophysiology of bone marrow failure syndromes under guidance of Dr. Neil White. In 2004, he moved back to Napoli, where he served as a research associate and then assistant professor in the hematology unit, focusing on PNH, aplastic anemia, as well as of stem cell transplantation. From 2010 to 2020, he was director of bone marrow failure transplantation unit and associate professor of hematology at the Federico II University before he began appointed as a head of hematology in Avellino in July 22. Prof. Rizitano pioneered in the development of novel treatment for aplastic anemia, PNH, through the seminal preclinical and clinical works. Welcome, Prof. Rizitano, and it's the floor of you.
Welcome everybody, this is Antonio Risitano on behalf of the EBMT of the European Society of Bone Marrow Transplantation. I'm really privileged to be here with you, even if not in person, to share at the Saudi Society of Bone Marrow Transplantation our experience on plastic anemia, discussing in detail the evidence, the data that we have to make a treatment decision between two different treatment options, which are bone marrow transplantation and immunosuppressive treatment. So, as you know, aplastic anemia was a disease characterized by very severe prognosis. You see here some data showing that this disease was eventually lethal in most, if not all cases, in the 70s. So I think this is something that we have to keep in mind when we discuss, even with patients, the current available treatment, which eventually completely changed the paradigm of this disease and eventually drastically changed the very dismal prognosis that we had in the 70s. Indeed, again in the 70s, this was one of the first diseases where transplant was becoming a possible treatment option. I don't want to give you details of this very old data by Bruce Camita and Ryan Storr, because of course this is just history, but I just want to highlight the fact that even in the 70s, we were able to cure patients by bone marrow transplantation, and this was eventually better as compared with the treatment, the non-transplant treatment that at that time was including just steroids and androgens. So of course, this is not a randomized data, but it is just to show you that even in the 70s, we had some evidence that bone marrow transplantation can cure plastic anemia patients. Then this experience was reproduced in Europe, and these are the seminal papers where, for the first time, we had a very, they had a very strange observation that despite of, I would say, failure of the transplantation, patient may have autologous reconstitution eventually being cured by the disease. This was eventually suggesting that immunosuppression by itself can improve the hematological response of this condition, and the stem cells from the donors were not essential, meaning that the IST was able to stop the immune attack, and residual hematopoietic stem cells of recipient origin may eventually rescue hematopoiesis of the patient. These were the initial observations. Since then, formal trials were start mostly at NIH, and you see here, you may see here that ATG, anti-thymocyte globulin, became a very effective treatment for aplastic anemia, resulting in survival higher than 60%, with, I would say, a vast proportion of patients, about 2/3 of patients, having some hematological response. Of course, the patient also required chronic maintenance cyclosporine after ATG. And so we are in the 80s and then in the 90s, and we had two very good options that may result in a survival rate of about 70%. And these are some old data from the EBMT showing that both treatment options are very good for this patient. But I mean, we should try to understand, to tailor the treatment for each individual patient to see how we can do the best for each individual patient. So the question remains the same since many decades, whether we have to offer transplant or IST to this patient. And of course, I'm focusing now on first-line treatment, because now I would say it's quite well accepted that once a patient fails IST, the second-line treatment could be transplant. But I mean, as first line, we really have two very good options, and we should try to investigate the factors that may eventually drive and shape our treatment decision. Before going more evidence about how to select the most important factors, I wish to remind you this very old, well, not very old data, this data from the NIH showing that the outcome improved a lot in the past decades. And this was not only seen, you see on the left side, in responders patient, but this was even more evident here in non-responder patients. You see how we improved from basically 10 to 20% in the late 80s to almost 60% survival in the most recent patient receiving IST at the beginning of this century. So this is very important because we are able to keep patients alive. This is mostly because we have better anti-infectious treatment. I would say especially treatment for fungal infections. So now that we have better option to keep patients alive, of course, we have to treat the disease and we have to try to find a way to have the hematopoiesis being restored from the immune-mediated death. And now, if you see the most recent data and you compare this one with the initial natural history of Kamita's data in the 70s, you see that on the left, if you use IST and eltrombopag, this is the first phase 2 trial from NIH, you see that at 2 years, the survival is very high, 97%. And similarly, in patients receiving transplantation, these are the UK data using the FCC protocol, survival may be as high as 90%, even in unrelated donors. So we do much better than 50 years ago. I think this is the very strong message that we can deliver to our patients. Say that, of course, we should do the best for each individual patient, and I will go through some data from the EBMT, eventually helping you in treatment decision. Of course, when we discuss transplant versus IST versus non-transplant, the issue is that if we choose IST, we may have less early mortality, but in the end, we could be worried about relapse, clonal evolution, I mean myeloid malignancies, and other side effects. Vice versa, if we do transplant, the issue is not too much relapse, but rather transplant-related mortality and morbidity, starting with GVHD and other problems that you are very familiar with. So let's pay attention to the most recent EBMT data from patients receiving transplantation between 2010 and 2020. You see that we are talking about many patients, 3,500 patients, and you see that broadly the survival is around 80%, which are amazing data if you once again remember Kamita's data in the 70s. These are the cause of death, so of course infection and GVHD are the most important cause of death. But do we have any factors that are associated with increased or reduced survival? Well, let's see. We did progress over time. So these data are much better than the ones from the previous century. But even in this 10-year period, you see that there was a slight improvement over time. Then we came to the most important predictor of survival, which is age. This is univariable analysis showing that basically we lose almost 10% every 10 years of patient age. And while data are very, very good in patients younger than 40, we'd expect survival largely higher than 80%. In patients who are 50 or older, you see that the survival is around 75%, which is not bad in the end, but is definitely worse than in youngest patients. And of course, as I will tell you later, we have to imagine the same survival using IST for this patient group. But age is not the only predictor. Of course, the type of transplant, donor type, largely affect the outcome as well. You see that the best outcome as expected are with matched sibling donor and matched unrelated donor. So you need a matched donor, which means for this analysis, 8 out of 8. And well, results are not very good with unrelated, mismatched unrelated donors, and I would say even worse with haplo donors. These are real life data. So when you do an haplo donor, you have to realize that the expected survival is not higher than 60–65%. When we did multivariable analysis, you see that different factors affect the outcome. Age was the most important, donor type the other one, and also in some way GVHD prophylaxis may play a role. Of course, SOROR index was also, comorbidity index was also playing a role. Whereas previous IST seems not to affect too much the outcome. And as I said, also the period of transplant was affecting the outcome. We looked at the impact of age for each donor type, and I think it is informative in treatment decisions because you see that, for instance, in matched sibling donor, patients younger than 40 are doing pretty well, and this is eventually, these are data justifying our treatment algorithm, which recommend transplant upfront for patients with a matched sibling donor who are younger than 40, whereas, you know, these 60–75% survival is not the best if patients are older than 40, and you may eventually wait a little bit. If you do the same analysis in matched, if you look in this patient population for the impact of GVHD prophylaxis, you also have the observation that CAMPA and PTCI are the ones who give the best outcome. So for sure, you should include a serotherapy. ATG is apparently a little bit inferior to CAMPA. PTCI could be an alternative which seems equal to CAMPA in terms of overall survival. We did multivariable analysis, and you see that eventually the most important, the only factors eventually affecting the outcome are age of the patient, high comorbidity index, and prophylactic regimen, and you see that CAMPA was the one performing the best. We did the same analysis for unrelated donor. You see that all curves are a little bit lower as compared with matched sibling donor, and you can see here that in any case, again, you know, between 40 and 50, you have some drop in survival. But the information here is that very young patients, younger than 18, are doing pretty well even with unrelated donor. And this is the reason why, if we are able to have quite quickly an unrelated donor, we tend to recommend upfront transplant even from unrelated donor in patients younger than 18. Again, if you look for the impact of GVHD prophylaxis, CAMPAT seems the most important, the best GVHD prophylactic regimen, performing better than PTCI. Please pay attention to this, even if these are retrospective data. And this is confirmed also in multivariable analysis, where age and GVHD prophylaxis are the only factor remaining significant in predicting a better survival. When we move to unrelated donors, mismatched unrelated donors, you see that survival is not very good. So here we are largely below 80%, and I would say that this should not be recommended as first-line treatment to patients. Here, we still have the impact of GVHD prophylaxis, but no major finding in multivariable analysis. Don't forget that, of course, here the sample size is much lower. And when we move to upload, well, okay, this is a possible treatment as suggested by American data, but please pay attention here that the outcome in patients older than 50 is very, very dismal. So this could be an option, not necessarily as frontline, even in children, because the survival is below 80%. And in multivariable analysis, the only factor affecting the outcome was age. Of course, we could not investigate GVHD prophylaxis because all patients included in this analysis were receiving PTCI. So these are the data with transplant. Let's see the other face of the coin. And these are the data from the prospective randomized RACE trial, the EBMT trial, comparing standard treatment, standard immunosuppressive treatment, ATG and cyclosporine, with or without eltron. This is the treatment design. These are, I would say, the data are published in the New England a couple of years ago, so I would not spend too much time on the details. I just want to highlight that finally we included 205 patients and 197 were eventually analyzed for all the primary and secondary endpoints. And as you can see here, the response rate was much higher in patients receiving a tropophan, arm B. The primary endpoint was achieved, complete response at 3 months higher than 21% versus the 9.9% of the standard arm, and this difference was still evident at the 6 months time point. When we use the overall response NIH criteria, you can see here that we have response rate of almost 80%, which are not different from the one seen in the phase 2 NIH trial with trifluridine. These are the most recent data. This is the final data of the trial, looking at response at 2 years, and you see that there is still a difference both in terms of complete response and overall response. So complete response rate is pretty high, it's higher than 40%. And you see here the reasons for treatment failure. And the most important difference is here in green. Basically, it was the patient not receiving and not achieving a response, some hematological response. Here you see the cumulative incidence of hematological response. I don't want to give too many details because they are already published, but I mean, this just highlights the fact that response with eltrombopag arm B here are not only better in terms of quality, but also quicker. And this is very important because you reduce the time when patients are at risk of lethal complications. In multivariable analysis, treatment arm was not the only factor affecting the response. Age and disease severity were also playing a very important role. Overall survival was pretty high. I mean, it's around 90% in a randomized trial, so multi-center trial, not like NIH. And you see that was 91% versus 86%. We are just at the borderline for statistical significance, and the factor affecting overall survival significantly affected the overall survival were treatment arm borderline and disease severity. Of course, there was some effect of age, and you see that this is more evident in patients receiving standard treatment because then patient receiving a thrombopag did much better irrespective of the age. And when we look for disease survival here, the difference is statistically significant because we have 36% in the standard arm versus 54 in the thrombopag arm. The difference was eventually due to the first year of treatment, if you look for the treatment arm, and age was also affecting the disease-free survival. It's very important to look at the specific reasons of causing the survival, I mean, affecting the survival, and we did it looking at the event-free survival, where you have 52 versus 48%. And again, this was associated with the treatment arm, the initial 12 months treatment, as well with age. And when we look for the reason causing the event eventually resulting in treatment failure, you see that the highest difference is here in green again for the response rate. So the proportion of patients not achieving a response was statistically different between the two populations. We also looked for IST discontinuation and relapse. Of course, these data are not mature because you should look at them at much longer follow-up. 2 years is not enough. We looked for additional treatment and we could not find any major difference. And you see here that the most popular treatment was a thrombopag because patients in the treatment in the thrombopag arm received additional thrombopag in case of relapse, whereas patients who have not received a thrombopag in the standard arm received a thrombopag because of lack of response. Clonal evolution, well, we have just 3 patients developing some myelodysplastic syndrome according to the WHO criteria, 2016 criteria, so there was no major concern about that with a 2-year follow-up. We also looked for somatic mutation in this patient, and we proved that the proportion of patients with mutation was about 30% at baseline, then it increased to 56% and almost to 80% with no difference between the 2 treatment arms. You see here by specific genes, the most commonly mutated genes were, I suspect, the EBMT and PGA and PCOL. And there was no major association with any clinical outcome. These data are impressed in the New England Journal of Medicine evidence. So if you want to see more details, you can look those data. I just want to highlight here that there was no impact on overall survival. So mutations were not associated with improved or worse overall survival. There was no standard dynamics of the most commonly mutated genes, PGA, DMTTA, BCOR, and ASF1. So there was just some minor increase, but you see that we are below 2%. So very small clones, which are just sitting there. And if you go even down to detect clones with a lower buff, you see that basically 99% of patients have some mutation, and they remain more or less stable over time without resulting in any major expansion. There was no specific association between different genes mutated in the same patient, so we could not find a typical co-occurrence or even some mutual exclusivity. Very few patients developed PNH, so this data eventually confirmed that what we are doing is pretty good. In children, basically you have to include two major criteria to take therapeutic decision: age and the donor type of donor. In children, if they have a matching sibling donor, you move to transplantation. Sometimes, if you have already matched unrelated donor, you may also start with unrelated transplant. Otherwise, they receive immunosuppressive treatment, and eventually, in case of treatment failure, they may have transplantation from any donor. In adults, which means patients of 40-year age or older, you start with transplantation only if they have a matched sibling donor. Otherwise, you offer immunosuppressive treatment first, and then in case of treatment failure, I would say preferentially you move to transplantation from any donor. And of course, in case of relapse, you may still consider second course of ATG, but maybe because of the transplant data and the chance of cure, I would offer second-line transplantation instead of second course of ATG. So with that, I will stop here. I wish to thank everybody, and especially a number of mentors from the EBMT, like all the past working party chair, Andrea Bacigalupo, Judith Marsh, Jacob Passwell, but also people like Gerard Saucier, and of course Neil Young from NIH. The most recent chairs registered for the Latour, Carlo Dufour, who are basically the masters as persons, not only scientifically. We did many things together, also with Austin Kulasikararaji from the King's College, and the tremendous EBMT staff, the severe plastic anemia staff, the statistician Dirk Jan and Simona, as well as the data manager Brian Enter. And with that, I will stop here and I will take questions in the live session. Thank you very much for your attention.
Okay, thank you, Prof. Rizzetano, for the excellent and comprehensive presentation. And because of the time, we have time now for question. He's live with us now, I think. Any question from the audience?
Thank you for the excellent presentation. My question is regarding using TBO or Termobag or other drugs post-transplant. Do you think it will have a benefit similar to what we see with immunosuppressive therapy?
Can you hear me? Yes, I think so. Which drug are you talking specifically? Sorry, I missed the name of the drug.
Stem cell transplant. Does it have benefit?
Yes.
We have seen with immunosuppressive therapy.
Okay, no, I mean, I cannot say that we expect some benefits from a thrombopag in this setting after transplantation. However, irrespective of the indication to transplant, we have some experience using a thrombopag in the context of poor graft function after allogeneic transplantation. Again, irrespective of the initial indication. And we see some benefit. It works, I would say, more or less like GCSF. And we were able to rescue some patients with chronic poor graft function after transplantation. I have to acknowledge that we try to identify the patient who may have the highest benefit depending on the cause of the poor graft failure. And well, basically, if you have let's say, a graft failure, a primary or a secondary graft failure, a thrombopag alone is not able to have. If you have just a poor graft function, mostly associated with, CMV infection, CMV treatment, or a little bit GVHD, well, in those cases, you may have some benefit. But if the reason is, for instance, not enough stem cells given at time of transplant, the benefit from a thrombopag is limited. There are also some experiences using different TPO mimetics. Results are more or less in line with that. So the final answer is that yes, we may expect some benefit, but if the graft is not good enough, basically even a thrombopag is not enough to rescue that bone marrow.
Question? Yes.
Regarding the data of CAMBATH that we saw, it has like better outcome compared to other GVHD prophylaxis. Does the working party recommend the use of CAMBATH or over the other drugs for GVHD prophylaxis?
Well, thank you very much for this question. As you know, nowadays it's not easy to make recommendation because when you do guidelines, you should follow, a very rigid methodology. We can just describe what we have. We have to acknowledge that the UK, the CAMPAT experience is mostly coming from UK only. And now with this retrospective data, it looks like that we have some benefit. However, the access to CAMPAT is not easy because you have to go through a compassionate use. So I think we can strongly recommend to use either CAMPAT or ATG or PTCI, depending on the type of donor. Apparently, CAMPAT is superior and is, if you like, a very easy platform that you can use irrespective of the donor type, because at least in matched sibling, matched unrelated and mismatched unrelated, it performs better than ATG. For APLO, as you know, we use a common platform, which is the ZER platform with PTCI plus ATG and plus TBI, and then after transplant, a calcineurin inhibitor and mycophenolate. So we have to stick with that. I would say that my preference is for CAMPAT if you have it available in your centers. Otherwise, you can continue to use ATG. And unfortunately, we tried many times to have a study, either randomized or a prospective non-interventional, and we didn't succeed to generate a more robust evidence. We are trying to have some retrospective study looking specifically to this question, but this is not completed yet.
Move to the next presentation speaker.
Hi, thank you. It's my pleasure now to introduce Dr. Juan Carlos Hernandez Peluda. Dr. Hernandez Peluda is an associate professor in the Department of Medicine in the University of Valencia, Spain. He is the former president of the Spanish MPN group, and he has also previously chaired MPN subcommittee of the Chronic Malignancy Working Party of EBMT. So please welcome Dr. Hernandez Peluda. Thank you. The title of presentation, meanwhile, is going to be Integrating Novel Agents and Allogeneic Transplant in Myelofibrosis.
Hello, good morning, everybody. I hope you can hear me. It is a real pleasure for me to be with you this morning, talking about the introduction of novel agents in the management of patients with myelofibrosis regarding particularly to transplant. See, these are my disclosures. And this is the outline of the presentation. First, a few words on the survival outcomes in myelofibrosis nowadays. Then I'm gonna summarize, very briefly summarize the current treatment and the new therapeutic agents for this disease. Then I will go through the transplant decision making and timing of transplant currently, and some recommendations on how to optimize transplant outcomes, and then go to the conclusions. First, let me show you the results of the outcomes of myelofibrosis in the JAK inhibitor era. So these are patients diagnosed after 2010 in Spain. This is the National Myelofibrosis Registry that comprised more than 2,000 patients, but diagnosed after 2010, there were more than 1,500. And here you can see the median age at diagnosis is 69, and the median overall survival is 6.6 years. And on the right-hand side, you can see that leukemia continues to be the main cause of death, but most of the patients die due to other causes. And actually, I usually say that any drug or any therapeutic strategy that is able to reduce the risk of these complications, even if it does not affect the clonal evolution of the disease, it may improve survival in myelofibrosis. And these are the relative survival of myelofibrosis compared with a matched population, a general population, matched for age, sex, and calendar year. This is the survival of the matched population, and this is the survival of the patients in myelofibrosis diagnosed after 2010. And as you can see here, the relative survival at 10 years after diagnosis is less than 50%. So there is a huge decrease in the expected survival of myelofibrosis with the current therapeutic strategies. And as you can see here, if you stratify patients based on the IPSS, there is a decrease in the expected survival regardless of the risk group. Although, of course, this loss of life expectancy is much worse when the patients are diagnosed within the higher risk categories. For instance, the expected survival at 10 years in patients diagnosed within the high risk IPSS is less than 15%. So here we have the only curative treatment nowadays, which is transplant, allogeneic stem cell transplant. These are the results of the EBMT in a large series of nearly 3,000 patients. And broadly speaking, around 60% are long-term survivors after transplant. It may depend a little bit on the donor type. But there is very few data on the number of patients that actually are taken to transplant in the real world life. And these are data again from the Spanish registry, patients diagnosed in 64 centers with a median follow-up of a little bit more than 5 years. Only 10% of the patients actually were submitted to transplant. It will go down to those diagnosed at an age of 70 or less. 18% of the patients receive during the follow-up period an allogeneic stem cell transplantation. So only 1 out of 5 patients diagnosed with myelofibrosis go through this potentially curative process. But the number of transplants in myelofibrosis is increasing, as shown in this slide by the EBMT, continues to increase, particularly in the elderly populations, in patients older than 65 years of age. So what is the alternative for transplant that is actually received by most of the patients? This is a non-transplant approach. Basically, a number of strategies to treat anemia, erythropoietin-stimulated agents, momelotinib, which is a novel important agent in this setting, danazol or prednisone, and then JAK inhibitors mainly to control the myeloproliferative manifestations of the disease, and then do not forget to prevent thrombosis in this disease. And here, of course, it is very important to have more information on clinical trials with novel agents. And if we are talking about novel agents, we are certainly talking about momelotinib and pacritinib because these drugs are JAK inhibitors that have very recently been approved in Europe and in the US. And they are very interesting drugs to be used in patients with cytopenias in myelofibrosis. They are less myelosuppressive, and also they have the benefit of potentially improving anemia. So these are the new incorporations in the real world setting. Then there is a number of drugs that are actually a TGF beta inhibitors, are actually drugs interesting to improve anemia, and there are some favorable results with these drugs, but they are not yet approved at least in Europe. And then there are the combinations of JAK inhibitors with different drugs targeting new pathways, imetelstat, pelabresib, navtemadlin, and selinexor. And the results so far are very interesting regarding symptom control and also histologic and molecular responses. But I should stress that regarding these molecular responses, the results are still very preliminary. And of course, everybody is very enthusiastic on the use of more driver mutation-specific agents, such as antibodies targeting the calreticulin, the mutated calreticulin on the surface of the cells, or the more specific JAK inhibitors that actually target the mutated clone and not the unmutated clone. But these drugs are in trials in very early clinical development in phase 1 trials. So there is still some time for this drug to go into the clinic. So for the time being, I say that the general algorithm that we have and the spec recommendations that have been published so far remain the same, which is first to consider patients as candidates for transplant if they have an expected survival of less than 5 years with conventional treatment. And this is the first step that we have with your patients in the first visit and then throughout the follow-up. Then it is important also to estimate the transplant risk, particularly to decide on the timing of transplants and times. And then it's important also to consider the patient perception of this balance of potential benefits and risk. So I'm just going to go very briefly through disease risk stratification, how we identify patients with a survival of less than 5 years. There are a number of prognostic scoring systems that have been validated in different series. On the left-hand side, you can see what we call the clinical hematological prognostic scoring systems. On the right-hand side, the ones that include also molecular profiling. And then there are some models that have been developed with artificial intelligence, or they have a more personalized approach to estimate the risk. I think they all perform really well to estimate survival, but there are some things that you should know is that when you apply these models into the younger age population and with the current treatments, usually only the high risk categories identify those patients that are clearly within the higher risk, what we call less than 5-year median overall survival. In the intermediate risk category, there is usually a wide spectrum of patients with a very heterogeneous disease course. So to estimate the transplant risk, we have the following scoring system. The one that we have been applying during the last years is what we call the MTSS, that was developed in Europe, in Germany and French center. And as you can see here, it takes into account some patient characteristics, disease characteristics, and the type of the donor. And it stratifies patients into 4 risk categories. Those within the high and very high risk category, they have an estimated survival of around 30% at 5 years. So you have to think a little bit more about taking these patients to transplant. This model is very useful, but it is important to remind that it lacks information on comorbidities, which is very important in the transplant setting, and also it did not include patients transplanted from upload donor or using post-transplant cyclophosphamide, which actually are modalities that are increasingly being used in worldwide. So for that reason, we recently developed a different prognostic model within the EBMT, an artificial intelligence model, and there is an online calculator that you can see, and basically includes several clinicomatological parameters that are considered not with cutoffs, but continuously, age, comorbidity, and performance status, and so on. This model was developed in more than 5,000 patients with myelofibrosis and also included a pre-identical transplant, patients receiving post-transplant cyclophosphamide. And what you are going to see when you fill in all this information is you will see a risk bar, and your patient would be here with a black arrow showing the risk of your patient, the high risk, intermediate, and so on. And broadly speaking, those patients that fall into the low risk category, they have around 15% all-cause mortality at 1 year. Those within the intermediate category, 25%, and those within the high risk category, 40% 1 year overall mortality. So this is important to take into consideration. So finally, we have to sit with the patient once or many times to have the informed transplant decision making. And in this could be kind of simple thing in this case with a high risk disease and low risk of mortality after transplant. But then in reality, you see many times that the information is not so clear and the patient doubts. And this is what I'm going to deal in the next slides, is the timing of transplant, because this is, for instance, the experience of Toronto, which I think is very relevant. This is a very important transplant center in Canada, and among the patients that they have a clear indication of transplant, around 50% actually refused to go to transplant upfront, and they decided to go through medical therapy first. And then afterwards, they actually analyze the results of those potentially candidates for transplant, younger patients with TIPS intermediate to or high. And as you can see here, 35% of these patients were taken to transplant directly, which is quite a high proportion of patients. And then the rest receive JAK inhibitors, and some of them actually eventually were transplanted. And this on the right-hand side, you can see the survival curve that actually crossed only after 5 years, and there was not a significant difference in overall survival. So with this strategy, you may lose, obviously, some patients through the path because they were candidates for transplant, but they lost the window of opportunity. But also, if you are you having close monitoring of these patients, the results are not definitely so different, at least in this experience. But it is very important to monitor carefully these patients that are actually candidates for transplantation due to their high risk of disease. And we have some tools to anticipate the treatment failure. For instance, this is the RRC model that was developed in Europe in patients receiving ruxolitinib, in which, depending on the ruxo dose, the spleens reduction, and the need or not of red blood cell transfusions, you can actually identify risk groups, and the higher risk category has an expected survival, once again, of less than 3 years. So you can anticipate after a few months of treatment with ruxo, those patients that again have a red flag that they may progress soon. Even if you've been receiving the JAK inhibitors and this treatment fails, at this time, consideration of transplant is again very important. These are data from the Princess Margaret from Toronto. Patients younger than 70 years of age, transplant eligible, and some of these patients with, of course, this is not a randomized trial, some of them receive medical therapy, and their median overall survival was only 2 years, whereas those patients that were taken to transplant had a better outcome. So again, here, very important message to take these patients to transplant. But the reality is that we have other drugs, particularly momelotinib, and some patients failing Ruxo, they did so because of cytopenias and so on. And now there is the trend to change Ruxo, for instance, for momelotinib, and that also is able to induce anemia responses. But what is the survival of these patients? We can see that in the simplified to clinical trial. In this trial, patients failing to Ruxo mainly due to cytopenias were randomized to receive momelotinib or best available therapy, and there was a crossover. But as you can see, in the whole series, the median overall survival was around 3 years. So in all these patients failing to Ruxo, they are all high-risk patients. And for this, transplant should be considered. You will have more information in this setting. For instance, this is a Ruxo myelofibrosis real-world study mainly from Italy. Patients failing to Ruxo, they were managed in the real-world setting by conventional treatment, including Ruxo rechallenge. These patients actually had a median survival of only 1.5 years, but there was another group of patients receiving novel therapy, including fedratinib, momelotinib, and so on, and the median overall survival was nearly 3 years, like in the simplified 2 clinical trial. And there were some patients that received transplant, and as you can see here with the survival curve, this was the patients that did better. Of course, the clinical condition of these 3 patient cohorts were different. But you have to think about when you change JAK inhibitor and in a transplant eligible patient that the risk of acute leukemia continues throughout the treatment. And if the patient finally progressed to acute leukemia, the results of transplant are not so good, are around 20% at the median term. So let's go to transplant optimization, which I think is a phase stage where new drugs plays an important role because, for instance, the performance status of the patient is critical concerning the results of transplant. These are Karnofsky performance status before transplant in the EBMT cohort, showing that those that have a better performance status do better after transplant. And then the spleen size. Those patients having a large spleen, they have an increased risk of graft failure, poor graft function, but also increased non-relapse mortality. And this can be seen, for instance, in this curve, these plots, cubic splines plots, showing a linear effect of the spleen size. Here you have the spleen size before transplant and the outcomes. And there is a linear effect the longer the spleen size, the higher the relapse risk and the non-relapse mortality. So this is something that we have to take into account. And there is this retrospective study showing that those patients that have the largest spleen before transplant, they have the poorest survival because they have the higher risk of non-relapse mortality. So here, novel drugs are very useful drugs. The patients, this is the EBMT, European Leukemia Net recommendations that were published a couple of years ago. And the idea was to give some guidance on what to do regarding spleen, so and clinical condition. Those patients have a good clinical condition and they have a spleen of less than 5 centimeters below costal margin, they can go to transplant directly. But those that have a spleen size palpable longer than 15 centimeters below costal margin, we do not recommend these patients to be taken to transplant entirely, but it is better to change treatment if the patient was receiving Ruxo, another JAK inhibitor, or another strategy, radiation, and so on, to improve their condition before transplant. And now there is some data on the use of fedratinib, very, very small data so far, showing responses. This is the median spleen reduction of 12 centimeters in patients failing to ruxolitinib, which is very interesting, or also with pacritinib. This is the Holborn study with Not so important results regarding spleen size reduction, but many of these patients, they did not have a large spleen. But these are useful drugs in this setting to prepare the patient for transplant. And of course, we would like to have other drugs, like for instance, pelabresib, that showed in a clinical randomized trial much more effectiveness in combination with Ruxo to decrease the spleen size. That could be very useful for our patients if this drug eventually could be approved. And then there is in another setting that the new drugs are interesting, and this is the post-transplant prevention of graft versus host disease. And there are a few centers, but I think this is increasing in real world life, that are using JAK inhibitors after transplant till day plus 30 or plus 90 in order to decrease the risk of graft versus host disease, and the results so far are very promising. So these are my conclusion. Despite the introduction of novel therapeutic agents for myelofibrosis, allotransplant remains the only curative therapy. Its indication is increasing, particularly in the elderly population. The optimal timing of allotransplant remains challenging and should be individualized, taking patient preferences into account. This is very important, but even so, another important message is the early referral for transplant consultation in potential candidates to have a close follow-up monitoring of these patients. And this is a chronic disease, so there is typically no urgency to proceed immediately to transplant, but we have to take into account that optimizing the timing and preparation of transplant is essential to improve the outcomes. And here, new agents may improve the patient's clinical condition and the spleen response, and JAK inhibitors can be useful to prevent graft versus host disease and are under investigation in this setting. I think the mutation-specific agents may represent future strategies to prevent or treat disease relapse, since they are very specific of the mutated clones, and they are not going to affect the graft versus disease control. So they are potentially very interesting drugs to prepare the patient for transplant, or to use it after to prevent relapse, or to treat an early relapse. With this, I will be happy to have any questions you may have. Thank you very much for listening to me.
mob for the old one for Hodgkin's disease. This is one element. The other element is the Canadian experience you presented in your slides, where the transplant will give you the same outcome after 5 or 6 years as the best available therapy. Actually, this is more or less a screwed type of data, because if you look at the area under the curve of the survival, the overall survival curve of that study, the area under the curve where the transplant is actually much lower than best available supportive or targeted therapy. And also, if you consider the GVHD with the transplant and you try to measure GVHD-free, disease-free overall survival, you'll see that the transplant doesn't do anything for the first 7 or 10 years compared to the best available therapy. What do you think?
Thank you. I mean, you have raised many of the caveats of our standard of care in myelofibrosis, and And I understand completely your message. But I mean, myelofibrosis is a different disease from myeloma or from leukemia. I mean, because it has, from one hand, is chemo resistant. I mean, you cannot. Myelofibrosis was treated. There were some trials with using autologous transplantation, and there was no benefit at all. And we know for many years that it's a disease that is chemo resistant. So chemotherapy has no role. So we have JAK inhibitors and so on, but chemotherapy is not the solution. On the other hand, it's not like myeloma in which you have autotransplant, that is a very safe procedure in general. Here, the alternative is allogenic stem cell transplantation, which of course has an inherent risk of mortality due to the procedure. So it is a difficult decision because actually it's not acute leukemia where you have a very short median survival if you don't succeed with treatment. Median survival is only a few months. Here you have a disease in which you have 6 years median overall survival, and some patients can be alive more than 15 years. So I think here what you need to know and what we base our decisions is in the prognostic scoring systems. So we need really to identify those patients that have a very high risk, because these patients can actually do poorly with treatment of progress to acute leukemia, and in that situation everything is going to go wrong probably, or you are going against the statistics. So I think this is a disease in which we need to know the dynamics and the risk of the disease. So our main advances have gone through molecular profiling and these sort of things. And actually, if you see to the American and European recommendations, they say consider candidates that have less than 5 years median overall survival. But the truth is that this is probably too broad, and I understand here because this includes a very high proportion of the patients, maybe 40% or at least 35% just at the beginning of diagnosis. And the truth is that many of these patients actually do not go to transplant because they want to continue being well and control the disease with JAK inhibitors. And this is a reality. But there are these guidelines. I mean, guidelines say that you should take these patients to transplant, but then you have the conversation with the patient does not want. And of course, usually there is not the urgency to do that. So through my talk, I actually wanted to emphasize where to put the red flag again, and to have this serious conversation again with your patient and say, okay, I have to transplant you because otherwise you're going to die to disease. I'm just gonna tell you what I usually do with my patient. When I see one patient into my clinic, because I'm not only a transplanted, I manage all myelofibrosis patients in my institution. I always think, this patient going to be transplanted? Maybe not now, but throughout the disease course. Is this a transplant eligible patient? And this is one group. And then if it is not, I think differently. If this is not a transplant candidate any time through. And with the transplant eligible patient, I say, okay, I don't want this patient dying from complications of the disease. I don't want these patients to go to progress into acute leukemia and so on. So I take this decision making through the evolution of the disease, and this is actually a kind of what I've been showing you through my presentation. I don't want to be. I mean, you cannot be very strict saying something like this should go, because patients also have their own lives and they have their own ideas on when to go through a risky procedure such as transplant. But what I consider a failure is not to be able to take a patient to transplant and this patient dying from disease deterioration. And this is something that happens when patients are managed in small centers and they don't think or they consider the transplant till too late. And this is actually the only way transplantation to have long-term survivals within the high-risk category. I mean, you say that the area under the curve, they may be lower because of the increased mortality of transplant, but actually, I mean, the only way you can have a patient alive after 7 years of follow-up is with transplant. I mean, with medical therapy, you will see a continuous deterioration of their clinical status. So this is how I see the situation.
Thank you. Thank you so much, Dr. Hernandez Pelota. This is very informative, and definitely there is no substitute for clinical judgments. We use tools all the time, but we have to put them together to make sense. Any other pressing question? Because I think for sake of time, we may need to move to the next. Okay, Dr. Zahrani.
If you have a patient going to transplant and spleen more than 15 centimeter, as you recommended, you will do some sort of therapy. From your experience, you will prefer to do radiation or splenectomy or JAK inhibitor. So from your large experience, what you would recommend?
What we usually do, of course, JAK inhibitor is the first thing. Patients may be receiving Ruxo, but usually at lower doses due to cytopenia. So, for instance, 10 milligrams twice daily. So you have two choices. Either increase the dose regardless of cytopenias and transfuse the patient if needed, because it's just going to be a period of a couple of months before you take this patient to transplant. This is one possibility. I usually change to fedratinib, full dose with control. If there is again cytopenias, I don't bother about that. Most of these patients, I use spleen irradiation the week before transplant. So we usually give 10 gray of radiotherapy in 5 doses from 5 days. And then the day after this, we start the conditioning regimen. We do not perform splenectomy. It's really exceptional. And I think the number of centers that do that is decreasing significantly there. So we go through spleen irradiation, although it's not magic. The data and our experience is that you have usually a median spleen reduction of around 6 centimeters or so before stem cell infusion, no more than that. But even though it's a good complement, I think, to the conditioning regimen, and it's very well tolerated.
Okay, go ahead, Sam. Thank you.
Okay, thank you. So our next presentation will talk about PNH, and my pleasure to present the next speaker is Dr. Ashraf Warsi. He's a well-known consultant of adult hematology at Princess Noor Oncology Center, King Abdulaziz Medical City, National Guard, Jeddah. He is interested in thrombosis, bleeding disorder, and MBNs. He's certified American and Canadian Board of Internal Medicine and Adult Hematology. He completed his clinical thrombosis fellowship from McGill University, Montreal, Canada. Please welcome Dr. Ashraf.
So, Assalamu alaikum wa rahmatullah. Thank you very much for the kind introduction, and thank you for organizing a scientific committee for inviting me to the meeting. Just one disclaimer, as you heard, I'm not a transplanter, so be gentle with the transplant questions for me. In the next probably 20 minutes, I'll be going through a bit of introduction about PNH. The complement system and the pathophysiology of PNH, I think this is one of the fascinating diseases where if you understand the pathophysiology and see how the drugs have been developed, it's really amazing developing targeted therapies for this disease. How patients present, what signs they have, and how do we screen and diagnose these patients. And finally, the bulk of the talk will be on the treatment options for these patients. So, just writing up ultra-rare disease. So this ultra term, I was really reluctant to use it. I found it in one of the articles mentioned, but yes, it's quite rare to see PNH. And in the next few slides, you'll see why some centers describe they have more than 1,200 patients of PNH, and why some centers describe we have only like 2 or 3 patients. I've been in National Guard for the last 13 years, and I've treated only 3 patients. So it's pretty rare, and we're a referral center, so it's pretty rare to see patients. So it's an acquired mutation of the clonal hematopoietic stem cell. The mutation happens in the PIGA gene, which is present on the X chromosome. and basically responsible for production of the GPI proteins on the cell surfaces. It's characterized by complement-mediated intravascular hemolysis, leading to thrombosis, and occasionally with bone marrow failure. So, mainly adults around 30s are usually affected or diagnosed with the disease. Its incidence really varies from center to center, and what are they using to report it? Are they using a positive clone, or are they using actually a PNH patient with either thrombosis or hemolysis? So 1 to 10 cases per million population. What do we have in local data? Really not available, but take what I'm saying with a grain of salt. In the GCC area, we have around 75 to 80 cases. This is from actually the supplies of ravulizumab, and we have 5 other patients on other treatments. So the whole GCC countries have around 85 patients in total. Male and females are affected equally. So the complement system and the pathophysiology of PNH. As you can see from the graph, so the complement system gets activated either through the classical pathway, lectin pathway, or the alternative pathway. All 3 pathways eventually go in to do the C3b amplification loop, which forms the C3 convertase, of course, first. And that cleaves C5 into C5b, forming the C5 convertase, and eventually forming the membrane attack complex. So unfortunately, I don't have a pointer here, but so those are the basic complement pathways. And what prevents the formation of these or protects the cells are basically the CD59 and CD55, which are basically the GPI anchor proteins. So what happens in the disease, when you have absent CD55, basically CD55 inhibits the C3 convertase, and the CD59 inhibits the incorporation of C6, 7, 8, 9, and formation of the MAC. So though you miss these in the patients of PNH, and that promotes basically hemolysis. So once hemolysis happens, what happens next is basically you get your LDH high, of course, just from the hemolysis, but with release of free hemoglobin, which is a scavenger of nitric oxide, that will lead eventually to end organ damage in the form of you get chronic kidney disease just from the hemolysis and injury to the tubules in the nephrons. You get pulmonary hypertension from chronic scavenging or decrease in nitric oxide and vasoconstriction. Liver damage from recurrent transfusions also can happen. Early gallstones can happen. From the nitric oxide decrease, you get smooth muscle dystonia, so you develop dysphagia, dyspnea, erectile dysfunction, occasionally chest pain as well. And with the activation of leukocytes and platelet activation and release of fibrinogen cleavage and platelet aggregation, you develop thrombosis as well. So you can thrombose and hemolyze all together, leading to, and thrombosis usually, I'll get into the more slides where common sites of thrombosis that happens. So the common symptoms that the patients present are fatigue, probably related to anemia, dysphagia, dyspnea, chest pain, abdominal pain, hemoglobinuria from the name of the disease, and erectile dysfunction. So around 16 to 46% of PNH deaths were due to venous or arterial thrombosis. Used to be the leading cause of death for these patients. Around 2 to 18% will have chronic kidney impairments, and 47% of patients will have some degree of pulmonary hypertension. So it's a quite multi-system disease, in fact. Oh, well, good as a timer, actually. So this is an important slide. This is the UK group, and if you've heard the people from Leeds, which lead the city is Leeds, but they also lead the national PNH services over there, they're going to tell you they have around 1,200 patients registered, and it doesn't make any sense from the data or from the numbers I told you, the GCC area. But basically what they're describing is this. So this is basically any clone above 0.01%, they regard as a PNH positive clone. And when they looked at these 172 patients, 65% of them had cytopenia. So probably those were your MDSs or the aplastic anemia patients. 28% had the hemolysis. MDS are separate, and thrombotic patients were very rare to be seen in this cohort of their patients. So if you regard all the and they do this, so they follow basically all PNH clone patients regularly, not necessarily treating them, it's depending on the underlying cause of the PNH clone. There's an overlap of PNH and bone marrow failure syndromes, and that goes back to their pathophysiology. So in aplastic anemia, which we just heard a wonderful talk about it, you get these T cells which are basically attacking your bone components, and because of the absence of the GPI anchor proteins on the PNH cells, these T lymphocytes do not attack or cannot attach to these cells, so they have this survival advantage. They do not proliferate, but because the marrow gets empty, they basically start occupying, and your PNH goes up in severe aplastic anemia with time. And that's what we have seen. Similar things happen with the hypoplastic MDS patients. So how do we classify them? So the classification is basically subclinical, I'll start from down, but basically one group is the subclinical PNH clones. So these are small clones that are not causing any symptoms or signs on the patients. And the other type is basically classic PNH, and what we mean by that, these are the patients who either present with hemolysis or thrombosis or both together. And the PNH type clones present with a defined bone marrow disorders, mainly severe aplastic anemia or MDS. So not all patients will behave the same, even if they have the similar clone percentage. So the differences is basically due to different or multiple occupied mutations in the gene of the PIG-A gene. So the grade of GPI absent proteins on the cell surface, they divide them into type 1, type 2, type 3 cells, and basically type 1 are the normal cells. Partial depletion of GPI anchor proteins is type 2. Complete absence are type 3. And your flow cytometry lab can actually classify these cells on their reports. Symptoms by percentage of GPI, certain symptoms are more common with type 3 cells compared to the type 1 or type 2 cells. For example, hemoglobinuria, abdominal pain, or scleral icterus are more common to be seen with patients who have type 3 cells. Similarly, LDH concentration, if your LDH is above your patients is above 1.5 upper limit of normal, you're more likely to have, again, hemoglobinuria, dyspnea, scleral icterus, abdominal pain, chest pain, and dysphagia. These are more common and probably related to more active hemolysis in these patients. So are they at risk of thrombosis? Yes, definitely. So probably risk of thrombosis, regardless of the percentage of or the type of PNH cells, it ranges from 16 to 20%, so it's quite significantly high percentage. And if your patients have symptoms and elevated LDH, the associated risk for VT really goes up. So for example, if your patient has abdominal pain and elevated LDH, then the odds ratio of developing thrombosis is 17.8, much significantly higher than if he had a normal LDH. And that really drives one of the monitoring of these patients on therapy is basically trying to get the LDH less than 1.5 upper limit of normal. So the common sites of thrombosis in these patients, of course, DVT is the commonest one, followed by the splanchnic or mesenteric vein, followed by the hepatic or portal veins. So occasionally you see voido-occlusive disease or VODs, cerebrovascular accidents, and occasionally much rare, but have been reported, the myocardial infarction and unstable angina in these patients, or what we call as white PNH. Take it with a grain of salt, but this is basically looking at the risk of different thrombophilias, comparing it to them. So the factor V-laden heterozygous is the highest risk of thrombophilia, and probably PNH is really close to it. So this really emphasizes the importance of monitoring them or treating thromboembolism in these patients. This is an old graph, so this is before the era of complement inhibitors, but basically tells you if the patient had thromboembolic events or if they had cytopenias, impaired renal function, or elevated LDH, their survival was significantly lower than those patients who didn't have it or compared to the general population. So what are the core signs and symptoms, and which patients should be screened for PNH? So patients usually, as I mentioned, have symptoms of anemia, fatigue, shortness of breath, headache. They may present with unprovoked thrombosis, dark urine, intermittent abdominal pain, or may have smooth muscle dystonias, for example, dyspnea, dysphagia, erectile dysfunction, abdominal pain, or chest pain. So they divide them into different categories. So bone marrow dysfunction, if they have unexplained cytopenia and any of the following, whether they have refractory iron deficiency anemia, non-responsive to therapy, or thrombosis, they probably should be screened for PNH. Aplastic anemia, all patients diagnosed with aplastic anemia should have a screening for PNH, looking at the clone size and monitored regularly. MDSs, if they are hypoplastic or refractory cytopenia, then they should also be screened. Unprovoked thrombosis with any cytopenia or hemolysis should be screened as well, and sometimes even without. So I basically screen all patients with unprovoked thrombosis for PNH. Coombs negative hemolytic anemia has to be done, and one of our patients, basically she's a female patient diagnosed 3 years ago, and her main presentation with hemolytic anemia, which was Coombs negative. Hemoglobinuria also deserves a screening for that. So what the labs does basically, and the recommendations from the International Clinical Cytometry Society, is doing 2 assays. One of them should be the FLAIR assay, which is a fluorescein-labeled aerolysin enzyme, which basically binds to GPI anchors, and if they're missing, basically you get negative tests for that, plus a CD55 or 59 on red cells, or doing a CD157 on granulocytes. And you need 2 different cell lines, so commonly we do granulocytes and monocytes and red cells looking for these anchoring proteins. So the initial evaluation, detailed history and physical examination are important, but the laboratory workup should include a complete hemolytic workup with a test for organ dysfunction, including renal, liver, cardiac, if available, BMPs, and bone marrow evaluation with cytogenetics. And of course, importantly, you do viral serologies and nutritional panel. Also, if you have available echocardiogram at baseline with an ultrasound abdomen with Doppler and pulmonary CT scan if suspecting pulmonary hypertension. So the treatment. So subclinical PNH, supportive care, which is basically based on nutritional supplementation. They do not hemolyze, so they don't have anemias, and regular follow-up for these patients. Classic PNH, which are basically hemolytic or thrombotic, we'll be discussing them later on. With the patient PNH type clones in patients with bone marrow failure disorders, treatment is usually directed to the underlying bone marrow disorder. So the treatment, we have 2 types. We have terminal complement inhibitors and proximal complement inhibitors. So as you can see at the bottom there, we have the terminal complement inhibitors, the C5 inhibitors, and these include eculizumab, ravulizumab, crovalimab. Also recently, there are biosimilars to eculizumab, which have been approved by the American FDA. C3 inhibitors include pegcetacoplan, and the more alternative pathway or proximal inhibitors also include factor B inhibitors, iptacopan, and factor D inhibitor, danicopan. So the TRIUMPH trial was basically a 2006 randomized trial which looked at the eculizumab in patients with PNH, and at that era we only had supportive care for these patients, so transfusion as needed, management with hydration when they presented with renal impairment and acute hemolysis. And in fact, at that point, eculizumab really changed the landscape of these patients. So hemoglobin stabilization was established in half of these patients, and transfusion independency, 51 patients, which was really unheard of, and became the standard of care since that time. There was also much improvement in patient-reported fatigue scores. So it became the standard of care. And later on, ravulizumab, which is again based on the molecule of eculizumab, was introduced, and in this trial, which was basically included 246 complement inhibitor naive patients were either randomized to eculizumab, which is given intravenous infusion every 2 weeks, versus ravulizumab, which is given intravenous infusion every 8 weeks. So significantly decreasing the number of visits. Not only that, but it was also much, so this was a non-inferiority trial, and it did reach its goal, and it showed very much significantly, and it did replace eculizumab in the treatment for PNH. They also did the second study looking at, so those were naive patients randomized, but here what they did basically took around 195 patients who were on eculizumab and randomized them to either receiving eculizumab or ravulizumab, and it was a non-inferiority trial, and they did reach their goal, so it was very similar to eculizumab, but better tolerant and better compliance with the patients. Second came the third medication in the terminal complement inhibitor is crovalimab. I don't think we have it in the kingdom here, but it has very recently, I think 2 years ago, approved by US FDA. And it is it's similarly what they did, and it was basically in the Commodore 1 study. They looked at patients who were on eculizumab versus crovalimab, switching them to either crovalimab or eculizumab, and it was a non-inferiority trial, and it showed it's tolerated very well. It's given every 4 weeks injection, so again, decreasing the number of injections. Similarly, they also did a naive patients, randomized them to either eculizumab and crovalimab, and it did very well in that, and it was a non-inferior to eculizumab, so that's where they got it approved. So was that the end of the story, and why did we need to develop proximal inhibitors? So that takes us just to define a little bit of the common terminologies in the literature of hemolysis in PNH. So there's intravascular hemolysis, there's extravascular hemolysis, and there's breakthrough hemolysis. So what do we mean by that? So in your left-hand side, the PNH untreated patients, they're missing the GP anchor proteins, and the C5 gets activated on surface of red cells, formation of MAC, and you get lysis, which is the intravascular hemolysis. When you block the C5, that really blocks the terminal pathway, so no more MAC are produced, but the C3b is still laid over the red blood cells, and these basically cause opsonization of the red cells, and they get recognized in the reticuloendothelial system, in the spleen and liver, and get hemolyzed. So this is what we call as extravascular hemolysis in these patients. What about the term breakthrough hemolysis? So breakthrough hemolysis is basically when the patients on treatment get any stresses like, for example, pregnancy, infections, vaccinations, that causes the stress on the complement pathway. And in these scenarios, probably due to the hyperstimulation, some of the C5 get through, and they form hemolysis in these patients. So that's what we call as breakthrough hemolysis. How you differentiate between extravascular hemolysis and intravascular hemolysis, this is what people, or what is published. Clinically, I would tell you it's really, really difficult, but it's basically it's a patient who is doing very well on therapy, but on terminal inhibitors, and you find that persistently they're having low hemoglobin. Some of them may be symptomatic, some of them may be asymptomatic. Probably after 6 months of therapy, and if they're symptomatic, you need to change therapy or add on, and I'll tell you in a minute what are the drugs available. So that was behind the extravascular hemolysis issue, the development of the proximal complement inhibitors, and the idea was if you block earlier on, you lose the C3b opsonization red cells, and that would prevent the extravascular hemolysis. So pegcetacoplan, available in the kingdom, the Pegasus trial, which looked at basically adult patients with PNH and persistent anemia, despite more than 3 months of stable eculizumab. It was a 16-week trial, and it showed that patients were randomized either to continue eculizumab or switch to pegcetacoplan. It showed an increase of 3.84 grams per deciliter in these patients. So that was a very significant increase in this patient. The other trial with the PRINCE trial, which was a single-arm study looking at naive patients with PNH, it's a 26-week study, and showed remarkable improvement. But remember, this was just a single arm of patients, so it wasn't comparing to eculizumab. So it did show that well. And from that, it got approved for treatment in PNH patients, and probably it has the potential of being the first line of therapy. The only issue with it is given twice weekly, so that's one of the issues with it. Oral iptacopan, the APPLY PNH and APPOINT PNH trials. So similarly, iptacopan is a factor B inhibitor up in the cascade of the alternative pathway. Here, they looked at patients who were receiving eculizumab or ravulizumab, having persistent anemia, and either and the arm A was switching to iptacopan versus just continuing on the terminal inhibitor. and it showed significant improvement in hemoglobin, so around 82% of patients had increased their hemoglobin by 2. Transfusion avoidance was achieved in 95% of these patients, so significant improvement with it. Favorable safety outcomes, so no adverse events were looked at. Common were diarrhea, nasopharyngitis, and nausea, which we see commonly when we use complement inhibitors. Ravulizumab or eculizumab in patients. So the later drug came in, the factor D inhibitor danicopan. So it's an add-on therapy to ravulizumab, again, registered and available in the kingdom as well. And we recently, just 2 months ago, added it to one of our patients. So the ALPHA-3 phase 3 trial were basically 73 randomized patients to either add-on oral danicopan or placebo to a terminal inhibitor. And what they found, their primary endpoint, there was an increase in by 2.94 gram per deciliter in hemoglobin. Transfusion avoidance was achieved in 83% of patients on danicopan. 60% of patients achieving hemoglobin increase more than 2 grams, and clinically meaningful improvement in the FACIT-Fatigue scoring system. So it was very well tolerated, 0 meningococcal infections, 0 deaths, and clinical conclusion was that adding danicopan in patients who are not achieving their goals in hemoglobin. By the way, the anemia on terminal inhibitors, different trials have used different cut limits. Iptacopan used 9.5 grams per deciliter. The danicopan, I think they used 10 grams. So it's a different level of anemia that different studies have used. So what happens to the hemolysis if you're using proximal inhibitors or if you're using combined therapy, terminal and proximal, with a danicopan add-on? So if you're using the complement proximally, yes, you're blocking significantly the extravascular hemolysis, theoretically, but then you have the C5 getting accumulated. So when a breakthrough hemolysis, so you have a stress on the complement system happens, that really causes significant hemolysis. So if one molecule of C3b red cell opsonide passes through, or C3 passes through, it will activate multiple C5 labeled red cells and cause significant hemolysis. And that's what we saw in the trials of pegcetacoplan. Whereas probably the ideal scenario is terminal and proximal inhibition as an add-on danicopan with a terminal inhibitor. So time is running out, so I'll just go very quickly. Breakthrough hemolysis can happen either pharmacodynamically, so this is what I mentioned with the stressors, but it can also happen pharmacokinetically. So in the patients who are only on proximal inhibitors, for example, iptacopan or pegcetacoplan, if you're missing a dose or you delayed in your doses, there's a significant chance that you'll have extensive hemolysis in these patients, just from the pharmacokinetic. And in the eculizumab era, I had a patient which I've seen that just because of availability issues, if he misses the doses for 2-3 days, he would present with acute renal failure from the significant hemolysis. So that's a very important factor to remember. Management of breakthrough hemolysis, there's no guideline for that, but basically this is an expert opinions. More than 4 weeks in last dose, pull dose forward. If it is less than 4 weeks, you have to observe closely. Breakthrough hemolysis on proximal inhibitors, it does happen. So iptacopan, pegcetacoplan, if they were using, ensure compliance, very important. And then probably if they have significant, you can use a single dose of a terminal inhibitor. On the other hand, C5 inhibitors with danicopan ensure compliance, of course, increase the dose of danicopan instead of BID to TID, treat the underlying cause. Allogeneic hematopoietic stem cell transplant, so I said I couldn't present this as SSBMT without discussing some of it. You've seen the severe plastic anemia working party from the EBMT. So they had this report as an abstract in the ASH 2024. Unfortunately, I couldn't see it as a full publication. But basically, they looked at 10 years, so the decade, and a total of 259 patients across 225 centers were transplanted. Male, females were probably equal. Age was around young age, so from 18 to 36. PNH subcategories, so classic PNH was around half of the patients. PNH with aplastic anemia, probably that's what for aplastic anemia more, 46% of patients. Donor type, they have around 47% matched siblings. MUDs were around 37%. And interestingly, the match and MUD did better than the mismatch MUD or the haplo patients. Source of stem cells, both bone marrow, peripheral blood, almost equally. Conditioning regimens, mainly RIC, but also there was myeloablative. And eculizumab was there used in only 28.6% of the patients. So the overall survival presented in Dodd's data at 3 years was 82%. GRFS was around 74% at 3 years, and engraftment was achieved by day 28 in 87% of the patients. And I said it's only a oral abstract, so forgive me not to have more data on that. So future directions, danicopan monotherapy is being under trial now. Pozelimab, so this is a C5 inhibitor that is approved for a disease called CHAPLE, where you have protein-losing enteropathy, thrombosis, and we actually, in the gastro department in our hospital, we have a patient on it. So it's very, very interesting, very rare disease to be seen. So combination of pozelimab and cemdisiran, basically cemdisiran is a small interference RNA molecule that decreases C5 production. Again, very promising data from the phase 3 trial. Nomacopan, again, is a C5 inhibitor with leukotriene B4 dual inhibitor, has been in phase 2 or 3 development. So probably we'll see more options coming in the future. So I'm finishing. So terminal complement inhibitors, eculizumab, ravulizumab, target C5, reducing the risk of thrombosis, stabilizing hemoglobin, improving quality of life, as well as overall survival. And probably that would be your first step of treatment for these patients. Most patients with PNH do well on intravenous ravulizumab administered every 8 weeks, but a subset of patients may develop clinically significant extravascular hemolysis. Danicopan as an add-on therapy to eculizumab or ravi may offer a more complete control of complement dysregulation, especially in the setting of a complement amplifying condition, and the long half-life of C5 inhibitors serves as a backstop against recurrent intravascular hemolysis in cases of missed medication doses. If extravascular hemolysis is unresolved, switching to other proximal complement inhibitors, pegcetacoplan or iptacopan, is an option. Allogenic stem cell transplant remains an option in selected cases, especially cases with underlying bone marrow failure. And that's just it's a bit also from 2022, but most of these drugs, actually all of these, most of them except for the others I mentioned, the trial have been approved. And with that, I conclude. Thank you very much.
Thank you very much, Dr. Ashraf, for the comprehensive, excellent presentation. And maybe we can take 1 or 2 questions. Dr. Askar.
Assalamu alaikum. Shukran, Dr. Ashraf. ربنا يبارك فيك. Considering that many of the patients with PNH will be enrolled, raise my voice?
Yeah, please.
Because I can't raise my voice at home, so I don't want to do this. So anyhow, considering that many of the patients with PNH will be enrolled on complement inhibitors nearly for life if they are not transplanted. If you face a patient with splenic vein thrombosis or portal vein thrombosis with huge splenomegaly that is exaggerating the cytopenia in PNH patients, would you recommend in this patient population to remove the spleen, or do as much as you can to do transsplenic stenting of the portal or splenic vein and continue with a functioning spleen so that you can reduce later on life-threatening infections and complications?
So first of all, if they have PNH with thrombosis, basically, they're going to need to be on an anticoagulant. And after you initiate your complement inhibitor, whether you really need the anticoagulant more or you just need it prophylaxically, some experts will just omit it after 6 months of therapy. Some experts will put it on prophylactic dose if they're on a complement inhibitor. Now, the issue with the huge spleen, I have seen that people who have developed, not PNH patients, but other reasons for JAK2, for example, and huge spleen, it causes lifelong cytopenias in these patients. Whether I haven't been in a scenario that's significant to say you need to remove it. And by chance, even if they have the splenomegaly and you, by a reason of anticoagulation, revascularize or recanalize the splenic vein or the portal veins, it doesn't go down, it doesn't shrink. I don't know why, but it still remains splenomegaly. Having significant splenomegaly and a different pathology, it may be an option to do splenectomy in these patients. It's not like a myelofibrosis patient. They do not have extramedullary hematopoiesis, so you don't worry about that. But having massive splenomegaly has its own risk during surgery. I had recently one patient who presenting with pancytopenia and massive splenomegaly. There's one of our expert surgeons told me clearly, first it's going to be an open one, second is a high mortality and morbidity from thrombotic risk, and third, most likely she will go to the ICU. We eventually did a splenic biopsy, and we got the diagnosis on that patient, which is a rare type of lymphoma. So you may consider it, but it comes with its own risks. I would only do it if it really was the last option to do that.
Thank you. For iptacopan, sorry, after
Chairman has a question, so.
Yeah, okay, after the chairman.
Ashraf, very nice presentation.
Thank you.
Regarding, we always, it's common that we face acute situation in the hospital, you're suspecting PNH, and probably, there is high probability, and you might start an agent either to stop an acute hemolysis or renal failure or thrombosis or whatever it is. So you need an urgent intervention. So which, in your mind, among these agents would have an onset of action that's more rapid than the other?
If you have ecclusive, first of all, we're in a good center, it's your sister hospital, so we can get the flow cytometry if it's in the daytime, we get it on the same day, or by mostly within 24 hours. And probably your patient can wait for that if he's thrombosing you anticoagulate, because that's the treatment acutely. If he's hemolyzing, and we see hemolysis in other diseases, for example, G6PD, very significant hemolysis, and we manage them support until we get the diagnosis. And if you get the diagnosis, eculizumab is still available. It's now registered in the kingdom, and it has other uses, for example, in transplant settings. If you have it, that's fine. If you have ravulizumab, it also has a good early onset. So any of these two, treatment, if you have a PNH patient, first-line treatment would be a terminal inhibitor. The breakthrough hemolysis is really a small number in these patients. The issue is the extravascular hemolysis. So eculizumab or ravulizumab, whatever you have available would be there, but I would really check the diagnosis. Remember, I didn't mention it there, but if you're using a complement inhibitor, 2 weeks prior, you should vaccinate your patients against meningococcal especially. For the proximal ones, you also vaccinate against pneumococcal and Haemophilus influenzae type B. So that's very important to remember. If you're in an urgent situation, then you need antibacterial prophylaxis until the vaccination works. I hope that answered your question, Dr. Asker.
Okay, thank you. For iptacopan, since it is working on intravascular and extravascular hemolysis, can be used as monotherapy from the beginning, or
yes,
only?
So the trial did use monotherapy from the beginning in naive patients. It wasn't compared to eculizumab, but yes, it's approved, and it is one of the options. Very interestingly, as I mentioned, not all PNH patients will behave similarly. So I heard from a physician in National Guard Jeddah, they have this patient they have exhausted. He was on eculizumab, ravulizumab, danicopan add-on, didn't work. Pegcetacoplan didn't work, and they were considering iptacopan. Now, the expert did mention to do that, and I think that eventually patient would be somebody with a PNH who will go for transplant. He's a very young patient as well, in the 30s.
Okay, thank you very much, Dr. Ashraf.
Thank you very much.
We'll go for next speaker.
Okay, thank you. So we'll move on. We'll move on to the next session. This is a SOBI-sponsored session on advancing myelofibrosis care from disease burden to real-world case insights. I will start by introducing my colleague, Dr. Amar Playan. He's section head of chronic leukemia, myeloproliferative neoplasm, and consultant of hematology and stem cell transplant, King Faisal Specialist Hospital Research Center. Welcome, Dr. Omar.
Assalamu alaikum. Thank you very much, Dr. Ayman, for a nice introduction, and thank you for the SSBMT to invite us to have this talk, and Subi for sponsoring this presentation. So I'll be talking myelofibrosis management, addressing patients' unmet needs. Philadelphia negative myeloproliferative neoplasm are a very rare disorder characterized by clonal proliferation of myeloid stem cells. Our focus today will be myelofibrosis. It can be either a de novo primary myelofibrosis or post-ETPV or secondary myelofibrosis, and typically diagnosed due to profound constitutional symptoms that affect patient quality of life. Although all cases of MPN have a risk of progressing to acute leukemia, for instance, ET and PV had a 15 years risk of progressing to acute leukemia around 2 to 5%. When talking about myelofibrosis, have a higher risk of approximately 10 to 20% of progressing to acute leukemia. So as I said, it's a very rare disease, accounting approximately 0.2 to 0.5 cases per 100,000 person per year as per the SEER database. It's a disease of elderly, so the median age of diagnosis is approximately 65 years old, and over 70% of the patients are over the age of 60. It's important to meticulously pay attention to the diagnostic criteria for those disease population. So they need to meet at least 3 major criteria and 1 minor criteria, being the megakaryocyte proliferation with atypia, along with grade 2 to 3 fibrosis, having the clonal mutation JAK, calreticulin, or MIPL, if it is negative, to have those specific clonal markers. The minor criteria being anemia, leukocytosis, palpable-splenomegaly, leukoerythroplastic pictures, and increased LDH. It's also very important to differentiate between pre-fibrotic myelofibrosis and ET, and that's mainly distinguished by the biopsy obtained. So the pre-fibrotic usually have less than 2 grade fibrosis. ET usually have pre-fibrotic differentiated by ET usually will have a megakaryocyte atypia, hypercellularity, and granulocytic proliferation. Additionally, it's important to exclude other causes of myelofibrosis, MDS, acute leukemia, multiple myeloma, or metastatic disease, hairy cell leukemia, can always be confusing with myelofibrosis. So what is the hallmark of myelofibrosis? It's affect the CBC, so affect the hematopoiesis, mainly through the JAK-STAT pathway. It can cause splenomegaly, mainly driven by the extramedullary hematopoiesis, and myelofibrosis symptoms that is mainly cytokine driven. It does not only carry a risk of leukemia transformation, but also carry a risk of thrombosis, approximately 34%, risk of bleeding, and does have a major impact on patient quality and overall survival. What is the signals involved in myelofibrosis? So we have mainly the JAK-STAT pathway. So we have the JAK1, which is mainly play a major part in inflammation, lymphopoiesis, and stem cell maintenance, which is very important as a mechanism of side effect of the treatments. JAK2 in the inflammation, hematopoiesis. The recently understandable more is the IRAK and the ACVR1, which play an important role in the inflammation, hematopoiesis, and the hepcidin transcription and the erythropoiesis. So how does the disease impact the quality of life? So mainly hematologically driven, anemia symptoms, fatigue, inactivity, or if it is cytokine-related symptoms, night sweats, B symptoms, bone pain, fatigue, weight loss, or splenomegaly causing abdominal discomfort, pushing the stomach, decreased appetite, weight loss, and so on. So cytopenia is a major component of the disease, and it's a major challenge when it comes to the treatment management. As you can see, most of the patients throughout the disease course will develop thrombocytopenia, will develop anemia. If not initially, it is as the disease progresses, the significance of cytopenia will increase. For instance, anemia, almost all patients will experience anemia throughout the disease course. 70% of the patient will develop thrombocytopenia at their disease course. How does it impact or reflect on the outcome? So it does have a major impact in the overall survival. For instance, comparing patients with a platelet of less than 50 to a platelet of more than 100, there is a significant difference in the overall survival. With the median overall survival for a patient of less than 50, approximately is 1.2 years. Similarly, with anemia, if the patient is transfusion dependent or have a hemoglobin level of less than 8, will have a major impact in the overall survival with a median OS of approximately 2.1 years. So it's not only 50, even if the platelet is less than 100, still have a major separation when it comes to the outcome and the overall survival. So cytopenia does not only impact the overall survival, but also affect the cytokine-related symptoms or myelofibrosis overall related symptoms. So patients who are thrombocytopenic, they've reported they have worse fatigue, worse early satiety, abdominal pain, and the list goes on for all the myelofibrosis-related symptoms. So it's also have a general worsening the quality of life for patients. So what are the JAK inhibitors that is currently approved? We have the most experienced agent that we are with is the ruxolitinib, that is a JAK1, JAK2 inhibitor that is approved for the intermediate and high-risk myelofibrosis with platelet count of more than 50. Major side effect we encounter with Jakafi, and it's usually a limiting factor when it comes to continuing the appropriate dose is thrombocytopenia. Fedratinib is the second approved agent in the US FDA. It's approved for intermediate high-risk myelofibrosis with a platelet of more than 50. Major side effect is GI symptoms that led to the black box warning of warning encephalopathy, but that's probably just due to the malnutrition from the GI symptoms. Pacritinib is approved for intermediate or high risk, will have a specific indication for a platelet of less than 50, which comes really in handy when encountering those patient population. The major side effect is GI symptoms that can be managed with antiemetics. Last and the most recent approved is the momelotinib that is approved for intermediate or high risk myelofibrosis patient with anemia. So just following the NCCN guideline, so this is mainly for a patient who are not transplant candidate and we're not intended to take them to transplant. Usually we'll take that route. So we classify them initially based on the platelet count. So if the platelet is more than 50, then you have all the agents to choose from. If the platelets are less than 50, the preferred agent is usually pacritinib. Momelotinib still can be used, however, as category B for those patient population. And ideally, beyond that point, we'll be enrolling patient in clinical trial. So just a clinical overview for pacritinib. Pacritinib is the only approved JAK inhibitor that have a specific label for thrombocytopenia. It's a multi-kinase inhibitor, but the most unique for patients with myelofibrosis is actually it spares the JAK1. Additional to that, it have a high potency against the SVR1, the IRAK1, unlike other JAK inhibitors. So how does it impact? I've showed you this slide, the mechanism of action of the disease. How does it reflect in the pacritinib? So as shown in the far left, it spares the JAK1 inhibitor. So probably it does have a factor on avoiding the suppression on the stem cell. So it provides stem cell maintenance. There is a potent JAK2 inhibitor, IRAK inhibitor, and ACVR1 inhibitor. In addition to controlling the myelofibrosis symptoms and the splenomegaly, it also is a potent hepcidin blocker, so it's allow for more erythropoiesis and increasing the hemoglobin in those patient population. It was studied into two trials. There's the PERSIST-1, PERSIST-2. So I'm going through the PERSIST-2. It's patients enrolled with myelofibrosis who have exposed to previous line of therapy, and they did allow prior JAK1, JAK2 inhibitor. They randomized them into 1:1:1 ratio, pacritinib 400 daily or 200 BID versus best available therapy, including JAK2 inhibitor. So the way the best available therapy enrolled are, so important to note that almost 50% of the patient in the best available therapy are receiving ruxolitinib. Other agents are hydroxyurea, steroids, danazol, thalidomide. Again, very important to note that for those who received best available therapy, 93% of them received a treatment of 10 milligram or less, including some of them 5 milligram or less BID. And we all know it is a challenge with Jakafi because it's a limiting effect in treating them. And when we go to 5 milligram, it's almost placebo at this point. So how did it translate when it comes to the outcome? So they looked at the splenic volume reduction of more than 35%, and indeed pacritinib have a higher percentage, 22 versus 3%, and when looking at the more 50% or more reduction in the total symptom score, similarly pacritinib was superior, 32 versus 14%, and they added additionally the modified treatment symptom score. Additionally, so the difference is most of the other trial, they did not include tiredness, but here they did include tiredness as one of the reported outcome. And again, pacritinib was superior, 35 versus 14%. More important is the impact of the cytopenia. So patients receiving pacritinib had an improvement in the hemoglobin, 25 versus 12%. Similarly, transfusion burden reduced in those patients' population when compared to the best available therapy. So how do we define ruxolitinib failure? First, if the treatment is receiving optimum dose for a duration of 3 months and failed to achieve a response. What are the response we're looking for? More than 20% in the spleen reduction and resolution of the symptoms reported by the patient for more than 20% when you look at the score. Intolerance is probably the most of the patient we encounter is that we'll have unacceptable side effect, toxicity, cytopenia, for which we are unable to give them the optimum dose, or loss of response. Those patients will achieve response, but later on they will have the loss of response to what is defined in the primary refractory. So when looking only on pacritinib versus Jakafi in the PERSIST trial, we still see there is significant improvement both in the splenic volume reduction, 22 versus 3%, and in the modified symptom score, 35 versus 19%, favoring the pacritinib. And again, probably because those who receive ruxolitinib, due to the challenges, they are unable to receive the maximum tolerated dose or the appropriate dose. Most of them receiving a small dose that some of the experts even call it as a placebo dose. So what are the side effect profile? It's fairly very well tolerable disease. The most of the side effects are GI, diarrhea being the most of it. However, it's manageable with antidiarrheal medication. It has a median time of onset of 1 to 2 weeks and usually resolved after a couple of weeks of exposure. Any adverse event reported is 94 versus 93%. Fatal event was 8% versus 11%. It's important to note that here they reported more cardiac adverse event in the pacritinib compared to the ruxolitinib. However, most of those cardiac events were related to peripheral edema. So going into a more understanding of the other mechanism of actions in pacritinib is mainly the ASVR1. So pacritinib and momelotinib are the two unique medication in the armamentarium for myelofibrosis that involve the ACVR, and it does have impact for anemia. When looking at the Cmax, you can see that the pacritinib have a higher level of concentration or higher potency compared to momelotinib when it comes to the ACVR and impact on the anemia. So in conclusion, pacritinib is a JAK1 sparing molecule which addresses the unmet need for a thrombocytopenic patient. It does have a higher potency for inhibition of the ACVR against the other agents. Pacritinib is associated with increase in the red blood cell transfusion independency, and pacritinib inhibition of ACVR provide a strong rationale for its clinical benefit in patients with myelofibrosis who are anemic. Additional studies are needed to further elucidate the mechanism underlying benefit of the inhibition role in the IRAK and the ACVR1 inhibitor. And with that, I would like to thank you and end my presentation.
Thank you, Dr. Omar, so much. Any questions, please? Okay, if we don't we have a question, Dr. Oscar? Okay.
Omar, very nice talk. Question, does JAK2 inhibitors have a role in splenectomized myelofibrosis?
The answer is yes. Spleen is one of the targets for JAK2 inhibitor, but however, JAK2 inhibitor also impact the symptoms. So splenomegaly is mainly driven by the cytokine impact, but also can be a potential extramedullary hematopoiesis site. So removing the spleen, there is still the cytokine impact of the disease everywhere else. So bone pain, impact on the leukocytosis and the fatigue and the night sweats. So the answer is yes. I understand the question because the spleen is usually the major impact, the major barrier, and the major encountered problem with the patient. Thank you very much.
So our next speaker, Dr. Ail Yahya. Dr. Ail Yahya is our colleague in adult hematology and stem cell transplant consultant at King Abdulaziz Medical City, National Guard, Riyadh, with focus on myeloproliferative neoplasm and clinical research. Welcome, Dr. Ail, and please.
Thank you, Dr. Hussam, for your introduction. And again, thank you for the committee for giving this attention for MBN. I think we have more awareness about MBN. I'm too happy, wallah. Anyway, so I think you heard a lot about the MBN. My colleague, Dr. Omar, he reviewed approach, Hernandez, about the transplant and the approaching. So I'm going to take it to the real life. So I'm supposed to share a couple cases with you guys where we're using picatinib. So this is just quick review, one slide. Usually patient with the myelofibrosis coming with significant symptom, fatigue, tiredness, reaching them to the some kind of psychosis and even depression, significant splenomegaly, early satiety, they are weak. Around 1/3 of the myelofibrosis, they presented with anemia. And this is a bad sign. And also like 1/4, they're presenting with thrombocytopenia. And I think this is the main obstacle of the disease. Usually the driver mutation, as we know, all talk about it. The landscape treatment is the option we have as treatment for myelofibrosis. So again, the only curable is the transplant. However, you can see in the Spanish registration that presented just one lecture ago, previous presentation, they have like around 1,600, only 10% they can take them to transplant. Well, this is in the reality. So myelofibrosis patients, they are elderly and some of them, they have comorbidity. So not all of them, they fit for transplant. However, again, any MBN patient in the age that make him eligible for transplant should be assessed by transplant expert and take the chance to discuss with them the option of transplant. So we end up with JAK inhibitors and what we have in the market now, ruxolitinib, fedratinib, picatinib, momelotinib. Don't forget the supportive therapy. Believe me, most of myelofibrosis, they're going to end up to have this supportive therapy, which is either EBO agonist, androgen, lenalidomide, IMID with steroid, the new erythroid stimulator like luspatercept. And we have this emerging therapy coming, which is all my colleagues, they touch base with it. So just one slide about the anemia, the thrombocytopenia. Anemia is a poor prognostic indicator. When the patient reaches to anemic or thrombocytopenia, the survival significantly dropped. So this is my first case. So this is a 73 years old male who diagnosed with primary myelofibrosis, was DIPS intermediate 2, and initially the spleen was around 19. So we start his intermediate 2, symptomatic, and have symptomatic splenomegaly also, plus the B symptoms. So we start him on ruxolitinib. Initially, as usual, just simple case, you start platelets looks fine, hemoglobin looks fine, you start ruxolitinib, the patient responding at the early stage of the disease. Then after a couple of years, you start to struggle with the side effect of the drug or the disease progression. It's not only the drugs, it's not only the side effect. So this patient, he develops severe anemia down the roads, hemoglobin reached to the 59, and we're trying to manipulate the ruxolitinib. At that time, we have only ruxolitinib. We don't have picatinib yet. So we reduce this up to 5, but patient continue to have thrombocytopenia, anemia, and we reach the stage where we cannot use ruxolitinib. We try with the patient lenalidomide, steroid, and unfortunately he didn't tolerate because of the cytopenia, because of the rash, and also the neutropenia. So the patient, then I tried danazol with the patient. So we're lucky we have the danazol. We did the prostate cancer screening, and then we started for like 3-4 months. Is improved a little bit the symptoms, but regarding spleen anemia is not helping. So the patient end up with recurrent transfusion, and barely I can maintain the hemoglobin 7. So I mean, the target of hemoglobin, yes, is better to be like 8, 9, 10, but most of the experts, they're accepting hemoglobin 7. Otherwise, he will receive transfusion weekly. So he ended up with transfusion every 2 weeks just to maintain the hemoglobin around 7. And the platelets remain around 50. So I introduced pacritinib for him. I got approval because of the low platelets. This is the only indication you can org with the committee in your center to have the pacritinib. So we start pacritinib with him, and in symptoms regarding the consistent symptom significantly improved. So that's a win for me. That I can make the patient feeling better, even the spleen not responding. For the anemia, he continued to be transfusion dependent. However, I mean, after like, I believe 12 weeks, we start to notice decreasing in the transfusion dependence. So instead of 2 weeks, now every 3 to 4 weeks. And I think this is another win for this patient because you don't have any other option. And believe me, they are not, I mean, they are not acute leukemia, so I'm not expecting them like either to get them in a remission or they will be die. They have a chronic disease, so they need a good quality of life and they need a good support. So I continued like with the pacritinib, with the data presented. All the assessment was at week 24, which is 6 months. So I pushed the patient to continue in pacritinib. We are the dose usually 200 because of the diarrhea. At some point we decreased to 100. We start noticing patient required more transfusion. His ferritin reaching 4,000 and above, and the disease seemed active. So now even his neutropenic become leukocytosis. So then I decided I have to add something for pacritinib. Yes, pacritinib helping me with the symptom, helping me with the anemia, with the transfusion independence. But however, the patient still in need for further intervention. So I consider luspatercept for this patient. I know luspatercept was not approved yet for myelofibrosis. I mean, we have the phase 2 did show good study. We have independence when they combined ruxolitinib with luspatercept, but was negative. There is ongoing trial. So I try with the pacritinib. I increase the dose pacritinib to 200. I add luspatercept, and within the first dose, with this combination, the hemoglobin maintained around 90, and this is the first time without transfusion. So until now, he completed 4 months. He has just only single transfusion just because of the massive epistaxis. Hemoglobin dropped because of bleeding. Then he maintained hemoglobin around 8, around 9 to 10. And I think this is a success. This is a great success for this patient. What I end up now with very low platelets, around 20, which is okay with the pacritinib. I mean, that's why he's approved. I'm trying to get supply for him for luspatercept. Each time we submit a request, we org with the committee what is the benefits of that. The second one, the second one is 68 years old, male with primary fibrosis. So he was intermediate 1 diagnosed in around 2015. There was no significant conscious symptoms. However, the spleen was enlarged. Ruxolitinib started. Initially, again, then the disease progressed in terms of the spleen and symptoms. And then we end up with progressive anemia and thrombocytopenia. We end up at some point with ruxolitinib 5 and darbepoetin, and usually we know 5 is not working usually for the spleen. However, some patients, they feel a good symptomatic relief for the consistent symptoms, so we keep the patient in 5 despite we know that it's not going to help with the spleen. And then we got a chance to have, I think, pacritinib, and so this patient, she ended up with platelets around 60, 50, hemoglobin 75, and surprisingly, the platelets after pacritinib jumped to 121. Is this pacritinib effect? Is this because we control the disease? All possible. I mean, probably we are controlling the disease now, so we have a good platelets number. The hemoglobin increased by 1 gram. However, the spleen, I mean, it's reduced from like 20 to around 18, which is good for me. with good control of symptoms. The key point, so I have more cases of pacritinib, but I choose these two cases. And all cases of myelofibrosis demonstrate significant extramedullary disease with multiple organ manifestation. Each patient treatment approach must balance combating disease priority and accounting the comorbidity and also the quality of life of the patient. I think treatment sequencing and combination approach is the riddle leading to optimal clinical outcome. And this is, I mean, we are not trying to cure, we are just trying to have a good quality of life, trying to keep the disease in low burden. This is our goal in myelofibrosis. Individualized approach is essential for maintaining clinical efficacy. The myelofibrosis case reveal unique challenge of treatment, resistance, continued transformation, disease progress, just ongoing whatever you do. Regular assessment and flexible therapeutic strategy is gonna improve your outcome. Again, we have clinical practice guideline, but believe me, it just provide you with just a framework. But when you come to the real challenge, to real world challenge, you need a wisdom. You have to be brave. You have to fight for your patient, and believe me, this is gonna take a big effort from you. Our experience demonstrates that trial result often don't fully translate to the clinical practice. And again, the success is depending on the sharing your cases with your colleague and usually sharing the decision. And that's, I think, earlier by 4 minutes. I'm good with that if you're okay. Thank you.
طيب. Thank you very much, Dr. Ail, for the excellent cases. So, because of the time, one question of any. طيب, if there is no question, we'll conclude our first session. Thank you, Dr. Ail, speaker and audience. So we'll allow a break for 5 minutes or 8 minutes. We have 3 minutes more. 8 minutes, then we'll come back. Thank you. 5 minutes, 5 minutes. So only 5 minutes, please.
Outside. Yeah, because you need to sign. Yeah. I will just get your certificate, doctor.
Sure. Thank you.
No problem, doctor. Because if I will not be able to get this for you, I'll have to return it to them because it's
Okay.
cash.
Yes. Okay.
And it will be hard.
16,
It will be hard for us to take
No
it from
problem.
them.
No problem. Thank you. Thank you.
Thank you,
So I'll
doctor.
take it.
Yeah.
And this one.
Yeah.
नहीं भैया कुछ नहीं खाए वगैरह
Maiden. Maiden.
Assalamu alaikum. Good afternoon, everybody. And I'm afraid we have to proceed with the next session. So I'd like to introduce you to the next session. I'm going to be sharing this session with my colleague, Dr. Amal Abdul Wahab. She's a consultant hematologist in King Abdullah city in Mecca. Medical city in Mecca, and this session is going to be quite fruitful and educational, and we have 4 speakers. So without any further ado, I'd like to start with introducing my dear colleague, Dr. Fahad Al-Manjoumi. Dr. Al-Manjoumi is known to the Pediatric Hematology Society. He's a consultant hematologist oncologist with interest in different aspects of hematology oncology, hemostasis, transplant, And today he's going to talk to us about the update on gene therapy, gene editing specifically in treating sickle cell disease and transfusion-dependent thalassemia. So please, Fahad.
بسم الله الرحمن الرحيم السلام عليكم ورحمة الله. Good morning, everybody. Thank you, Dr. Abdullah, for this nice introduction. And I also want to thank Vertex and Biopharma for organizing this satellite symposium. And it's a great pleasure for me to be with you today. So this is my disclosure. So hemoglobinopathies, namely sickle cell disease and beta thalassemia major or transfusion-dependent thalassemia, is considered one of the healthcare burden at the national level and international level. And the current treatment is based mainly on the prevention and treating of complications related to this disease. And the merging of a curative therapy available for all patients is very crucial and very important at this time and should change and revolutionize the treatment for those patients. This is just a basic knowledge about hemoglobin. As you can see in the middle, the normal adult hemoglobin, where we have 2 alpha and 2 beta chain, and we have the heme group containing ion that form hemoglobin. On the left side, you can see that any reduction or defect in the genetic controlling the beta chain or even alpha chain, leading to reduction or absence of the globin production. For example, here will lead to marked reduction or absence of beta globin that will lead to thalassemia major. However, in sickle cell, there is a mutation and defect in beta globin chain that will lead to abnormal hemoglobin that lead to easy polymerization, especially with the deoxygenation, that forming sickle cell and all complications relating to deformed RBCs. As all we know that the infants, they are protected in the first few months of life, and this is related to their high hemoglobin F after birth. And you can see in the graph on the right side that with the time and after a few months, the hemoglobin F will decrease and hemoglobin adult A will increase with the time. And this switching is normal and natural that happen in every newborn. And what we learn from this, that the symptoms appear only after reduction of hemoglobin F and silence of gamma chain that forming the hemoglobin F, which contain alpha and gamma chains. And this is the basic for rationalization of increasing hemoglobin F, again, that will protect the RBCs and increasing hemoglobin F as if he's in the first few days of life. What we have now in the treatment of sickle cell, as you know, is prevention by vaccination, using antibiotics like penicillin to prevent infection, and using medication like hydroxyurea that modify the pathophysiology of sickle cell disease, increasing hemoglobin F that prevent the sickling and complication. And what we have also, we have a symptomatic treatment as usual, patient coming with vaso-occlusive crisis, with anemias, with whatever type of crisis we are treating with blood transfusion, exchange, depending on the situation. And the only curative therapy historically for many decades is hematopoietic stem cell transplant. And with all a study, more than 90% of the patient can achieve long-term survival. And this is excellent outcome. However, the transplant, conventional bone marrow transplant, is not coming without a price. And the price here the risk of GVHD and the risk of graft failure, which can happen in few patients. And the most important, that majority of the patients, they lack the HLA full match family donor. And when you go to other alternative donor, like transplant from unrelated donor, the risk of chronic GVHD is high. And this type of transplant considered only under a clinical trial because of the risk of chronic GVHD. Using haploidentical transplant, maybe it's available for most of the patient, all patient, almost. However, we should know and keep in our mind that especially in patients less than the age of 18 years, the risk of rejection is high. So in Vanderbilt consortium studies, it was around 25%, and it has been also reported by other groups that in children and in young adolescents, the risk of rejection is high. So having said that, and with all what we say about transplant as a curative therapy, if you have available full match donor, which is not available, still we left with considerable number of patients with a chronic disease with severe phenotype, sickle cell, or with transfusion-dependent thalassemia that they need curative therapy, which is not available to them. So CRISPR-Cas9 gene therapy for sickle cell and for thalassemia overcome this limitation, as if it's autogenic nature, it doesn't need donor, and we'll come to that over the time. So this is the basic of the Columbus study in sickle cell disease, 121, and the extended study that mainly looking to the safety and durability of the efficacy from the previous study, 121. And you can see that the study included only patients from age of 12 till the age of 35, and including the severe phenotype of sickle cell disease. And the primary endpoint for the study was the free of vaso-occlusive crisis for at least 12 consecutive months. And the second endpoint was free of hospitalization for the same period. And as you can see here, that almost a quarter of the patients, they were adolescent, the other are adult, and majority, almost 89% of the patient, severe phenotype beta S0, beta SS. And here, the result of this study, as you can see in your left side, the primary endpoint was achieved. 91% of the patient, they were free of vaso-occlusive crisis of at least the first 12 months after the 6 days of infusion. And almost all patients, 98%, achieved the second point, which is free of hospitalization. What is interesting about this study is the durability. As you can see here, that the median duration for free of these symptoms was 3.4 years, and even some patients, they reach 6 years free of these symptoms. And this is very important. The other important point, as you can see in your right side, that this was reproducible across all different groups, adolescent, adult, different genotype of this disease achieved the same rate of 91% free of vaso-occlusive crisis. And maybe most of you are familiar with this slide. You have seen it before a couple of times. But just to simplify, the one on your left side here with a lot of dots, this is the last 2 years before gene therapy. You can see these dots, blue dots, indicating the number of infant vaso-occlusive crisis and hospitalization. And there is one in the middle. This is the preparation period and selecting the patient and infusion of gene editing. And after that, you can see the one in the green, that patient after infusion. And you can see this, what we have mentioned, that 91%, they achieved free vaso-occlusive crisis. What is interesting that in the follow-up study, that almost all patients, 100%, they achieved free of vaso-occlusive crisis and subsequent follow-up, which is something great and excellent outcome and promising and opening the horizon for patients for curative therapy. So here, as we mentioned about the durability of the response and free of hospitalization, same like what mentioned about vaso-occlusive crisis. When we come to the thalassemia, transfusion with the thalassemia is the same schematic and same age group included in this study. However, the end point here is free of transfusion with hemoglobin more than 9 for at least 12 months post-infusion. And you can see here that when we look to the most important is the tissue ionophil load, that considerable number of patients, they have medium serum ferritin is above 1200, and with good medium liver iron concentration around 3.6. This is the same like what we mentioned about sickle cell. You can see here our endpoint here is free of transfusion in the 12 months after the gene editing infusion. And you can see that 95% of the patients achieved the free of transfusion in the first 12 months. And also durability, and 98% with the time in the follow-up, they achieved this endpoint, which is excellent for patients who used to be in transfusion-dependent Q3 to 4 weeks. And this lead to sustained increase in hemoglobin to normal level, as you can see here, around 12, and also hemoglobin F. So here, when we are talking about understanding the risk of benefit of advanced therapy or curative therapy, as we mentioned about bone marrow transplant, here the exa-cel is non-viral autologous cell therapy designed to reactivate fetal hemoglobin production by using the technique of CRISPR-Cas9. And the good thing here, there is no risk of GVHD because it's own cell, and there is no need for donor. So eliminating and open the door for patients who need curative therapy, preventing their chronic organ damage, and yet they don't have the full match donor. Here we didn't need donor. It's the autocell of the patient that can be edited and can be transfused. There is no graft failure reported so far. And the only here thing is using myeloablative like bone marrow transplant. So this is the initial study criteria for selecting the patient. So you can see in the middle that most important is sickle cell disease with at least 2 VOCs events per year during the last 2 years while receiving the appropriate treatment with hydroxyurea and other pain management. And patient should have normal TCD and diagnosis, as we mentioned before, beta SS or beta S0, and selective patient of beta S, beta plus thalassemia. The exclusion criteria is the most important is stroke, history of abnormal TCD, and moyamoya disease not treated, so this patient excluded from the initial trial. And of course, if you have much related donor, patient should go for transplant as standard of care conventional therapy rather than going for gene therapy. And other things were not included. We'll come to that, like immunization and other hemoglobin F level was limited to 15% in this study. Again, some patients with comorbidities related to the lung, to the heart, to the kidneys were excluded from these studies, and patient with active viral infection. For thalassemia included, as we mentioned, the age and patient should be fit enough and eligible for autologous stem cell transplant with good clinical performance. And we should have documented homozygous beta thalassemia doing a genetic testing, not only the hemoglobin electrophoresis. And exclusion criteria, as with sickle cell, patient with available donor should not go for gene therapy. They included only patient who has no available match family donor. And of course, prior hematopoietic stem cell transplant and advanced liver disease. Advanced liver disease was defined as increase in BT time more than 1.5 upper limits and transaminitis. So those are the criteria were restricted in the initial trial. Again, significant comorbidities related to organ dysfunction. Now, when you come to the real world, and this was published by European Hematology Association in combination with the EBMT, Hemoglobinopathies Working Party, how to choose patient for curative therapy. As we mentioned, patient who is defined to have severe phenotype of sickle cell disease, for example, or thalassemia-dependent transfusion, and yet they don't have matched donor and their age above 12, they are candidate to be considered for gene therapy. So what we can observe here, different from what has been published in the initial trial, that here the hemoglobin F increased to 30%. So again, patient with 25% or up to 30%, they are eligible to be included in real treatment world for thalassemias, sickle cell. Of course, there is no family match donor, and the patient should be and family available for annual monitoring and control for at least 15 years, because this is a new approach. So safety of the patient is very important, and those patients need to be followed for at least 15 years after infusion. For the age, still to now, what we have is limited to the age of 12 and above. However, most of you have seen the report that came in ASH last year and showing a promising result and outcome similar to what has been published in pediatric patients. We are waiting for the final approval for this age. Now, same recommendation, patient should have sort of severe phenotype that is not controlled by conventional hydroxyurea maximum dose, not controlled by transfusion. So those patients are candidate to undergo gene therapy if they don't have full match donor. So this indicating the severity of the disease that cannot be controlled with the conventional therapy available now. And patient with recurrent acute chest syndrome despite transfusion, despite hydroxyurea. However, if you look to the comorbidity that we mentioned in the early study, here every patient should be evaluated separately, because not all patients, just because they have some cardiovascular disease or some liver disease, excluded. It depends on the severity. For example, liver disease is common in those patients, but patients with a history of sickle cell-related chronic angiopathy, chronic cholestatic hepatopathy, without hepatic failure, they are still eligible for gene therapy. So those patients need to be selected to prevent further damage to their organ. Similar thing for the kidney. If they have chronic kidney disease started, in fact, those patients should be salvaged early, because if they start to show some renal disease, if you leave them with the time, it will be evident and clear chronic renal disease. So they need to be treated earlier to prevent further damage. Same thing when we say about cardiovascular and for other complication. Also, thrombophilia status patient with VTE, they are not excluded in real world, can be undergo gene therapy. It's not contraindication. They need maybe heparinization, they need anticoagulants that can be managed easily during their transplant. And this is what we are doing even transplant patient with thrombosis, so how to manage them when they are getting severe thrombocytopenia. So I think all hematologists and transplanters, they know how to deal with this complication. Here, some recommendation that some patients, you should not wait until they get all the complications. So we know that some sickle cell disease, yes, the phenotype we mentioned, that they have VOCs despite they are on high dose, maximum dose of hydroxyurea. But also you should put on your mind when you prioritize your patient, those patients either that may have severe phenotype disease. For example, some genetic factor that you can see here on the left side that might indicate that this patient at risk in the future when they get older to get more complication, like that we know beta SS and beta S0. This is the most severe phenotype, and you should give them priority over the other. Patients with low fetal hemoglobin, we know with the time that they don't respond very well to hydroxyurea, and those patients should be given priority. Absence of alpha thalassemia, because there is, with alpha thalassemia, there is decrease in concentration of hemoglobin. So these, it's not validated predictive markers, but they are prognostic that we should keep in our mind all the time. Same thing when we are looking for non-genetic factor, like chronic anemia. And this has been shown for a long time. Patients with persistent chronic anemia, they are prone to get more complication. Now, when we come to comparing the curative therapy between the historical bone marrow transplant and between gene editing, we can see here that in this cartoon, you can see in there that the advantage of the bone marrow transplant is available, and it's established protocol for the last 40 years or more. And it's available, like here in Saudi Arabia, maybe 5 centers, they are doing transplant, so it's available for all patients. And the limitation we know is the donor. So if you don't have donor, a patient still need definitive curative therapy. This is a limitation, the availability of the donor, especially in pediatric and adolescent. On the other hand, the gene therapy, there is age flexibility. It's improve the quality of life. It's not curative for the disease. It's functional cure. And it's gene editing. There is no risk of GVHD and no risk of other complications, but still need myeloablative therapy. The limitation is high upfront cost. So it's not comparable right now when you compare the cost, upfront cost between hematopoietic stem cell transplant and gene therapy. However, if you take the whole process and the long process of the admission and the ER visit and the care for the patient, maybe it's a comparable end of the day. Last thing that we should know, although this is opening the door for and horizon for curative therapy for patients who they need curative therapy but they don't have donor, that what we have so far for gene therapy, especially CRISPR-Cas9, Cas9, is only the complication that we see with regular transplant, because still we are using a myeloablative dose of busulfan that might lead to some complications. Cytopenia is a very common one, but other like VOD that can happen. Having said that, as by all regularity, the gene therapy, either gene editing like what we have now, or gene editing still carries a risk of undesired effect in the target chromosomes. And this should be evaluated and patients should be kept under follow-up. No reported cases of malignancy so far with Cas9. However, there are 2 cases of sickle cell disease. They developed MDS using the lentivirus from the other, which is different than this technique, because that one is gene editing. And there was one case of AML, maybe it's not related directly to gene editing, maybe related to conditioning therapy. So overall, although the recent target gene editing and gene addition for sickle cell have produced encouraging results, these therapies still face many challenges. Long-term follow-up is needed to assess efficacy and safety. I think by this I will conclude. Thank you all for your listening.
Thank you very much. Nice presentation and informative update. I think because of the time, we have time for one question. Not you. I'm sorry. Somebody else. If you are the only one, go ahead.
خلاص في حد معترض؟ شوف
طيب go ahead. It looks like you're the star today. Okay.
والله بص انا هتكلم عربي بقى علشان هو احرجني كويس.
ما خليت احد يسال يا سعيد.
بلاش مش هزق.
لا 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 والله تسال.
When CRISPR is 2 million. تمام. When center supply of hydroxyurea for a year is 500,000. There is a time lag effect over here. We are very happy that we have a new procedure for curing patients, quote unquote curing patients with sickle cell disease. But being physicians and big institutions, I think we have to have another societal role, which is directing money and finances of the whole country towards the best of the society and the targeted populations of sickle cell disease. By the time you will see CRISPR going into each house or at each shop, in each hospital, you will have at least thousands of people dying before they reach to the CRISPR. How can we catch with this? احنا كأطباء مطلوب مننا يكون عندنا دور اجتماعي او مجتمعي اعلى من اننا نبقى قاعدين في المراكز بتاعتنا في البيج تاور بنقول يا قاعدين يكفيكوا شر الجايين. احنا عاوزين نخرج الناس. عايزين نحل مشاكل السيكل سيل ديزيز patients in the south. 31,000 patients in the south, at least 1,000 per year are dying without CRISPR. In the east, you have more than 40,000. The same thing. يعني احنا محتاجين نخرج شوية من يكون عندنا مؤتمر وعندنا مؤسسة وعندنا مستشفى وعندنا وحدة بتعمل كريسبر ل5 عيانين في السنة. يا فرحتي. It doesn't work. عشان كده بقول يا جماعة ده دور SSBMT دلوقتي. السوسايتيز كلها محتاجة تتضافر وتتعاون من أجل إنتاج منتج حقيقي لهذا المجتمع الكبير اللي احنا هنعمل له ديليفري زي KFC وماكدونالد. بيعملوا هوم ديليفري للاكل، الناس اللي يقدروا يجوا اصلا عشان ياكلوا. احنا محتاجين نعمل ديليفري للسيرفيس بتاعتنا، الناس اللي ما يقدروش يجوا لنا مش فاهمين يعني ايه sickle cell disease that can cause death. That's it.
Message is clear. Yeah. Okay. Briefly, Fahad, please. Yeah. Yeah, please. You want to answer?
The answer, I totally agree.
He answered himself. I think that's it. Thank you. هو جاوب خلاص. شكرا. Next speaker.
Our next speaker is Dr. Hind Salama. She's a consultant adult hematology at King Abdulaziz Medical City, Riyadh. She's an assistant professor at King Saud bin Abdulaziz University. She has a special interest in ALL and histocytic disease. She initiated the first adult histocytic clinic in the region. We're proud of you, Hind. So, floor is yours, please.
Assalamu alaikum. Thank you, the SSBMT, for inviting me, and thank you, Dr. Amal, for this introduction. And let's warm the conference room a little bit. So, I'm going to, my session today will be 2 parts. The first part is brief about HLH, and the second part is ICHS, which is HLH-like syndrome secondary to CAR-T. So what's HLH? HLH is a severe syndrome of hyperinflammation driven by massive overexpression of interferon gamma, result in blood cells engulfing other blood cells, like what you see here in the smear. So to understand the mechanism of HLH, you need to know the normal immune system. So in the picture, in the slide here, on your left side, this is the immune system. So when a body is exposed to a trigger, for example, a virus, your immune system will activate the CD8 T cell, and it will release interleukins and cytokines and interferon gamma, and then there will be a negative feedback in red to terminate this immune system and get rid of the organism. But if you have a defective in the enzymes that encode for the cytotoxic T cell, like deficiency in perforin, like in primary HLH and other enzymes, then this negative feedback will not occur, and there will be a hyperstimulation, a storm, increased interferon gamma, activation of macrophage, engulfment of the cells, and this is the whole pathogenesis of HLH. So what are the causes of HLH? We have primary HLH and we have secondary HLH. So primary HLH is mainly because of immune deficiency syndromes or defect in those, or mutations that lead to defect in cytotoxic T cell, as listed here. But I'm an adult physician, so primary is not our main concern. We see it rarely. So our main concern is in adult is the secondary HLH. And the most common cause of secondary HLH in adult is malignancy HLH, and mainly lymphomas, and mainly T-cell lymphoma and NK cell lymphoma. So in adult, whenever an older patient presents with HLH, we need to search meticulously for an underlying malignancy. The second cause is infection. Any infection can cause HLH, but the most common is the EBV, the CMV, and any other infection. So, and there is an HLH secondary to autoimmune disease, and this is referred to as MAS, macrophage activating syndrome, but it's the same as HLH and management is the same. And now recently, people started to recognize a new syndrome, immune effector cell, HLH-like, which is secondary to CAR T cell. And if you did not find the cause, this is idiopathic HLH. So we as adults, we get many consultations. Come and see this patient. We think this is HLH, ferritin is high. But we know that in adults, it's not like in children. Ferritin can be high for many other inflammatory or other reasons. So we cannot accept any consultation as HLH just because the ferritin is high. So most of the experts use the 3 F terms. The first F is the falling count, means unexplained cytopenia, and persistent fever without a positive culture or a real a cause. And the last one is high serum ferritin. So if you found these 3 together, then think of HLH, and you need to apply your scoring system to diagnose HLH. So this is the HLH 2004 diagnostic criteria, and I'm sure most of us are aware of. It's either a primary disease or one of the genetic defects that we mentioned, or 5 out of 8 of these criteria. But in 2024, Hunter and his colleague, Hunter is the one who created the HLH 94 protocol and the HLH 2004. He recognized that HLH 2004 works with an accuracy of 99% without the NK cell function. Most of us, we don't do the NK function, but still we diagnose HLH. So they removed the NK cell function from the HLH 2004, and they name it HLH 2024, where you need only 5 out of 7 criteria. But if you look at the ferritin here in this diagnostic criteria, they use a cutoff of more than 500. 500 is not applicable for us in adult. It's not an indicator of an underlying HLH because we have 500 for many other reasons. Even if the patient has a fever for a flu or anything, it could be 500. So this HLH 2024 or 2004 is suitable for children with primary HLH. It's not applicable for adult patients with secondary HLH. So the French group came with the H score, which is a score that took into consideration the ferritin level. So if you have a ferritin, for example, of less than 2,000, it was given a 0 mark. So you need a ferritin of 2,000 or more to consider HLH or to consider it positive mark. So they give grades to each parameter. They consider also the underlying immunosuppressive. They gave it also marks. And then this is an easy calculator available online. Then they will, you have the probability if the scoring system is 169 or above, this is positive score. And if it is 250 or more, then you have a 99% probability of having HLH. The beauty about that is all the parameters here are usually available when you see the patient, and the calculator is ready online. You can use it and calculate. And then you can sign off of the case or in. Recently, there is a context-specific HLH scoring system. So this is Lorenz Zorev came with this scoring system for lymphoma patients. So when she looked at the HLH 2004 diagnostic criteria, she found that for a lymphoma patient, the only two sensitive criteria are the soluble CD25 and the ferritin. So if you have a normal soluble CD25, which is interleukin-2 receptor, and the normal ferritin, then, and the patient had HLH, then very, very unlikely that this patient will have an underlying lymphoma. But if the soluble CD25 is more than 3,900 and the ferritin is more than 1,000, this is a positive OHI index, and it's highly suggestive of underlying lymphoma. Not only that, it also correlates with the survival of the patient with lymphoma. So patients with positive OHI index, they do worse than the other patients. So whatever scoring system you use, and also there is a context-specific scoring system for mass used by rheumatology. Whatever scoring system you use, the most important thing is to diagnose your patient quickly, because here time means money or life. So for the management of HLH, I usually say 2 steps. 2 steps go together head by head. So the first step, keep your patient alive. Please, till you know the underlying cause, and treat your patient. Keep your patient alive means suppress the cytokine, suppress the inflammation, so the patient will not end into multi-organ failure, and then you lose the time. So how to keep him alive? Most of us are concerned about steroid, will mask my lymphoma, will mask my sepsis. Don't worry about that. The most important is to keep your patient alive. Unless if you have a biochemical markers of HLH and the patient is stable, then you can search for the lymphoma and do the diagnosis. But keep him alive using steroids. Don't be afraid of steroid. Use anakinra. Use anakinra. Anakinra does not mask the underlying lymphoma. It's available everywhere. It's cheap. It does not worsen the sepsis. Also, if you have the facility to have imapilumab and patient did not respond to first line, don't hesitate to use it to suppress the inflammation. While you are doing the first step, you do the second step. Search meticulously for the underlying cause, okay? So do all the investigations, and of course it will be obvious if the patient is post-CAR T, you don't need to do much of work. Now, how to manage the patient, to manage the underlying cause, the HLH94, everybody is aware about it. But again, this one was mainly for pediatric patients with primary HLH. Adult patients do not tolerate these large doses of etoposide twice per week and prolonged steroid. If you have to use it, and when you use it if you have a severe inflammation and you don't have an access to, that does not improve with steroid and with anakinra, and you don't have an access to imapilumab, for example, or you are suspecting an underlying malignancy or in EBV, HLH, because usually it's severe, then you can use it, but you use lower dose, 50 to 100 milligram, once per week instead of twice per week, so some modification. Now, imapilumab is a humanized monoclonal antibody, FDA approved for primary HLH and for macrophage activating syndrome last year. And real-world data showed some benefit in malignancy-associated HLH and in other secondary causes. What are other medications? Anakinra, I talked about it already. It's an anti-interleukin-1 receptor, frequently used in mass, but can be used in any HLH, secondary HLH. Ruxolitinib recently started to be used also because of the role of STAT activation in HLH. Alemtuzumab only in refractory cases and in conditioning chemo for transplant. Tocilizumab has very limited role in HLH beyond the CRS secondary to CAR-Ts and bispecific. Zanubrutinib, this is in ASH 2024. This is very interesting because this is an oral medication, and here they check zanubrutinib in patients with secondary HLH. The majority of them were macrophage activating syndrome, and 50% of the patient had achieved remission, and this is very interesting because those are relapsed refractory. We usually lose those patients, and there is normalization of the cytokines in those patients also. This is a promising medication. This is a trial from MD Anderson, the ELA-026. The importance of this is that it had signal regulatory protein alpha and beta 1 and gamma, so it blocks several signal regulatory proteins, not only one. And they tried this medication in malignancy-associated HLH, and they reported 100% response rate and improvement in 2 months survival, but this is only 2 months, and I didn't see any follow-up data about this medication may be next ASH. So my conclusion from this part is that over the last decade, our understanding of HLH biology and management have advanced considerably. If the patient has the 3 Fs criteria, apply the proper scoring system to diagnose HLH. Bone marrow is not diagnostic of HLH. So the presence of bone marrow biopsy with hemophagocytosis or no hemophagocytosis, this is just one parameter in the scoring system. It's not diagnostic, it's not exclusive. Once diagnosed, a 2-step management strategy should be applied instantly, and HLH-94 does not fit all patients, so you should modify your treatment based on the underlying cause, and it's time to use more effective and less toxic agents. So the second part of the talk is, since this is an EBMT meeting, is about immune effector cell-associated hemophagocytosis-like syndrome, IEC-HS. So this is Melissa Hines. She's an pediatric intensivist who is interested in HLH. So together with her colleague from the American Society of Stem Cell Transplant and Cellular Therapy, they published this nice guidelines about diagnosis and management of IEC-HS in 2023, actually. So they defined the IEC-HS as manifestations with features of MAS or HLH attributed to immune effector cell therapy associated with progression or new onset of cytopenia, high ferritin, coagulopathy, and or transaminitis, and how to differentiate it, delay in onset and manifestation as CRS is resolved or resolving. So in the next slide, we'll see, so the conditions required, again, hyperferritinemia, and Melissa used 2 or more times upper limit of normal. And many adult HLH physicians criticize this because, again, she's a pediatrician, so the 2 or more of upper limit of normal is nothing for adult. So most of the adult HLH experts use 7,500 or more to make it like a sensitive marker of IEC-HS. And then the other important issue is the timing of onset. So usually it's after the resolution of the CRS, because it mimics CRS, so we need to differentiate between CRS and IEC-HS. So it's usually after the resolution of CRS, and you can have transaminitis, new worsening cytopenias, hypofibrinogenemia, also bone marrow hemophagocytosis, although not necessarily to do a bone marrow, and other manifestations like high LDH, coagulopathy, and organ failure. Also, the timing differs, depend on the type of CAR-T you are using. So if you are using the CD19 CAR-T, it could occur simultaneously with the CRS, and this will be confusing, but it's how, when you are giving treatment for the CRS, and then the patient initially improving, and then he lost the improvement, then think of IEC-HS as a cause, change your management to the management directed towards IEC-HS rather than TOSI for CRS. But for the BCMA CAR-Ts and the CD22 CAR-Ts, usually after the resolution completely of CRS, 2 or 4 weeks, then it will occur. So it's easy to differentiate. So there is a grading system. I will not go through that. You will find it in their published articles. The grading varies from 1 asymptomatic to 5 deaths. What's the incidence of IEC-HS? Actually, the incidence varies in many reports because some of the reporters reported only severe cases and some reported mild cases. This is in Hines' publication. She put this incident from a real world, but also the incident varies based on the type of CAR-T. For the CD22 CAR-T and the BCMA CAR-T, they can reach up to 30%, and for the CD19, it's up to 3% or 6% in the maximum. People look also at the outcome of IEC-HS based on disease. So for example, those are children with B-cell ALL, and they look at patients who develop IEC-HS, post-CAR-T, and patients who did not develop. So as you see, the overall survival and relapse-free survival are worse in patients who develop IEC-HS, mainly because of the non-relapse mortality. Also, this is a real-world data, looking at BCMA CARs following ide-cel and cilta-cel in patients who develop IEC-HS. And this is a multi-center trial from all through USA. They look at progression-free survival based on the development of IEC-HS. And they found that patients who receive ide-cel or cilta-cel, if they develop ICHS in the dotted graph, they have worse outcome regarding the progression-free survival and overall survival than patients who did not develop ICHS. And they found also in this publication that the predisposing factors for developing this complication are high baseline ferritin. So if the patient from the start has high ferritin, this is a risk for ICHS. If the patient is pentarefractory, myeloma pentarefractory, and if the patient has high plasma cell burden in bone marrow. This is nice, and we need to look at this in other disease subcategories other than myeloma. Now, why some people develop ICHS and some people do not? We know that high ferritin, high disease burden, these are indicator, but is there any other factors? So this is a study from Boston. They look at patients in the ZUMA-1 trial. They look at 110 patients actually, and they look at those who develop ICHS, and they look at this expression of STAT2, and they found that patients who had ICHS had high upregulation of STAT2, while patients who did not develop the, I will say HS, they did not have any STAT upregulation. Moreover, there is more upregulation of interferon gamma, interferon alpha in those patients. So baseline high interferon gamma and high STAT2 will make those patients at risk of developing ICHS. We know this is primary HLH, and there are many genes encoded. So is there any genetic role of genetic mutation in ICHS? So there are two studies. The first study, both of them were presented in ASH, one in ASH 2022 and one in ASH 2025. So the first study, they look at 5 out of 9 patients who develop ICHS, and they found that they, post-CD22 CAR-T, they found that they have STXBP2, and we know that this is a very important gene in primary HLH. And a group from MD Anderson also looked at 11 patients with ICHS after CD19 CAR-T, and they identified 9 genes, including UNC13D and STXBP2. That means even if the patient does not have primary HLH as a cause of bone marrow transplant, the patients who develop ICHS, some of them have this genetic predisposition to HLH. So this will raise a question whether we need to screen those patients before CAR-T or no for primary HLH. So now for the treatment. For the treatment, Heinz, she recommended for the first line to start anakinra first, and if the patient did not improve, to add steroid. For the second line, to increase the dose of anakinra and add cortisone, if not yet added, and consider ruxolitinib. For the third line, if all this did not work, she recommended to add imapilumab. And each line, when you move from each line to other line, you need to, again, search for the other etiology. But this How I Treat article was published just last March in 2026. It's more informative, actually, and more detailed than the Melissa's guidelines. Here, in grade 1, they advise not to give anything, just observe the patient, and there was a debate whether to observe the patient outpatient or inpatient, but the majority chose inpatient because patient can rapidly, from grade 1, go to grade 2. In grade 2, they advise to give anakinra first, and they put the doses for anakinra, and steroids if anakinra did not work, and you can add, and generally it's not added ruxo and imapilumab, not for grade 2, but for grade 3 and 4, optimize the doses of the anakinra and steroid, add imapilumab, different dose for grade 3 than grade 4, and add etoposide if you do not have imapilumab and ruxolitinib in your center. So I think for every center that will do CAR-T, we need to have ruxolitinib and imapilumab available in-house if you are doing CAR-T in case you develop this complication, especially if you are doing the BCMA CAR-T, which has a 30% risk of ICHS. For the monitoring, this was based on expert opinion. This is a monitoring, and I think most of us will do this monitor, except we don't test for the CXCL9 because unfortunately we don't have it in Saudi Arabia. However, there are efforts now to get this test done. And the nice thing about, in the same article of how I treat, I advise every person who deal with CAR-T to go and read this article. They put a taper strategy. For us in HLH management, we seldomly see taper strategy. We don't know when to stop, whether to stop suddenly, whether to taper, but most of them, they advise to taper gradually, okay? So the first thing to taper is steroids and anakinra. Once the patient improves, 7 days, after 7 days, start tapering it, and they put how to reduce it every 24 to 48 hours. Prioritize
5 minutes.
Yeah, this is my last slide. Prioritize weaning steroids before anakinra, especially in patients with poorly controlled diabetes or older patients who are at risk of hospital-acquired delirium. However, if the patient had previous ICANS, steroid and anakinra should be tapered very gradually. Ruxolitinib taper it more gradually. Start once organ function improve and reduce by 2.5 to 5 milligram every 24 hours. They did not talk about the taper of imapilumab, I think because still the experience is developing. They don't know when exactly. So my conclusion from this part, Heinz's recommendation, they were very excellent, but they have some limitations. First, it was based on expert opinion. Second, despite she put the cutoff, the time as a, still you cannot differentiate between CRS and ICHS except by timing, especially in the CD19 CAR-T, which is overlap. So we need more definition maybe in the future. Each CAR-T center should create their own management guidelines based on the available facilities. So if you have, if you don't have imapilumab, ruxolitinib, you need to put etoposide if you could not control it, if you have it like that. So each center should develop their own management guidelines. Consider testing patients for germline mutation associated with primary HLH before CAR-T, because as you see, many of the patients who developed this complication had germline mutation. Monitor closely patients with baseline high ferritin and high burden disease, because also those who are at risk. For severe cases, use imapilumab and ruxolitinib as suggested in the two published articles. And do we need prophylaxis for those who had high disease burden and those with high ferritin? This is a question to be answered in the future. And with that, I conclude. Thank you so much.
Thank you so much for comprehensive review. Any question? Dr. Hind, can I ask you, how can we differentiate HLH occur with CAR-T from CRS, and how do you manage this?
This was mentioned in the last part of, in the second part of my talk. You differentiate actually by the criteria, definition criteria that is put high ferritin, they put certain level and they put the timing. So the timing is the most important thing to differentiate. So usually it occurs after the resolution of CRS, many weeks or overlapping when you improve, when the CRS improve with TOSI, and then the patient lose the response suddenly, you need to look for ICHS and high LDH and other features they put it.
Okay, thank you. So now we are moving into the next speaker. Our next speaker is Dr. Ellen Javerki. She is specialized at Hematology Department, BMT unit of Papinucula Hospital. Her clinical and translational research focus on complement-related disease with special interest in thrombotic microangiopathy. So welcome, Dr. Ellen. Floor is yours.
Thank you very much. I hope you can hear me well. Please let me know if there are any troubles. I'm very happy and excited to be among you today, and I will present data on transplant-associated thrombotic microangiopathy, or TATMA. I have tried to summarize all our current questions in the field, and I will try to provide highlights from the very interesting educational session that we had during the EBMT conference. These are my disclosures. So the basic questions that we are going to try to answer are why TATMA occurs after HCD, how we diagnose it nowadays, how we try to stratify severity, and potentially how do we assess response. And we are going to start with a case that in our experience typical of TA-TMA. So it's a 30-year-old male patient, almost 1 year post-haploidentical HCT, that remains under long-term immunosuppression due to extensive steroid refractory GVHD, and unfortunately presents suddenly with neurological symptoms like an apheretic crisis, thrombocytopenia, and evidence of macroangiopathic hemolytic anemia with hemoglobin of 7.8, increased LDH, and schistocytes in the peripheral blood smear. So this has a difficult differential diagnosis post-transplant, but I will try to persuade you that this patient really suffers from TA-TMA and may benefit from complement inhibitors as a new treatment in this field. So, what do we know about TA-TMA? We currently recognize 3 phases in the syndrome: the initiating phase, the phase of progression, and then the phase of microthrombosis. Unfortunately, we do not have any tools to observe this into our patients. And this syndrome is also recognized as an endothelial injury syndrome because everything happens within the vessels of our patients. And endothelial injury, as we know, is a cornerstone of pathophysiological symptoms in graft versus host disease, but also other life-threatening syndromes post-HCT. However, I will try to summarize the recent knowledge in transplant-associated TMA that has gained a lot of interest. Because we recognize that TA-TMA may have some similar features with other complement-mediated TMAs. We recognize that there are pre-HCT risk factors like older age, prior HCT, some patients that have predisposing complement gene variants that, however, cannot be detected in clinical practice but have been found in some research papers. We have HCT factors, the mismatched donor conditioning regimen toxicity, and then post-HCT factors that together with the predisposal to complement activation may lead to this extreme phenotype. And to dive more into the endothelium and complement, which have a continuous interaction, we have data that we have increased soluble C5b9 as a marker of terminal complement activation, and this may be even more in the urine of our patients, although we rarely study this marker in the urine. We have shown some patients may have increased complement activation that happens with on the cell surface with an assay that is again unfortunately not available in clinical practice. There are some studies showing alternative pathway dysregulation, lectin pathway dysregulation, this genetic susceptibility, but also we know that this is multifactorial and there is this vicious cycle of inflammation, increased neutrophil extracellular traps, and interferon signaling, and together with oxidative stress and lipid dysregulation, we have this cycle of microangiopathy. So this is the 3-hit hypothesis as we have already developed it, and this highlights that we do not need only one weapon in this patient. We need to face the whole pathophysiology and especially infections and GVHD. We have to treat them simultaneously with any other treatment for TMA. Now, how do we currently diagnose? There has been a lot of discussion for these harmonization criteria. In my opinion, this is a very important effort to try to move this field forward with all the limitations. And importantly, these criteria have also unified pediatric and adult population. Of course, the criteria need to be adapted and according to our clinical knowledge and also to our personalized approach to our patients. But I think these criteria can be a very useful tool for clinicians. So to summarize, our patient needs at least to have 4 of the 7 criteria. Anemia, and in the criteria there are some suggestions on how to define that this anemia is relevant to causes in these patients: thrombocytopenia with a similar notion, elevated LDH, particularly an increase in LDH, the presence of histiocytes, hypertension, and proteinuria. I find them very important features that we neglected sometimes in the past, and these may be early signs of renal damage. And elevated soluble C5b9, this is in the plasma, but at least any complement biomarker may be important. And more than that, these criteria have tried to establish high-risk TMA patients because, of course, not all patients need specific targeted treatment, but high-risk patients are those that really need this treatment. And these high-risk criteria, we rarely find only one, are specified as more than double LDH, more than 1 milligram per milligram proteinuria, any organ dysfunction, which is here also specified with specific manifestations, the elevated soluble C5b9, the presence of GVHD, and here I will try to persuade you that not only acute GVHD but also chronic GVHD may be important, and the presence of systemic severe infection. So there is a lot of discussion about complement biomarkers. They do not have 100% specificity and sensitivity, but I think we have to try to incorporate them in our clinical practice. This can be incorporated especially by the pediatric criteria by the Cincinnati group from Sonata Jotel, and also added in the recent harmonized criteria. We don't have many data, and we have to take into account really increased values. So here, for example, this table summarizes studies that have used this biomarker. In our study, we have found that the level of C5b9 that differentiates TA-TMA from GVHD is increased compared to the level that we use as a cutoff for normal. So we need to have soluble C5b9 as a nanogram per ml, and this is easy to get by a commercially available ELISA assay. And we need to take into account values that are really increased. I would say roughly above 500. And these values are really indicative of systemic complement activation. And I think this is also relevant to the literature, and we hope that we will have more data about all that when we have the data from the randomized clinical trial that has been performed in the adult population, and many centers have been participating. Our experience on the incidents has been really stable, I would say, and maybe relevant to the literature before and maybe also after this experience. We have found TA-TMA, and this was with the criteria before the harmonization, 15% of our patients. And I want to highlight that in our experience in the adult population, this is not only an acute complications. We have found it many days post-transplant, many years post-transplant. And this also is in line with other studies, we have to take into account that many studies stop screening for TA-TMA, or some centers stop screening for TA-TMA, and they do not screen patients years after transplant. And of course, we have to take into account that late TMA is more likely have also concurrent chronic GVHD. So these patients need continued screening, and this is highlighted in these two very nice more recent studies. We also have additional risk factors, as we know, other infections that may be triggers of TA-TMA in these patients. And this is one unpublished schema based on the criteria, where we try to highlight what we need for screening of our patients and how we can continue screening after the first year. So, how can we implement severity scoring into clinical practice? I think this really needs a learning curve, and we have known negative predictors of survival. We have to take into account all GI manifestations that have been negatively correlated with survival. This is one of our articles showing actually that patients with intestinal TMA, based on certain criteria for pathologies, have very bad survival without complement inhibitors, and patients with neurological dysfunction, like the patient I presented to you in the beginning, also have a very negative outcome without complement inhibitors. Now we are talking about complement inhibitors, and I will not really dive into this field. I think we certainly need to learn more, but we also need to learn more on how to assess response in our patients so that we can implement all these new tools. And that is why we have established this new consensus document for response criteria. And of course, there are limitations always in these consensus documents, because we do not really have enough data for all decisions that we make in this document. But we have tried to establish it as a mirror of the diagnostic criteria, focusing again on response of anemia, thrombocytopenia, hemolysis, complement activation, and of target organ damage. I encourage all of you to read these consensus documents and maybe try to adapt them to your clinical practice. So, the main message for this response criteria is that our aim is to have a clinically meaningful partial response. So this third line here, this third column, because we cannot always achieve complete response, and this was not really our aim for our patients. So clinically meaningful partial response for anemia, for thrombocytopenia, and this is something that we have tried also to set some diagnostic criteria here. And histocytes, LDH, and soluble C5b9, we have defined some percentage of decreases for this value. So when to assess response is also very important. We believe at least at 3 to 6 months, but we have to take very careful follow-up of our patients. Again, we aim to partial response in anemia, thrombocytopenia, soluble C5b9, and histocytes. And we have also defined the organ response according to acute renal injury, proteinuria, hypertension, which is also again something that I want to highlight, and the number of antihypertensive drugs may be very important, both in adults and in children. Pulmonary arterial hypertension, pulmonary insufficiency, and serositis have been also defined, and we again want to achieve partial response. I want really that to be one of the main messages in the biochemical, but also organ response, and then the overall response. So to conclude, and maybe we can have some time for questions, my ABCDE of TA-TMA, we believe that there is a vicious cycle of endothelium and complement, and we have somehow to stop this vicious cycle. We have always to be alert after transplant. We may need complement biomarkers, and we have tried a lot to improve ourselves in this field, but it's difficult to have them in the diagnostic lab. We need to define severity because not everyone needs specific treatment, but we need to start specific treatment as early as possible. And also we need to evaluate response with every tool that we have and standardize criteria. So thank you very much. I'm very happy to answer to questions now, but also to contact and may potentially also have some collaboration in this rare field that has gained a lot of attention, and potentially we have gained a lot of positive outcomes for our patients. Thank you very much.
Thank you for the comprehensive presentation. So we'll take questions. Yes.
Thank you so much for extensive talk. It was very informative. The question comes to Dr. Eleni is that the timings of TMA sometimes is very confused with GVHD. So here you have these non-specific marker like LDH and other inflammatory markers goes high with the GVHD as well. So when do you suggest to introduce treatment? And even introducing the treatment is very challenging sometimes because you're questioning, shall we push the eculizumab or ravulizumab or some medication? Then what's the best timings in terms to push the button for the medications as well? Thank you.
Thank you very much. I think, and I want to emphasize on that, that you're totally right. And many patients, especially our adult patients, have this GVHD course that may get worse. And then on top of that, they will have the TMA. So I think this is why we need to have close monitoring for those patients and very specifically assess the increase of LDH, for example, or the decrease of platelets that, or anemia that these patients might have. In addition, I think that hypertension, proteinuria, and potentially C5b9 and some organ involvement that has been described in the criteria may be more specific for these patients. And if these patients have these definitions, have anything of that, I would highly suggest to consider specific treatment on top of the intensification of GVHD treatment or treatment of infection. So I think we have to treat everything together and try to start a specific treatment as early as possible. For example, in the patient that I presented to you, we did all the differential diagnoses, treated for potential infections, for CNS infections, but also started with pegcetacoplan in the clinical trial, the phase 2 clinical trial that will be announced, and the patient exited the ICU in 2 days and went really well after that. So I think we have to actually use all our weapons and then try to make a better diagnosis over the days.
Thank you, Dr. Eleni. I have a question. Transplant-associated TMA is becoming a challenging problem, especially in the setup of if you have, coinciding or it's overlapping with severe GVHD, for example, of the gut, for example, and you have some hemorrhagic manifestation. And it's really becoming a challenge, especially if you can't get the C5b9, resulted in a reasonable time. So I wonder, this becoming a really repeated scenario, what would be your approach if you have both like severe GVHD and suspected TMA?
Yes, I think that addition of any drug that we have available of complement inhibitors would potentially benefit these patients, although we still we need to learn more about these drugs, the dosing, and all these questions that we didn't have a lot of time to discuss. I would use any drug that would be available to me. For example, nowadays in Greece, we have ravulizumab available for these patients, and although it is not FDA or EMA approved, we use it off-label in these patients. And again, the data show that if we give it as early as possible, it may benefit these patients. We have to, regarding these drugs, we have to take attention to meningococcal infections. We have to vaccinate all our patients, although we know that may not generate antibodies, and we have to keep them under long-term prophylaxis. But with the knowledge that we have right now, we may be able to give the drug for 6 months and then stop the drug if we have a clinical meaningful partial response. And we have patients that we had a relapse of the TMA after, for example, 1 or 2 years, and these patients again responded to the drug. The scenario of intestinal involvement, I think, is one of the worst scenarios in these cases, and we have to use all our weapons together with every GVHD treatment that we have available in a personalized manner for our patient.
If there are no other questions, I think we will proceed with our next speaker.
Thank you.
Thank you very much, Dr. Aline. Our next speaker is Dr. Salim Gorbakjoglu, who's well known in the field of pediatric hematology oncology. Dr. Salim Gorbakjoglu is a professor of pediatrics and chair of Department of Hematology Oncology and Stem Cell Transplantation in Children's Hospital of Regensburg. His interest in stem cell transplant and the haplo transplant field and the T-cell depletion, and in the field of hemoglobinopathy and in gene therapy in particular is well known. And we're glad to have him today to enlighten us about updates on hemoglobinopathy. So Dr. Salim, welcome to our conference.
Thank you so much, Abdullah. It's nice to hear your voice. Unfortunately, I'm not here present in person. Can you hear me? Can you hear me? Can you hear me also? Wait a second.
Yes, doctor.
You can hear me. Okay. So, well, then let's get started. These are my disclosures. And when you look at the map of sickle cell disease, you can clearly see that the majority of patients do not reside, of course, in Europe. We have approximately 4,000 plus patients. Plus means that many of the sickle cell patients in particular are not seen by hematologists for a long period of time, but rather by general practitioners who deal with, the pain crises and all the other issues, which is, I think, a huge deficit in our country. How about thalassemia? Again, the situation is very similar. We have approximately 400 plus patients in Germany, and as we all know, the majority of patients are in, the Mediterranean strip from, western part of Spain all the way down to Indonesia and Southeast Asia. And I think now you can stop laughing because Mohsen was kind enough to provide me your data with more than 80,000 patients that are affected, and you say 10,000 patients need a transplant. I think rather that most of the other patients need a transplant as well. And in order to addresses this very particular prevalence in your country, I'll try to answer the following questions. Number one is, should we offer a curative option to every patient with hemoglobinopathies? Number two is, should we consider a hemoglobinopathy a non-malignant disease? A very tricky and mean question. Can we offer a curative approach to every hemoglobinopathy patient? Number four is, are transplantation or gene therapy competitive treatment options? Number five is, are haploidentical transplantations a feasible alternative to a matched sibling donor or MUT transplantation? And last but not least, when should we offer a curative approach? Well, first question. When we look at the survival curves of sickle cell disease, starting in the 1970s of the last century, we see that the overall survival curve is significantly improving in these patients. But we are basically back to square one in the 90s, where we had supportive care, transfusion, and chelation, as well as hydroxyurea as the only treatment options, because the most encouraging drugs, crisanelucinumab and voxelotor, basically died on 2024 and 2023 due to inefficacy and unexpected high adverse effects. And overall, even applying best supportive care for these patients, the overall survival in African American in the United States, where you have really comparable experience with a high prevalence, very much like in Saudi Arabia, the overall survival of these patients is significantly worse by more than 20 years, and I'm not talking about quality of life. What about thalassemia? Milestones on the right-hand side, starting with transfusions in the 1960s, all the way down to the Farazirox in 2003, and the Kaplan-Meier curve on the left-hand side does not reflect the impact of luspatercept yet, but nevertheless, data by Fournier et al. In 2022 show clearly that over the last 20 years, again, the overall survival of these patients has not improved. So there's a significant unmet need for a curative approach. Now, the tricky question, should hemoglobinopathies be considered non-malignant diseases? Well, if you ask a physician, you might say, well, with thalassemias, you come to get your transfusions every 3 weeks and your chelation, and you're fine. If you ask a patient himself, he will tell you, well, sorry, I want to go for a whatever, safari in Africa for the next 8 weeks. Where can I find proper transfusions and proper care if I'm in trouble? And if you ask a sickle cell patient, I think he will be very upset if you consider his disease a non-malignant. But for a transplant physician, it is considered a non-malignant disease, such as severe combined immunodeficiency, anaplastic anemia, and so on and so forth. But there's a major difference between these non-malignant diseases, because sickle cell disease and thalassemia have a obligatory transplant indication. So you can transplant them today, and you can transplant them 20 years down the road. And that makes a challenge, or poses a challenge for the transplant physician and the patient to consult them when to go for transplant. And in the end, this situation with a non-obligatory transplant indication has to raise our approach and our restraints and our discipline to transplant these patients to the highest level. So we expect a rapid engraftment, low risk of infectious complications, minimal risk of systemic vasculopathies, next to no acute or chronic GVHD, at best a disease-free survival of more than 95%, and of course, preservation of fertility. This would be the optimum we should really ask for our hemoglobinopathy patients. And this question is to be answered if curative approaches can meet these requirements. Now, can we offer a curative approach to every hemoglobinopathy patient? Well, what do we have to offer? Number one, stem cell transplantation, matched related donor transplantations, and alternative donors, which is mostly haploidentical transplants these days. And on the opposite end, as we have heard from the other talk before, gene therapy, which is an autologous transplant from either genetically modified stem cells or a globin addition process where a viral vector is introducing alternative beta globin chains. And I'm going to start with matched sibling donor transplantation as standard of care. We consider it standard of care, but we have to be very much aware of certain problems that we are facing doing that. Because number one, there's a age as a major denominator for outcome. Event-free overall survival, and in particular chronic GVHD, is rising when patients are transplanted beyond 15 years. And 15 years is still an adolescent and young adult that needs to be consulted differently than when you're talking to a 5-year-old or the parents of a 5-year-old with regard to these complications. Same is true for mud donor transplantations, but in the MUTs, there's the issue that like in acute leukemias, the outcome depending of a mud or matched sibling donor transplantation is again different, with a chronic GVHD incidence of up to 31%, which I think is not acceptable in sickle cell disease. In the end, again, this might be a rhetorical question because donor availability is below 20% for sicklers and almost as much for thalassemia as well. So there's a significant unmet need for cure that must be addressed with alternative treatment options. Now, we start with gene therapy, gene editing before, and I will keep it short because you have heard a similar talk before. It might be a little bit more critical here. We have available genetics, the gene addition approach with a lentiviral vector, and we have the gene editing approach, and I will focus a little bit on Vertex, but a little more on Beam Therapeutics that just presented very nice data. The principle of gene editing is very clear. There's not much to talk about that. The timeline below, again, was given to me by Mohsen, who, of course, in your country has lots of experiences already with gene editing. And the point here is that the process taking the patient from patient identification to the time point where he eventually is ready to go for conditioning can be up to 12 months. This is a logistical issue that we have to face because you talk to the patient, he eventually consents to a procedure that is new, that can carry certain risks, as we have heard before, and keep him online for that long period of time might be a challenge for the patient psychologically, but also for the treating physician. We know that Vertex CRISPR-Cas-based editing double-strand breaks, knocking out BCL11A, de-repressing gamma chain transcription, and therefore upregulation of hemoglobin F production. These data are very well known and published. We have a vaso-occlusive free period that is achieved by 100% of those patients along the way in the trials. For thalassemia, the same 98% of the patients achieve transfusion independence. So we have a very efficient curative treatment option for these patients. But there are some caveats here that we have to consider. We have persistent hemolysis, a persistent reticulocytosis, slightly elevated LDH, and the haptoglobin is on the lower level here, or on the subnormal level here. And it might be due to the fact that the editing process still leaves approximately 60% of hemoglobin S in the system. Number two, there's in sickle cell disease poor mobilization and insufficient collection. So the manufacturing of gene-edited stem cells is a very wasteful process where we need 20 to 25 million CD34 positive cells to eventually start manufacturing and having at the end a sum of 4 to 5 million CD34 positive cells that are genetically modified. And this is reflected in the apheresis cycles that are on median 3 but can reach 5 or even higher, and approximately 20% of collections are collection failures in sickle cell disease. You can improve this by trying to add GCSF to the plerixafor mobilization that is obligatory, but you have to be aware that the licensing information clearly states that the use of GCSF is not recommended in patients with sickle cell disease due to significant crisis that can be triggered by using this drug. And there was also an editorial to a publication most recently by Arcioni that stated that really be very careful with using GCSF in mobilization. It might work, but if it doesn't really work and cause trouble, you are in an issue that in a situation that might be not so nice. Plus, there are additional strategies around the corner or already available, which is optimization of the apheresis process, plerixafor dose optimization, and new drugs like motixafor-tide with a higher affinity for CXCR4, so that you can improve your mobilization cycles without the addition of GCSF and other drugs that you see down there. So there is help around the corner, and I think we should be very careful with using G-CSF in these patients. There is delayed engraftment for sickle cell disease and thalassemia using the double-strand break vortex approach. Time to neutrophil engraftment is 29 days on the median, but can be as high as 56 days. Time to platelet engraftment is up to 200 days, which is far too long. Very similar data we see here for the TDT and, for the sickle cell population in the second table. Last but not least, but this is an issue with all the gene editing approaches, is busulfan conditioning. Busulfan is a horrible drug. It has high epi and endothelial toxicities. We know that the incidence with single conditioning with busulfan in TDT can be as high as 15%. And as we know, there are already fatalities in an 8-year-old child due to busulfan conditioning, only consequence of severe veno-occlusive disease. Busulfan passes the blood-brain barrier. We don't like that. We see high levels of PRES, in particular in the sickle cell population. And of course, busulfan has a very narrow therapeutic window. We all do serum level measurements, but when you do round robins and proficiency testings, you suddenly see that the levels and the cumulative AUCs between these different labs can differ by more than 20 to 50%, which I think is not acceptable. So we really need proper proficiency testings, standardized approaches, and external quality assessments. And last but not least, again, the patient information sheet says, consider prophylaxis for hepatic veno-occlusive disease prior to initiating busulfan conditioning. And for Litvia, the product by Genetics, it states literally use defibrotide for prophylaxis of veno-occlusive disease while doing gene editing, or gene therapy in this case. The problem is there's no drug licensed for prophylaxis of veno-occlusive disease. Now, around the corner comes now gene editing 2.0, and Gupta et al. Published most recently data on base editing for HBG1 and HBG2 promoters for sickle cell disease that I think are quite remarkable. So the difference is here, we are using an adenine-based editing. There are no double-strand breaks, and inosine later on is replaced by guanine at subsequent DNA repair and replication. And we are not editing BCL11 itself, but we are editing hemoglobin 1 and 2 promoters. So we're eliminating the binding site for BCL11A without disrupting other BCL11A regulated pathways. Now, the consequences are interesting. Number one, the median number of cycles for the collection of adequate stem cells is 1, low. Number two, the neutrophil and platelet engraftment time is almost reaching the time of the engraftment for a haploidentical transplantation with 17.5 and 19 days on the median. And here the question is it the difference of a double-strand break versus a single-strand break, that these cells, after they're thawed and they're eventually nested in their niches, need the time to recuperate and recover from these double-strand breaks versus single-strand breaks. That is the reason for the shortened time to engraftment. And we can also consider now or philosophize about the fact that what is the consequence for secondary off-target effects if you have a double-strand break versus a single-strand break. Of course, at the moment, we cannot answer these questions, but we should keep in mind. Outcomes, again, the swimmers plots that we know very well are excellent on 31 patients here. One patient succumbed during the treatment, of course, as a consequence of a severe busulfan-related pulmonary complication. So it's, again, busulfan that is an issue in this treatment as well. The data are slightly different. When we look at hemoglobin apheresis, we see a more than 60% hemoglobin F editing here. So we're down now to the real proper trait level with the hemoglobin S expression of 34% only. Percentage of F cells, very high, as in the Vertex trials, and hemoglobin F per F cell is also fairly high, enough to avoid further hemolysis. Now, in conclusion, we have all the benefits on the left-hand side, highly efficient, no donor problem, no GVHD, no risk for rejection, and a lower risk for viral complications. But, of course, it remains a surrogate therapy. We're not curing sickle cell disease or thalassemia. We're providing an alternative so-called functional cure with upregulation of hemoglobin F. We have a limited track record, so we still don't know yet what is going on in the next 10 years with secondary malignancies and off-target effects, and that might be the case more so for double-strand breaks rather than for the single-strand breaks. Poor mobilization and delayed engraftment are significant issues that are affecting our hospitals. We need the beds, we need to carry on with our transplants, and our nursing forces are limited, so this is something on a daily basis that might be an issue. Real-world data need to be collected with regard to the incidence of veno-occlusive disease and other complications and all the other factors that we need to keep in mind. So here the numbers have to be cranked up in order to give a proper answer. And of course, there's a persistence in patients of alloimmunization and hemolysis because this is something that you cannot cure with an autologous transplantation. And we talk about in a minute about the eligibility beyond clinical trial criteria. And last but not least, I think the costs. Are transplantation and gene therapy competitive treatment options? Well, let's look at the slide again, and then let's analyze how many patients with sickle cell disease, in this case, live in countries that can afford gene therapy. We're talking about, as you heard before, 2 million for the product itself, plus approximately 300,000 to 500,000 for the treatment procedure in hospital. So 10% reside in high-income countries, and of those 10%, only approximately 30%, that's 3% of the world population, are eligible for gene therapy. Why? 15% approximately, 20% apheresis failure, 15% matched donor availability, age over 35, that is not in the licensed indication, 20% approximately, and approximately 20% do not have an indication according to vaso-occlusive crises in the preceding 2 years. But what we're going to do with patients with chronic pain, osteonecrosis, progressive organ damage, hyperhemolysis, chronic hemolysis, and transfusion dependence, etc., etc., etc. So a substantial number of patients will be treated basically off license if you still want to apply gene therapy here. Same is true for thalassemia. 5% reside in high-income countries, and approximately 45% of those 5%, again, around 2 to 3%, will be eligible for gene therapy due to similar reasons: age, donor availability, and iron-related complications that, that make a gene editing approach dangerous. So the significant unmet need for a cure for the majority of world sickle and thal patients is an issue, and we have to tackle that. And the question here is a haploidentical transplantation a feasible alternative, matched sibling and mud transplantation, or even to gene therapy? So we're back to alternative donors for stem cell transplantation, and I'm going to talk about haploidentical transplantation. The benchmark at the moment here is Adetola Kasim's publication in 2025 in Nature, New England Journal of Medicine Evidence. They analyzed, in the end, 42 patients, 2-year event-free and overall survival, 88% and 95% respectively. But this is, of course, a very natural issue, I would say, related to post-transplant cyclophosphamide, which is a chronic incidence of chronic GVHD of 22%. And I think this is something that is very difficult to get rid of, in particular in this patient population. The alternative that we are propagating in Regensburg for the last almost 15 years is a haploidentical transplantation with a mitra alpha beta T cell depletion. And this is the regimen that we're using more or less unchanged for the last 15 years. We're starting with an immunocellular therapy with ATG grapholone of 15 and 10 milligram per kg for the haplo and for the matched sibling donor setting with a different timing, as you see here. We have a FDT approach with thiotepa, fludarabine, and treosulfan. And treosulfan is used because it has a very low end-to-end epithelial toxicity, doesn't pass the blood-brain barrier, is not metabolized in the liver, and it clearly showed in our setting that it is a very easily handleable drug with a high efficacy, as you will see in a minute. This is flanked by a post-transplant immunosuppression prolonged up to 240 days with MMF and tacrolimus to achieve GVHD-free survival for the matched siblings and to raise the level of chimerism in the haplo setting. Expectations were, with a high stem cell dose, we achieve early engraftment, low rates of infectious complications, shorter hospitalization, and hopefully next to no acute and chronic GVHD. So the challenge was fairly high. We started in 2013. As I said before, we had this pilot series of patients where we directly compared matched siblings with haplotransplants, 24 and 44 patients respectively. Median age was 23 and 14.6 years. And here are the outcome data. We have an overall survival of 96 and 89% respectively, disease-free survival of 96 and 91%. Those that needed a retransplant had a disease-free survival of 100%, as expected, a significantly better time to engraftment for platelets and neutrophils with the haplo setting, and basically next to no significant complications. Acute GVHD only grade 1 to 2, fairly low. Chronic GVHD only mild, that resolved within 8 to 12 months post-transplant, and also the incidence of VOD was negligible and was mild. Now, based on these data, we engaged in a prospective stratified trial directly comparing haploidentical transplantation with a matched sibling donor transplantation. The primary efficacy endpoint with a composite endpoint, acute GVHD, chronic GVHD, primary graft failure, and death. The trial is currently running in several countries, in Germany, Austria, and Switzerland, and we're going to initiate also Italy, possibly Canada, and also a center in Turkey. We enrolled so far 67 patients, and most recently we presented the data cut with 47 patients at the last EBMT meeting. So we compared 24 and 23 patients. The median age was 15 and 12 years in this setting, and these are the interim results now of this prospective multi-center monitored and controlled trial. We have an overall survival of 100%, a disease-free survival of 92 and 87%. Again, time to engraftment was significantly better, and again, a negligible incidence of acute and chronic GVHD and any other complications, in this case, viral complications. Now, I compared here the data, as you have seen from the trial, with the data from the pilot series in Regensburg. And what is remarkable is number one, the overall survival increased to 100%. And at the same time, the incidence of acute and chronic GVHD within the trial was reduced significantly. Not much of an explanation for this besides we started with a letermovir prophylaxis in 2019 in all of those patients with a mismatched CMV constellation. Definitely the cause for fatality, because we lost all our patients in the early phases due to CMV infection. But I think also it could be the reason for the lower risk of or lower incidence of acute and chronic GVHD due to the lack of the inflammatory response to a viral reactivation. So further data hopefully will show this. Now, the progress of the trial is like this. We combine now the pilot series that was treated exactly identical with the trial series together. We have 35 patients. The statistical analysis, sorry for the busy slide, but in the end, it clearly shows that the outcomes are absolutely identical, so that we are now closing the reference arm and we continue with the transplantation of the haploidentical arm so that we can reduce the sample size overall to another 69 patients. And in the end, we have very solid prospective, directly comparative data between the standard of care, which is matched sibling donor transplantation, and a alpha beta haploidentical transplantation in this setting. What about TDT? Being encouraged by these results, slowly in 2016, we treated THAL patients accordingly, and now we have a comparative analysis between 10 and 17 patients in this setting. Exactly the same conditioning. We don't do any pre-transplant immunosuppression, no hypertransfusion. We just do the classical approach in these patients where we do fertility preservation. We transfuse the patients immediately prior to transplant and go into transplant. And these are the results here. Again, an overall survival of 100%, 89%, disease-free survival, retransplant was successful. So we have 100% disease-free survival in all patients. The chimerism is excellent, as you see here. And in the end, no acute, no chronic GVHD, and in particular in the THAL population, basically no veno-occlusive disease. Now, the conclusion here is we have similar results to match sibling donor transplantation for both populations. We achieve a significantly faster engraftment, reduced hospitalization, a low incidence of acute and chronic GVHD, a low incidence of endothelial and sinusoidal toxicities, no risk of graft rejection or failure, basically a very minimal risk. And we have seen rejections in patients, for example, where the donor developed an acute adenovirus infection basically on day 0, and the same was true for a matched sibling donor who developed a parvovirus infection basically also on day 0 pre-transplant, and this was the major cause for graft rejection. So very unfortunate situations here. We will hopefully show by the end of this year data on fertility, because we're collecting our data after we have seen approximately 40% of our females receiving a myeloablative conditioning, delivering healthy children after natural conception. And this is, I think, very remarkable for a fully myeloablative conditioning. And of course, alpha-beta haploidentical transplantation is cost-effective and accessible. So when should we offer a curative approach? I think these criteria by Mark Walters are obsolete. We should not wait for any of these significant complications in our sickle cell population, but we should rather proceed for transplant and do not wait for the best option, because in this case, I really like the quote by Frederick Douglass, who said, "It's easier to build strong children than to repair broken men." And with this, I would like to invite you to the Hemoglobinopathies Working Party meeting in Regensburg again in September this time, and we have beautiful weather. It will be my pleasure to host you there. Thank you very much for your attention.
Thank you very much, Salim. This is a very impressive, elegant presentation as usual. You know, it was quite comprehensive, informative, and so a nice review of the update on the topic. So I'd like to thank you again for taking this time to prepare it. The floor is open for question.
Thank you so much, Dr. Salim.
Yes. Memon, yes.
Thank you so much, Dr. Salim. Very good and very interesting discussions. And Shabazz from Riyadh, just to introduce myself. I like to congratulate for your work, excellent work, and we are always learning by doing a mutual discussions all the time. Two important things which I want to address today, particularly to learn from you in your experience. One is that here we offer gene therapy and numbers are quite acceptable, and we are happy that this opens the door for a hope for hemoglobinopathy patients. So particularly still the CNS indication for sickle cell anemia still is a gray area. And there are patients, I know when you have a full-blown stroke, it's not a good indication because the data is not solid yet. But where we stand for a silent history of silent stroke or TIA in the past or high TCD in general, I mean, just what's the update? Are we ready to go ahead for those patients, or still is a consideration but need more work? This is number one. Number two, for alpha beta, the data is excellent, and we have started doing this therapy here in Riyadh, so this is really a good start. So far for immunology patients, but not for hemoglobin patients yet. So the question is that what do you see in terms of viral reactivations, which is, I know, a big problem for immunology patients, but from hemoglobinopathy, I want to learn, do you see this concern also for these patients, or it's quite handy to do this thing? Thank you.
Thanks. These are very, very important questions. Well, for question number one, in our hands, the only really patient population where we are concerned with regard to their pre-transplant complications is moya. But otherwise, we are really now going for transplant even in very severe sickle cell patients. We had most recently a patient with a severe hyperhemolysis syndrome, that had basically no product available. So we collected a few products before transplant, went into transplant, and now within 3 weeks post-transplant and 2 transfusions, he's doing very well. So even in that situation, we are quite happy with a very solid treatment option for these patients. So strokes are really the latest indication that we should go for, but we should go for transplant in patients with cerebral complications, most definitely. So, and we don't see any higher risk in this population doing the transplant the way we're doing it, in particular because treosulfan, as I said, is not passing the blood-brain barrier and does not cause additional endothelial issues as does busulfan. I think that's a major point here. Viral reactivation is absolutely an issue. And as I said, the major viral risk factor that we're facing is CMV. We can tackle that with letermovir. I mean, it is really a black and white situation with and without the letermovir prophylaxis. We try to stay away from the very little ones. Most of the time, we are challenged by families that have already a sickle cell patient and they deliver another child. And of course, they bring it basically from the delivery room directly to us and say, okay, please do the transplant. We don't want to face a similar situation with our second child. And those are the ones that we tell, please stay away from a transplant until you're older, I would say rather 3 to 4 years of age, because of a higher risk of adenovirus infection. That is, of course, as we know, difficult to treat, and the incidence is going down with age. And the other issue is the pharmacokinetic of the drugs is quite erratic in this age population, and up to 3 to 4 years, most of the time with some adequate care, you can avoid most of the sickle-related complications. So this is my take on that. When these patients develop viral complications post-transplant, we have a very pragmatic approach where when we see viral titers are rising, most of the time, we also observe a increasing mixed chimerism, which is to some point what we like to see. Why? Because when viral titers are rising and your chimerism is dropping, it tells us that you might develop a reactivation of autologous virus-specific T cells. And we confirm that with split chimerism analyses. So if you do a split chimerism analysis in the situation of a rising viral titer, a decreasing chimerism, it is most of the time what we call dissociated split chimerism. So we see 100% myeloid chimerism, and we see a rise of the autologous T cell chimerism. And that encourages us to, stay calm. We reduce MMF. In some cases, we start antiviral drugs and observe the situation. And in almost all cases, we're doing fine. Sometimes we're concerned if, for example, there's an adenoviral reactivation, we have no autologous viral, how can I say?
With
Thank
that,
you so much.
Thank you very much, Dr. Salim. We really enjoyed your lecture as usual. And with that, we conclude our EBMT highlights for physicians. I'd like to thank all the attendees. I hope you enjoyed the meeting, and we hope to see you again and again in this meeting. And I think the annual nursing event will start at 1:30 today, and I have one more announcement for our guests. I think this is just housekeeping announcement. For our guests to go to reception to finish at least 4 hours before the flight. So you have to go to the front desk for the further arrangements. So thank you, and please, you can go for lunch now and prayer. Thank you.
Hello.
nurses with me as well. I'll give it to Betty, huh?
Because he is one of those
special people.
speakers.
والله you are really bookless for the hospital, والله for the chemo.
Yeah, no, it's them. It's them who didn't want it, so.
No, they won't, but this stupidity.
Hi everyone, welcome to the 13th Annual Nurses Conference. We are privileged to have this meeting as a part of the annual SSBMT conference in collaboration with EBMT. I would like to thank EBMT Nursing Committee for co-organizing this meeting with us. I would like to thank all speakers from SSBMT and EBMT. I would like to thank all the speakers from SSBMT and EBMT. The program will have 2 sessions with different topics. I wish you all informative program. Please let me welcome Ms. Hilda from EBMT Nurses Group for welcome remark. Ms. Hilda, mic is yours.
So I can hear you now. Is it right that I can introduce my presentation? Okay, thank you.
Yes, Ms. Hilda, we can see you. You can start.
Okay, perfectly. Thank you so much. Can you see my right screen now? Probably it's not the right one. Sorry. It's a bit messy on my screen. So I guess this is the right one, right?
Best of EBM 6 with Ms. Hilda. Nurse at William Alexander Children's Hospital and researcher in the Department of Medical Ethics and Health Law. In addition to her clinical and academic roles, Hilda served as a president of the EBMT Nurses Group. Ms. Hilda, mic is yours.
Thank you so much. And it's my pleasure to do these welcome remarks on behalf of the EBMT Nurses Group. And I would like to present you I would like to welcome you on behalf of the EBMT Nurses Group, and I would like to welcome you to this 13th annual Saudi Hem-Ong Nurses Conference. Thank you so much to the organization, to Norkaya and to Mariam Amatourai for this great initiative and organization of this day. Huge congratulations with this excellent program. And let me introduce the EBMT Nurses Group to you. As Nurses Group, we are part of the EBMT, and we are a group of EBMT. The EBMT Nurses Group brings together nurses and allied health professionals working in the field of HCT and cellular therapy. And we do that by improving the care of our patients through evidence-based practice, to enhance and value the nursing role worldwide, and by supporting and sharing knowledge through communication, advocacy, research, training, and education. And this picture shows you an overview of the EBMT Nurses Group. And in the middle here, you can see the EBMT Nurses Group Board, which we consist of a president and a secretary, and sometimes also a president-elect or past president. On the left side, you see a list of all more medical working parties. And in each of those working parties, we have a link nurse collaborating with us and also collaborating together with the lead of a lead nurse. Then we have 4 committees, a scientific committee, a research committee, the pediatric committee, and our global education committee. And at the bottom, you can also see that we collaborate closely with national groups. And in this picture, I will explain a bit more about the committees. The scientific committee first aims to coordinate and organizes the annual conference, including symposia and the educational day, usually on Sunday. Next to that, we have our research committee, which aims to coordinate and lead the development of research programs in hematopoietic stem cell transplant and cellular therapy. Then next to that, we have the pediatric committee, who aims to improve the care of pediatric and adolescent HET and cellular therapy patients and to promote, develop, and share knowledge between pediatric nurses. Lastly, we have our Global Education Committee, who aims to coordinate and organize outreach meetings in cooperation with other non-profit associations with the same mission and objectives. And in this map, you can see that we have a lot of nurse members across 66 countries worldwide. And I also see your country involved in this picture. It's not totally that all members are included here, because I know that a lot of nurses are active, for example, on the member center list. So I guess there are more nurses involved than these 1,200. What we do, can you bring together to 3 main pillars, which is education, research, and projects. And in that, we also support nurses with grants, and these grants will usually become available in June. And there are several grants, and you can apply to that by sending your CV and a motivation letter. And then after June, we will read them and let the results know. And sometimes when there are grants available during the rest of the year, we will re-advertise them. But we also do a lot of communication, for example, by the newsletter, but also by the social media channels. And we try to give support wherever needed. And sometimes that's also in other countries who are developing their transplantational cellular therapy programs. And of course, we advocate for nurses in HCT and cellular therapy where we can. And what is also listed here is that we do research. We do research in collaboration with the working party nurses or with the working parties, and sometimes on ourselves. And I will list some of our highlights of the projects we do at the moment. And during the annual meeting, which we held in Madrid this year, we launched our first EBMT exam for nurses, including a preparatory course. And this preparatory course could be followed online. And it is based on our nurses group textbook. And if nurses completed both the preparatory course and the exam, they get the certification, which could be a great acknowledgement for the experience and knowledge of nurses in HCT and cellular therapy. And especially when such education is not organized in a certain country, this might be of a very high value. And then next to that, we also have our digital skills videos. And aspirate and Trefine, but also on the insertion and management of peripherally inserted central catheters and thawing and And then last but not least, we also have our EBMT Nurses Group textbook, which was already available in Italian, French, German, Polish, and Spanish. And this is just a couple of our highlights. To know more, we have the website and newsletter. And I highlighted on this picture the nurses section on the page. And if you enter the website, you can find a lot more here. And if you want to subscribe for the newsletter, you can click on the button at the right side, and then you subscribe for the newsletter and can tick the boxes where you are interested in. And I also would like to point your attention to our 18th educational meeting of the EBMT Nurses Group, which will be held in Dublin in Ireland in October 2026. And then lastly, we also have our 53rd annual meeting next year in April in Rotterdam. And yeah, probably we can see some of you there as well. And if you want to submit an abstract for that conference, that will be opened, I expect, after the summer. And the deadline for submission will be mid-December. Then after submission of those abstracts, this will be followed by a blinded review process by a panel of nurses who all give a score between 1 and 10, followed by a thorough discussion within our committees based on mean scores and comments. And these are the general requirements. The abstract should contain max 500 words, should be in English, original work, and usually one table and one image can be included. It's not necessary, but it can be. And the following structure should be followed: background, method, results, and conclusions. And if you want more guidance how to submit an abstract, there is also a Nurses Group abstract guidance document, which is easy to follow for you probably. And there's also an episode on our podcast of the EBMT Nurses Group. And additionally to that, on the website, you can also find a webinar focused on abstract submission. So I would like to thank again for the organization and everyone involved for making this fantastic day possible. And I'm looking forward to ongoing collaboration with the SSBMT. And I wish you all a very, very inspiring, meaningful, and energizing meeting. Thank you so much.
Can I ask you about the nurse exam? Because actually this is, I think, the first time to announce there is EBMT nurse exam. We saw that before the videos and educational material, the ebook, but for the exam, any nurses can be submit for this exam?
Yes, all nurses can apply for this exam, and you have to subscribe yourself, and then you can follow the online preparatory course. That's not mandatory to do that, but it's recommended to do, and it guides you actually through the whole process and it's based on our textbook. And then actually it's very useful to also do the quizzes between which are included into the preparatory course, and then you can follow the exam. We are currently discussing how we can improve the access to the exam, but because last year we opened it only on site in Madrid, but for next years we are discussing that it would be also possible to do the exam online or during other meetings. So I hope I can bring some good news soon.
Because we have time. Anybody?
I just have one question.
Yes.
For the EBMT Nurses Group meeting, who are those people can attend? Is it only members or any nurses from any region, any country?
Yes, thank you for this question. And any nurses of every region can join our meetings, of course. They are always open for everyone. And I can let you know that there are still grants available for example, for the meeting in Dublin. So if you go to our website and you try to find the educational meeting in Dublin, for example, there are still grants available to join us there. And also, if you don't need a grant, you can also join us. But yeah, of course, it's open for everyone.
Thank you so much, Ms. Hella. Any more questions? No more? Thank you, Ms. Helda. We are a pleasure to have you in our SSBMT. Thank you, and really appreciate you represent with us. Thanks a lot. We will go for the second subject. Thanks a lot.
Thank you.
Is Dr. Izakon online?
Yes. Well, I think I needed also to give another presentation. Is that right? I also needed to give a best of the best presentation. Yeah, sorry. I will share my screen. You see my screen right? Okay, then I would like to also present you the best of the best of the annual meeting. And actually, this I will present 5 of the best abstracts. And of course, I can only very shortly address these. So if you want to know more, you can go to the website and try to read their abstracts. And in total, this year we received 184 abstracts, and we offered 28 oral presentations and 133 poster presentations. Only a couple of them were rejected, and more than 30 countries were involved. And here you can see an overview of the countries that were involved, with on the top the UK and China, but it was very nice to see that a lot of countries contributed with abstracts this year. So it was also lovely to see your country included here. Now I'll present the Best Adult Oral Presentation Abstract Award. This was given to Nina Canova from Switzerland, and she presented on journey mapping as a method to explore the adoptive cell therapy experience of patients, informal caregivers, and healthcare professionals. And the aim of their study was to explore patients, informal caregivers, and healthcare professionals' experiences and the perspectives with adoptive cell therapy. And they used a qualitative exploratory design using purposive and pragmatic sampling. Their participants included patients, informal caregivers, and healthcare professionals. And they used semi-structured interviews with psychological processes mapping activity. And their analysis included transcription, content analysis, frequency of reported psychological impact at each stage. And these were the main results. They were able to analyze 43 maps, and which shows that adoptive cell therapy pathways are highly emotional and ambivalent, according to the respondents. And in the therapy presentation, hope for life extension coexist with fear, and fear pointed to the toxicity, complexity, uncertainty, and efficiency. Then during the pre-treatment phase, increased stress was seen due to the diagnostics, logistics, hospitalization, and clear communication in this builds trust. During the treatment, relief and hope was mixed with fear and unexpected toxicity intensity. And in the post-treatment outcomes, the researchers identified both positive and negative outcomes, and positive like joy, gratitude, cautious optimism, and negative pointing to sadness and anger. And across all the phases, fluctuating social support was seen, but also loneliness and a sense of control. And the coping strategies that were used by patients was emotion-focused, problem-focused, and meaning-focused. And the key gaps identified by healthcare professions were the underestimation of pre-treatment coordination burden and underestimation of post-treatment physical debilitation. The highest unmet needs were pre- and post-treatment phases, the priority targets for psychosocial interventions in the future. And this study concludes with that this study identifies critical psychosocial pressure points across the adoptive cell therapy pathway, and there were discrepancies between healthcare professionals' perceptions and the lived perspectives and experiences of patients and carers. And this highlights the importance of proactive, structured psychosocial assessment and the need for targeted support interventions at key moments. And this method, the journey mapping, provided a valuable in capturing an emotional shifts and revealing unmet needs that are less evident in traditional interviews, offering actionable insights to strengthen person-centered care across the adoptive cell therapy services. Then the next award went to the Best Pediatric Oral Presentation. And that was Isabel Salcedo from Spain, and she presented on safety profiles of 2 anti-thymocyte globulin formulations in pediatric hematopoietic stem cell transplantation, and they reported also on the implications for nurses. The aim was to evaluate the incidence of adverse events associated with the administration of Rafalon on the one hand and thymoglobulin on the other hand in pediatric patients undergoing HCT. The design was a retrospective cohort study, multi-center, and the data were based on electronic health records. They included pediatric patients between 0 and 18 years old, undergoing hematopoietic stem cell transplant since 2018, and a receipt of thymoglobulin and quavalon as part of the pre-transplant conditioning regimen should be in their health records. They excluded simultaneous use of both drugs and also the use of ATG for GVHD. So this picture is showing the results. As you can see here, they included 4 hospitals in Spain, and in the cohort, thymoglobulin was used in the orange parts and quavalon in the blue parts, and over 400 patients were included. So that's quite a big study. I cannot show you all the results, which were actually quite interesting, but the main result was that there is a higher risk of capillary leak syndrome with hemoglobin compared to quavalon. And also more ICU transfers within 72 hours were seen. Like 15 children out of 251 treated with hemoglobin were transferred to ICU within 72 hours of ATG initiation, with a mean stay of 2.67 days. But none of the 171 treated with quavalon required ICU. So in conclusion, quavalon demonstrated a more favorable safety profile during the 24 and 72 hours of ATG infusion compared to thymoglobulin, and higher incidence of capillary leak syndrome and ICU transfer with thymoglobulin underscores the need for adequate nursing staffing ratios and well-trained nurses to ensure patient safety. Although retrospective studies may have some limitations, to their knowledge, this was the first study on this comparison on pediatrics and with an important sample size that leads to meaningful conclusions. But prospective and randomized controlled trials are needed to confirm the findings. And what it also shows that multi-center nurses-led studies based on their bedside observations are feasible and necessary to provide an evidence-based care to our patients. Okay, I will rush a bit. Then best research on the oral presentation on, the best research oral presentation went to Sabine Valenta on emotional burden predicts mortality 5 years after adult HCT. That was a prospective Swiss transplant study. The study aimed to evaluate the evolution of emotional burden and its impact on overall survival from pre-transplant to 5 years post-transplant. They had 3 sub-aims, as you can see here. They used the following design: a multi-center prospective open national cohort study with secondary data analysis of the Swiss transplant cohort study. The setting and sample was that all 3 Swiss centers were included and adult patients after transplant were included between 2013 and 2018. The data sources were, on the one hand, the psychosocial questionnaire, and on the other hand, EBMT registry data. And here you can see the results. On the horizontal axis, you can see the different time zones before transplant, after 6 months, after 12 months, and after 24 months. And in blue, the clinical insignificant depressive symptomatology, 8 to 10, the orange one, borderline depressive symptomatology, and the greens showing clinical significant depressive symptomatology. And here were represented anxiety levels, same way of presenting it, a bit quite some slightly and moderate anxiety levels here. And also here is shown the perceived stress assessed using a single item 5-point Likert scale. And you can see that rather much and very much stress levels were reported here as well. And overall, these results also shown that there was a higher risk of mortality in all these groups of patients. So it was really associated with each other. So the conclusion was that emotional burden independently and robustly predicted poorer 5-year overall survivor in HCT recipients, and the findings highlight the clinical relevance of systematically assessing emotional burden and integrating timely psychosocial support into post-transplant care to potentially improve long-term outcomes. The next, the best adult poster presentation, which went to Alexander Istomin from the Ukraine on global collaboration. They saw an increase of transplants in their country, but there were also unmet needs of education, and they sought for a collaboration with the WBMT nurses group and using an educational program. Consisting of several steps, they reached out, they developed a program, they raised funds, produced video materials. They produced a course with translation to Ukraine with expert views, and then it was opened for the audience. And 11 nurses from 11 of the 11 centers participated here. And they also had a 5-weekly modules delivered via Zoom meetings with different aspects of the modules. And they did a post-test and satisfaction survey. And they also included one hands-on workshop about CVL care. And as you can see here, quite briefly, 75% of the applicants successfully finished the course, and 82% find it very clear and relevant. So this highlights actually that the need for structured nursing education in Ukraine was scalable and it was a resource-efficient model for expanding easy access. Then the last one, the pediatric poster went to Dina El Mouzain from the United Arab Emirates, establishing the first pediatric bone marrow transplant nursing program there. And their aim was to create sustainable framework for nursing excellence through structured education, validation, and mentorship. And they collaborated with the Boston Children's Hospital. They included an educational program and implemented that and developed that in collaboration with Boston Children's Hospital and the Abu Dhabi BMT nursing educators. And they also evaluated pre-post directly and 6 months competency revalidation cycles. These were their results. They had some indicated nursing competence, nursing confidence, patient satisfaction, antibiotic administration within 30 minutes, and nursing documentation. And as you can see, in the purple bars were the post-program indicators, and the red ones were the baselines. And you can see a very nice improvement in all of these indicators until almost 100%. So this was really a nice achievement for them. So their conclusion was that through structured education, mentorship, and capacity building, the Abu Dhabi BMT program established the United Arab Emirates' first pediatric BMT nursing program, achieving Certificate of Excellence Effect accreditation. And their collaboration with PCH and implementation of a framework resulted also in measurable improvements, and the development of local instructor capacity ensures sustainability, knowledge transfer, and scalability. So their abstracts are all available at the EBMT website and also the other abstracts. So if you want to know more, you can have a look there. So thank you so much for your attention.
This presentation, any question? Appreciate your presentation. Thank you so much.
Thank you so much.
Is Dr. Izakon online? Ready? Yeah, she's ready? Dr. Izakon? Okay. We will go for the second subject. Doctor, please excuse me if I spell your name in wrong way. Dr. Izascon Ziperio. Dr. Izascon Ziperio is from Spanish. She has completed her residency, specializes in hematology and hematopathy in the Virgen del Camino Hospital between 1995 till 1998. And since 2014, she's working in the Department of Hematology and Hematotherapy at the University Hospital of Donostia. And since 2025, she's the head of the clinical hematology unit. Her clinical interests focus on primary of the diagnosis and treatment of lymphoma and lymphoproliferative syndromes, as well as advanced therapies. In 2016, she received the Dr. Beller Lewis Award of the Best Scientific Article published in the Medical Journal from the Foundation of the Official College of Physician of Jiboska. She's a member of Bosik-Naravi Hematology Association and the Spanish Society of Hematology and Hematotherapy, SEHH. And she's also part of the Giltamo Lymphoma Treatment Group. Welcome. We are appreciate that you are with us, especially with the nurses, as you are ahead of the hematology. Mike is yours.
Thank you very much. It's a pleasure to be in this SSBMT Congress, and thank you for your kind invitation. I will talk about Hodgkin lymphoma. These are my disclosures, and this is the agenda that I will follow in the next 20 minutes. Hodgkin lymphoma is a type of malignancy that affects the lymphatic system and is marked by the presence of red stem cells, which are large cancer cells not found in non-Hodgkin lymphoma. Although the disease originates in the lymph systems, the cancer can spread to almost any organ or tissue, including the bone marrow, liver, and spleen. It's a rare disease. It only accounts for around 10% of the whole lymphomas and is the lymphoma with the best overall survival because we are lucky that most of the patients will achieve the cure after the treatment. It's a rare disease. The incidence is around 2 cases per 100 inhabitants. And as I already told you, the cure is very high. And we have seen an improvement in the survival rate in the last years, not seen in another neoplasia. The incidence is biphasic. Most of patients are young teenagers or young adults in their 20s. And also we have another peak of incidence in older patients. Around 20 to 20% of patients are older than 60 years old. Risk factors to develop Hodgkin lymphoma is the Epstein-Barr virus, the age, young age or older people, male being a male, the family history we have, we don't know why, but brothers affected with Hodgkin lymphoma, and the immunosuppression due to HIV or another treatments in solid organ recipients or patients receiving immunosuppressant for autoimmune disorders. For the diagnosis of lymphoma, Hodgkin lymphoma, we need a good biopsy. Usually we need an excisional biopsy because the pathological diagnosis is based on the finding of these red stem cells in the tumoral tissue. It's also very important the microenvironment, the cells that are surrounding these red stem cells, the lymphocytes, eosinophils, neutrophils, and histiocytes that are characteristics of this illness, and this tumor microenvironment supports the red stem cells. There are different red stem cells. The most common one is the binucleated red stem cell, but also we have in the nodular predominant variant, we have another type of L and H cell that is the popcorn cell. The classification, we have two types of Hodgkin lymphoma. The main one is the classical Hodgkin lymphoma that accounts for 95% of the Hodgkin lymphoma cases, and the red stem cells in this case is the typical one and is positive for CD30 and CD15. There are different variants like nodular sclerosis, that is the type most frequent seen in young people, and the mixed celularity seen in older patients. There is another variant, the nodular lymphocyte predominant Hodgkin lymphoma, that is only 5% of all the Hodgkin lymphoma, and is totally different. The tumoral cell is the popcorn cell, and the immunophenotype is negative for CD30 and 15, and is positive for 20. Is positive for 20, and another markers typical of non-Hodgkin lymphoma. Nowadays, in the new classification, we consider that this variant non-classical Hodgkin lymphoma is more is considered a low-grade B-cell lymphoma because all the presentation, the clinical evolution, and the treatment should be totally different. And what symptoms have patients with Hodgkin lymphoma? They usually go to the doctors because they have an adenopathy, a lump in the neck and in the armpit. Usually the adenopathies are rubbery and painless. They can also have a mediastinal mass with cough, with breathlessness, or also with chest discomfort that was lying flat. Due to the inflammatory interleukins and substances that the tumoral cells throw in the patients, they can develop also systemic symptoms like B symptoms, that these are fever, weight loss, and drenching night sweats. They also can have itch and alcohol-induced pain that is very typical. When this patient drinks alcohol, the lungs are induced pain, and they also can develop fatigue. It's very important for the nursing point, the early recognition of these symptoms and prompt referral to these patients. Before we start treatment, we usually do an echocardiogram because they will receive anthracyclines that they are toxic to the heart. We also consider lung function test because these patients will receive bleomycin that is toxic for the lung. And also we have to inform patients and blood bank that they should only receive irradiated blood products. Also, we have to discuss if we are going to give chemotherapy to these patients, fertility preservation in women with stimulated egg or ovarian preservation, and in men with sperm storage. The extension study are made by PET-CT. And the staging system is the Ann Arbor system. It's very simple. Stage 1, when the patient have one involvement of single lymph node region. Stage 2, if the patients have 2 or more lymph nodes regions, but in the same side of the diaphragm. Stage 3, when the patient have involvement of lymph nodes in both sides of the diaphragm. And stage 4, when the disease is disseminated in the extralymphatic disease, like a solid node in a liver or in the bone or in the lung. And we put B if the patients have B symptoms, X if the disease is bulk, that is when you have adenopathies greater than 10 centimeters, and S if the spleen is involved. The nursing role is very important. Is this preparation for diagnosis, for the biopsy and imaging, and also the education on a staging process and expectation with this disease. Most of the patients will have stage 1 or 2 that is considered localized, and 40% will develop advanced stage, that is stage 3 or 4, and this impacts in survival. Patients with stage 3 or 4 have worse survival. I already told you that 20% of patients are older than 60 years old, and these patients have a much worse prognosis because the histology and the biology of the disease is different, because these patients don't tolerate well the chemotherapy. They receive lower dose intensity treatments due to the treatment-related mortality, risk of infection and toxicity, and because these patients have also comorbidity that limits the capacity to receive chemotherapy. And they also have an increased risk to develop lung toxicity due to bleomycin. And how do we treat these patients? we usually, in first-line treatment, we use in early stage, we combine 2 or 4 cycles of chemotherapy plus radiotherapy, and in advanced stage, we usually use 6 cycles of chemotherapy. Now, we have the capacity to use new drugs that I will comment on that, like brentuximab or nivolumab, improving especially the survival of patients with advanced stage disease. With this first line, we are able to cure more than 80% of the patients, and this means that we will have long-term survivals, and these patients will live a long time, and they will develop long-term side effects like secondary neoplasia, cardiovascular disease, hypothyroidism, and infertility. The 2 main chemotherapy approaches in first line are ABVD, used more in North America and Europe, and is less effective in advanced stage because it cures around 75% of patients in advanced stage, but is less toxic and this chemotherapy has lower impact on fertility and the development on secondary neoplasia. The German group uses in advanced stage, especially escalated BioCop, that is a chemotherapy that is really effective in curing more than or around 90% of patients with advanced stage, but is much more toxic with a lot of infertility about this treatment and the risk of developing secondary neoplasia. Now we have 2 new options, including chemotherapy with new treatments like nivolumab or brentuximab vedotin for advanced stage, and these are new combination nivo-ABVD developed in North America, and BRICAT, that is like a better BCOP escalated. They take out the more toxic bleomycin and they substitute it for brentuximab and also procarbazine to dacarbazine, and they achieve a very high cure rate with this BRICAT combination with brentuximab and the old escalated BCOP with much less toxicity. The new drugs that we are using in Hodgkin lymphoma are brentuximab vedotin, is anti-CD30 antibody conjugated to a drug, monomethyl auristatin. This antibody is internalized in CD30 positive cells like the Reed-Steinberg tumoral cells and causes the death of the tumoral cells. The main toxicity of the brentuximab is neuropathy, and the nurse teams are crucial to detect and adapt the treatment when patients developed neuropathy. And the other drug that is very interesting for Hodgkin lymphoma are the immune checkpoint inhibitors, nivolumab and pembrolizumab. The Reed-Steinberg tumoral cells, they express PD-L1, that is an antigen that inhibits the activity of the patient's T cells. With blocking this PD-L1 antigen with nivolumab or pembrolizumab, then patient's T cells are able to attack and kill the tumoral cells. And as I already told you, the drugs that we use, they are cause of important toxicity that we have to detect and manage. The immunotherapy also causes immune-related adverse events when these T cells attack the patient's tissues like thyroiditis, pneumonitis, or colitis, and it's very important to use all the supportive care in this patient. From the nursing role, the symptoms control, the patient education about side effects and when to seek care, and also all the support for the treatment adherence is crucial. Most of the patients will achieve the cure with the first time, but some of the patients will relapse. when we have the suspect that a patient has a relapse, we have to do again a excisional biopsy, because sometimes you can see that there are alternative pathology results, and also we have a lot of false positive in PET-CT. When a patient has a relapse, you have to restage again with PET-CT, consider fertility presentation, and also seek the input of different specialized services. Around 10% of patients will be primary refractory to first-line treatment, and 20% will relapse. In these patients, we use salvage therapy, usually target agents, again, like brentuximab or pembrolizumab, combined with chemotherapy, and we try to consolidate these patients with autologous stem cell transplantation if they are fit and if they achieve a response to the salvage therapy. In high-risk patients, to try to reduce the risk of relapse, we use also brentuximab vedotin maintenance after autologous stem transplant. Some patients will relapse after autologous transplant, and then we have the option of use again new target agents as salvage therapy, and if they have a good donor and if they achieve some kind of response, to try to bring them to an allogeneic stem cell transplantation. We are happy to have a lot of long-term survivals, but these patients have a higher risk to develop respiratory disease, also cardiovascular events and secondary cancers, and also especially the risk of cumulative incidence of heart failure in these patients is very high after using high cumulative doses of doxorubicin, and especially if they are combined with mediastinal radiotherapy. Also, there is a very interesting publication that not only radiotherapy is a risk factor in women for breast cancer, also the high dose of cumulative doses of doxorubicin are linked to a higher risk of breast cancer in survivors of Hodgkin lymphoma. For this long-term risk, is crucial the nursing involvement in the long-term follow-up coordination in the different programs that we have to follow these long-term survivors, in the lifestyle counseling, and also in the different screening adherence. And with this, I would like to finish. Hodgkin lymphoma is an unique epidemiology. It's very common in very young patients, and it has a biphasic incidence. Unique outcomes. We cure the majority, but we have to must keep an eye on late effects of the radiotherapy and chemotherapy, and elderly patients remain a challenge, and we have to be very cautious with bleomycin in elderly patients. I think that nursing role is crucial in the different teams, and especially in the whole process in the care of these patients. And thank you very much. I will be happy to take some questions.
Isaacson, I would like to ask you to avoid positive PET scan. As you know, when you do it, sometimes if the patient in GCSF, usually we are trying to avoid to do it within 5 to 7 days, but sometimes some the radiologists, they will ask more than 2 weeks. And also, if radiation, usually we do 2 months, but sometimes some radiology, they ask 3 months. And sometimes if the patient have infection, all of these factors, it will affect to give us a wrong PET scan result. So usually, what is you prefer time, the best time to repeat the PET scan? Of course, after treatment, but to avoid these circumstances. And if the patient GCSF, or if he received the TBI, radiation therapy.
This is a very important question because PET-CT has a lot of false positives. We usually, when the patient finishes treatment, we try to have like 4 to 6 weeks before we do the PET-CT. And if patient has an infection, we always we tell them to call us because sometimes if they perform the PET-CT with a respiratory infection, you will have a false positive PET-CT and you have to repeat it. After radiotherapy, we try to at least we have a window of 3 months after radiotherapy because after radiotherapy we have a lot of false positives. And in the follow-up, we never do PET-CTs. We follow up this patient in the clinic with a blood test and a physical exam and nothing else. And if you are suspecting that the patient is relapsing, then you have to do a PET-CT, but not in the survivorship follow-up.
Thank you so much for your nice presentation. I have one question. What's the recent update has most changed management in Hodgkin lymphoma in your center?
For me, the most important is that we have an amazing nursing group that supports our patients. They follow all the toxicity. They support our patients. They do all the if we need a peak or a vascular access, they follow our patients, and this is the I think the nurse team support is the main success in our team. Also, we have access now. I as already told you, most of patients will be cured, but this 30-40% of patients with advanced disease, stage 3 to 4, we use in Europe ABVD, and it cures only 70% of patients. Nowadays, we have the option to use Brecard, that is like a better BCOP escalated with brentuximab and with less toxic drugs, and with that we are curing 90% of patients, and this is also it has a huge impact in our patients.
Thank you so much.
Any question? Yeah, she has a question.
Hello, Dr. Iza. Good afternoon.
Hello.
Hi. Dr. Iza, in your years of experience managing Hodgkin lymphoma, you mentioned it's commonly with a young adult. Have you encountered a patient undergoing induction chemotherapy and got pregnant? And that's the first one. Secondly, a patient that has been newly diagnosed with Hodgkin lymphoma but currently pregnant, and what is your treatment plan of action afterwards? As you mentioned, although ABBD have a less impact in fertility, and you do fertility counseling, but I just want to seek your experience as compliance-wise. I don't know, the people in your area might be more compliant when it say, do not get pregnant. We have a different set of patients here that sometimes it happens. They do get pregnant even if they advise them to be in contraception or something. Thank you.
This is a very important question. We are lucky because we don't have too much patients that become pregnant during treatment, but this is a drama, of course. We try to educate our patients, but sometimes you have these are young people and they get pregnant, and this is a huge ethical issue. if it is in the first 3 months, you cannot give any chemotherapy, and you have to avoid also radiotherapy. And if it's a localized stage, we give the option to the patients to wait if the patient is in a good shape and it's a localized disease. We try to wait some months and try to avoid the treatment until the pregnancy is advanced. You can give chemotherapy safely, and there are and also delivery the babies inserts period of from 6th to 9th month of the pregnancy, and ABVD is safe. I have never done that. And if patient is in the first 3 months and has an advanced stage disease, it can compromise the life of the patients and also the life of the baby. And that's why in the first 3 months, if the life of the patient is in danger, we talk about abortion. But this is there are good reviews about how to treat this patient, but this is a drama. And I have had a patient who was already pregnant in the 6 to 9 months of the pregnancy, and she was diagnosed with Hodgkin, and we wait until the delivery and then treated her. But I am very lucky not to have patients getting pregnant during treatment, but this is reported and it's very important.
Any more questions? Thank you so much, Doctor. We appreciate, really, it was an honor to have you with us. So now we will move to the second speaker, which is Ms. Sylvia Nietzsche. Ms. Sylvia Nietzsche is working as a specialized nurse in oncology, hematology, and bone marrow transplant at the RICCS San Rafael Scientific Institute. Her clinical expertise encompasses the management of the hematopoiesis stem cell transplant, cellular therapy, and CAR-T treatment for both adult and pediatric patients. Her commitment for professional development is further demonstrated through her leadership, and also she's working now she's working with the unit in support of a new pediatric transplant facility in Tanzania through ISBO, no-profit organization. It's an honor to have Ms. Sylvia. She will talk to us about the impact of novel therapies on clinical nursing education. Welcome again, and the mic is yours, Ms. Sylvia.
Hello, everybody. Thank you for the invitation. I try to share my screen and in the presenter mode. Okay. Okay. Good morning, everyone, and so thank you for joining this session. My name is Silvia Gnecchi, and today I'd like to explore how the rapid evolution of advanced therapies in transplantation and cellular medicine is reshaping clinical nurse education and learning. Novel therapeutics are challenging, and great consideration should be promoted on what nurses must know, how to learn, and how to implement in everyday practice. I have no conflicts of interest to declare. So, about clinical nurse education, I try to provide some definition. So, nursing preparation has always relied on a combination of theoretical knowledge, supervised practice, and mentorship. It's a process that helps nurses develop judgment, technical skills, and also the ability to make sound decisions in complex situations. But the environment in which this learning takes place has changed a lot in the last years. The complexity of today's therapies requires, in fact, a more structured and forward-looking approach to education. And this brings us to the therapies that are driving this transformation. In recent years, we've seen an extraordinary expansion of therapeutic options, engineered immune cells, gene-edited stem cells, target biological agents, and also new strategies to modulate the immune system. These innovations are improving outcomes, but they are also introduce new responsibilities for nurses. In fact, we are now caring for patients who may develop rapid onset toxicities, who require a very precise handling of cellular products, and also who need detailed education about treatments that are still unfamiliar to most people. In fact, there is also the need to promote multimodal training from the knowledge field to the practical one. So, how do we prepare nurses for this new reality? In this slide, we can see a list of some examples of advanced nursing training. And in fact, delivering high-level nursing care to individuals undergoing novel therapeutics requires a wide range of nursing competencies, each essential at different points along the treatment pathway. Within the broader multidisciplinary team, structured nurse education plays a pivotal role in ensuring safe, skilled practice and also shaping the patient's overall treatment journey. Examining the educational needs of the nursing workforce across the full continuum, it becomes clear how vital the contribution of specialist nurses, practice educators, and the wider team are in sharing expertise and supporting learning. Educational strategies should also strengthen collaboration with universities and referring nursing teams to promote continuity of care across hospitalization and follow-up. So, to meet these challenges, nursing education must become more and more diversified. We need a combination of structured courses, digital learning, simulations, communication training, and also a strong mentorship. So I'll deepen in the following slides these strategies list in this slide. So in this first table, there are some examples of strategies. Specialized postgraduate programs provide, for example, stronger consolidation and master covering oncohematology, transplantation, and the cellular therapy areas. According to the country, the length of the course can change. Usually, they are 1-2 years long. Digital learning platforms allow nurses to stay updated on topics like immune effector toxicities, infection prevention, and safe manipulation of chemotherapy. Nurses can easily access from their personal computer, smartphones, everywhere and at any time. Simulation and role-playing are demonstrated to be effective in practical training. It allows teams to rehearse realistic scenarios in a safe environment. They promote, in addition, also communication, manual skills perfectioning, and critical thinking. But training doesn't stop there. In fact, there are some more strategies which are written in this extra table. Mentorship, for example, remains one of the most effective ways to support new staff. Shadowing experienced colleagues during stem cells infusion or GVHD assessment provides insights that no textbook can offer. Peer learning activities like case reviews, reflective groups, share protocol updates create a culture of continuous improvement. And practical tools such as manuals, pocket guides, podcasts, and short videos can help nurses refresh their knowledge during some busy shift. Learning objectives should be negotiated between the educator and the learner according to Bloom's taxonomy. What is Bloom taxonomy? It consists in gradually reaching new competencies and skills through different domains, starting from the base level, which is knowledge, followed by comprehension, application, analysis, synthesis, and evaluation. So these elements all contribute to a broader set of educational goals. So what are the key elements of clinical nurse education? Effective clinical education must strengthen hands-on abilities, help nurse apply theory to real situations, and ensure that competencies are assessed regularly. It must also support professional development and provide a strong mentorship structure, especially for nurses entering high specialized areas like cell therapy. But we have also to understand who are the main stakeholders of this pathway, who actually delivers this kind of education. And here we can find the answer. A wide range of professionals contribute to nursing development, starting from clinical educators, preceptors, academic faculty, advanced nurse practice, and also unit leaders. This multidisciplinary involvement ensures that nurses receive consistent guidance across different learning environments and also at different times of the career. And speaking of environments, I provide in this slide some examples of where education is performed. In fact, learning can happen everywhere. At the bedside of the patient, at the nursing stations during the shift, in university, at home, and also increasingly in simulation centers. Academic programs provide the theoretical base, while clinical settings usually allow nurses to refine their skills in real time and in safe environments. But to maintain high standards, we also need a structured evaluation. So we also need not just somebody who has the competence to teach, but also somebody who has the competence to evaluate if the standard is achieved. Competence must be assessed on a regular basis. Annual evaluations help maintain quality, while new staff usually benefit from structured checkpoints at 1, 6, and 12 months in San Rafael experience. In fact, we had designed a mentorship program which has these specific checkpoints. Clear job descriptions, but also ethical frameworks and standardized exam help ensure gold standards of competence. One example of standardized exam is the very new experience of EBMT. In fact, at the last annual meeting in Madrid, there was the very first exam for nurses that can help to assess competencies and also to give value to our job. Learning could be also be facilitated through team building and the regular nursing training need assessment. But it isn't so easy. To design effective training, we must first understand what the nurses actually need. So there is also the need of a target assessment. In this table, we can see some example I provide to better understand this nurse assessment need. Across the oncohematological field, the rapid expansion of advanced therapies has intensified the need for robust, standardized education for nurses, whose roles are central to ensuring safe and effective patient care. Some papers outline the complex clinical competencies required for new therapeutics and also highlight persistent gaps in nurses' confidence and access to structured training. So we have still some gaps and some difficulties. The increased complexity of treatments demands not only technical proficiency, but also multimodal skills such as toxicity recognition, interdisciplinary communication, and patient and family education. Yet, training opportunities are not mandatory, unfortunately, across institutions, leaving many nurses without the preparation needed to meet the evolving clinical demands. Collectively, the literature underscores an urgent need for harmonized, accessible, and practice-oriented educational pathway. Why? Because we need to support our colleagues, nurses, as frontline providers in an increasingly sophisticated therapeutic landscape. Educational needs fall into 4 main areas, always according to the Bloom's taxonomy I was mentioning before. Starting from clinical knowledge, as you can read in this slide, practical and procedural skills, psychological and supportive care, organizational and standard of care issues. Now let me share how we have approached these strategies at San Raffaele Hospital. So in this slide, I talk about our experience in Italy. At our institution, we've developed a mentorship booklet to guide the new nurses through their first month. We are building also a dedicated social media platform to share educational content and updates. And we have also created instructional videos on essential procedures, helping standardize practice and support nurses during busy shift. For example, another experience is the Tanzanian experience. And since 2019, we have been promoting through a no-profit organization, Tanzanian nurse training for the opening of a pediatric bone marrow transplant unit. Finally, let's look at where we are heading. So I would like to conclude with some sentences, some take-home messages. Caring for patients undergoing advanced cellular therapies requires highly specialized preparation. International surveys consistently show gaps in training, in confidence, and institutional support. To address these challenges, we need harmonized training programs, more simulation-based learning, stronger education on toxicity management, and greater recognition of advanced nursing roles. As therapies evolve, nursing education must evolve with them. Investing in nurses means investing in patient safety and better outcomes. Here are the references of my presentation, and thank you for your attention. I am open to some questions. Hello.
Holistic approach in giving your nursing education. I cannot find a single thing to delve into. But in your experience, what are the usual challenges that you encounter when you start giving your education? Though you have given all the approach, online, podcasts, simulation, mentorship, peer mentoring, do you still encounter challenges? And if there are, what are those?
Thank you for your very interesting question. The main issue isn't about the way to educate the new colleagues or the newly graduated nurse. The main issue is about the support of, for example, the institution, because education is performed during the shift, usually. To train nurses, senior nurse should work, should take care of the patient, and at the same time should train also the new grade nurse. So the main problem we find in everyday practice is time. We lack of dedicated time out of our shift. But we are working on it, and we are trying some strategies, as I was mentioning in the presentation. For example, now in our mentoring program, we have some permissions. So the mentor can stay outside the shift. So the mentor doesn't take care of a group of patients during the mentor shift, and can dedicate his time to only train, to only educate the new nurses. So we have, moving on, we have this well-structured mentorship program that is very useful, very helping us to perform a better training. Of course, the other issue is that education and training performed in a self way at home, for example, isn't recognized in the working shift. So people should study by themselves in the free time. So somebody isn't so committed to spend the free time in studying and in go in deep in bone marrow transplant areas, in hematology area. So we see that at the evaluation point, somebody isn't well prepared because maybe some steps aren't followed in the right way. But I think that every center should find a very tailored strategy that can be effective.
Okay, thank you so much. That's great. Next speaker is Suha. Suha Al-Kharesat is an experienced nursing professional with over 27 years in healthcare field. Throughout her career, she has demonstrated a strong commitment to patient care, clinical excellence, and continuous professional development. For the past 10 years, she has specialized as an adult stem cell transplant and cellular therapy nurse coordinator, where she has played a key role in managing complex patient cases. Her career reflects detection, leadership, and passion for improving patient care in the specialized field of stem cell transplantation and cellular therapy. Ms. Soha, mic is yours.
Thank you so much, Mariam, and good afternoon, everyone. Now we will start with the live presentation. Thanks, first of all, Happy Nurses Day for all of you. Even this is our week, so we should be proud, all of us, of taking care of the patient, especially with advanced treatment. And my presentation will be so simple regarding what is about leukemia and multiple myeloma. So I hope you will get at some information, especially the latest update for the treatment of leukemia and also when we take these patients for transplant. Okay. Yeah, okay, back. This is actually my learning object. We will define the disease framework. We will talk about mechanism of transplant, evidence-based selection of the patient, and the clinical surveillance of the patient. So what is the leukemia? We usually, all of us, we working with hematology patients. Most of our patients, they have leukemia, lymphoma, right? What is the leukemia? The leukemia actually, it's a cancer in a blood form tissue. This is the most important to know. And it's primarily usually in the bone marrow, causing overproduction of abnormal cells, white blood cell. This we call it, the abnormal cells, we call it a blast cell. So it is they usually diagnose percentage, how much percentage of these blast cell in the bone marrow. Usually the first signs of the patient, he will have fatigue, he will have infection, easily bleeding. Because that, sometimes patient will come, when he come for the complaining of fatigue more than 2 months, 3 months, or sometimes easily when he bleeds, it's hard to stop the bleeding, and fever, all of these. So it's categorized, the leukemia, it depends on the fast it's growth. There is kind, we call it acute, and there is kind, we call it a chronic, and all the type of cell affected. So the acute, what is the acute? It is AML and ALL. AML and ALL, it is fast growing, which is aggressive, and it's required immediate treatment. The moment you transplant the patient AML, even the patient midnight, weekend, they do excellent fast to assist the patient to start the treatment directly. They don't wait for the acute stage, which is AML or ALL. AML is effect in myeloid cell, ALL it's effect in lymphoid cell. Usually AML, you will find it with the adult, really to find pediatric has AML. But ALL, most patient actually with a pediatric, and also some elderly patient, they will come with ALL. For the chronic phase, which is slow growing, we call it CML or CLL. Why slow? They are still function, but function poorly. They don't produce, they don't act as a right way, as what is the body need, which is commonly CLL and CML in the adult patient. You will never see pediatric is diagnosed as CML or CLL. There is another part, we call it about bone marrow failure, which is MDS. All of us, we heard about the MDS. MDS, it's malformed in the cells. The cells, the number of cells is right number, but the way the function is malfunction, which is often, we call it pre-leukemia, because usually most of the MDS, if they are not treated or not controlled, they will be transformed to AML. There is a quick comparison table about, we have AML. AML, what's type of the cell? Myeloid cell. Primary audience, usually adults. Key, fast-growing, area rod, often present. ALL, lymphoid, male children, most common childhood cancer, it's aggressive. CML, as we said, myeloid, middle age of the adult. Philadelphia chromosomes, there's 3 phases of the CML. CLL, lymphoid, early adults, adolescent actually slow, often found by chance. Usually you will never diagnose CLL just only by chance all the time. MDS, it's mixed, myeloid and elderly adults, as we said, ineffective blood cell productive, and they will come with low count. The diagnosis, usually how we diagnose, all of you know, usually CBC, blood smear, bone marrow biopsy, and cytogenetic. AML, this is the type of the treatment of the AML. We have 3 categories. They classified the AML 3 categories. They call it favorable risk, which is when he has, you will see sometimes the doctor, they wrote AML, favorable risk. He has NMB1 mute with or without flat 3 ITD, CEBA, and also invergent 16. Intermittent risk and advanced or adverse risk. There is no high risk, they call it adverse risk, which is complex karyotype, TB53, ASX1, RUNX1. So these type, when they classify these patients, when we refer them for transplant, for favorable risk, it is not totally deferrable. It's not really need to go for the transplant if he is in CR, okay? Or he is sometimes, unfortunately, sometimes the patient, they will relapse, they will refractory for the disease. That the time we will take them to the transplant or relapse. For the intermediate, HSCT actually is kind of recommended, highly driven by MRD status, usually if MRD positive or negative. Sometimes you will find patient morphology in remission, MRD positive. This will tell me I should take this patient for transplant. The other things about this patient also, the availability of the donor. If he has a full match donor, I will take him for transplant. But if he doesn't have, sometimes we do not take him for haplo or for MUD. Since he does have match donor, we will take him. But also still, it depends how he responds after he received the induction. The adverse risk, this is strongly recommended for allostem cell. The moment he will have in CR, you should take this patient directly for transplant. ALL actually the most powerful trigger for this, MRD. The predictor for ALL, MRD, if the MRD positive or negative. As we're saying in B cell and T cell, it should be the MRD. If the patient's CR and strictly indicated of high feature, Philadelphia positive or Philadelphia-like, MML, hypodeblipidemia or persistent MRD more than 0.01, that the time after he received the induction and consolidation, because it depends, sometimes we're using different, sometimes after induction will be positive, but after consolidation he will be negative. This patient, we do not take them for transplant, especially the B-cell ALL. If they, after the consolidation, he is positive, that the time I will take him to a transplant. In 2026 now, there is a bridging. This is the EBMT highlighted using blinatumomab. Any patient has positive MRD with ALL, you should give them blinatumomab as immunotherapy, as bridging to clear this patient prior he reach the transplant, okay? And actually it's showing much significant improvement in the survival rate. So then we will come to the CML or the CLL. Actually, the core treatment for them, there is a lot of target therapy for the CML. It's reduced the requirement for the transplant. So it is really will be the last choice for them to take them for the transplant. When I will take the patient who is diagnosed as CML for transplant, first of all, TKI inhibitor failure. TKI and failure, it doesn't mean one TKI, there should receive 2 minimum TKI. If he failed these 2 TKI or he could not tolerate it, this TKI, because some patients, they cannot tolerate this medication, or he progression in top of his taking the TKI. So these patients at the time, I will take them for the transplant. Or he has the T31F1 mutation, which is ponatinib resistant. You will see patient ponatinib resistant. This time, I will take him to the transplant. Or sometimes he is CML, but he comes with accelerated phases, or he has a plastic crisis, okay? This time, I will take them for transplant. For the CLL, extremely rare to take the patient actually for transplant, restricted for also, they will be refractory to BTK inhibitors and venetoclax, TB53 abbreviations, and with progression or Richter transformation. With the Richter transformation, because sometimes you will have patient Richter transformation, before they used to give a choices for the auto. Now auto is strictly not recommended for any Richter transformation. As you know about transplant, we have auto stem cell and we have allo stem cell transplant. Auto, we are own patient cells, and the mechanism we are treating the patient, we will collect the dose what we need, and also, but the good thing for auto, he doesn't have any versus GVHD or something, but he has high risk for disease relapse, right? But the allogeneic, it need a donor, HLA matching donor. It is mechanism immunotherapy, relieve the graft versus the tumor, and we have GVL. You will heard always they will saying there is a GVL. GVL, it's the effect of the GVL because it is clear the residual disease. Because you heard sometimes it's better the patient let him have GVHD because then I want to increase the GVL. GVL, it can control the disease. Okay, so it is, as we know, all of us we know, unfortunately, allogenic has always there is a risk for GVHD. Okay, but most of the time, if thanks God, with all these new treatments, every day we have a new treatment, it's curative. Eligibility. Before, as you know, we used to put a cut-off age, right? But now there is no age. Limited for transplant, no age. The most important, they focusing in the heavily of performance status. If between 0 and ECOG, between 0 to 2, preferable, and the comorbidity score. Sometimes young age, but the comorbidity score high. So I will defer him from the transplant, right? So let's say he came 70 years old, he is fit, his comorbidity index low or 0, so I will take him for transplant, okay? Organ benchmark, also the strict organ function baseline must be met prior the clearance. Usually the GFR, they said more than 30, and the LVEF is more, left ventricle function is more than 45%, and also social support is confident as a critical factor for both transplant and safety and shared decision making. As you know, we are living in Riyadh. Actually 50% of our patients out of Riyadh. If they don't have a family support and social support to stay in Riyadh, it will make a major effect, a major role in the decision of take this patient and the transplant. And we sometimes decline or defer this patient because he doesn't have any social support or family support. Now, this is about my leukemia. We will move to multiple myeloma, and it is multiple myeloma. It's really a huge number of our patients. Now we have multiple myeloma diagnosis. So multiple myeloma, I will talk about just overview and the risk. How they criteria to diagnose the multiple myeloma. As you know, there is International Myeloma Workup Group. They put criteria for the diagnosis. They requires clonal bone marrow plasma cell. The clonal plasma cell should be more than 10%, or biopsy proved there is a plasma cytoma plus one of the following. There is a CRAB criteria and there is a SLIM criteria, biomarkers. A CRAB criteria, the calcium more than 11, the renal creatinine less than 2 milligram per daily, or creatinine clearance, it's less than 40. Anemia, hemoglobin less than 10, and or 2 below normal. Bone lesions should have one or more than one bone marrow lesion. The SLIM biomarkers, 60% clone plasma cell cytoma, light chain ratio more than 100, MRI more than one focal lesion. And also, depend on what is the you diagnose what the patient has, they staging, stage 1, stage 2, and stage 3. It depends. And also they put overall survival depend on the diagnosis staging. If the patient is stage 1, they consider around 80 to 82%, the patient can 5 years alive, overall survival. Stage 2, it's a drop to 62%, and stage 3, it's between 40 to 40%, the 5 years survival. As you know, myeloma, it's not a curative disease. Just only we are prolong the safety to not progression disease, okay? High risk category, which is deletion 17p, this is the things you will find it in the bone marrow and the cytogenetic for you. And also sometimes you will hear double hit or triple hit, which is more than 2 high risk abnormality. There's actually donated a very poor progression. Multiple myeloma, this is the standard gold of the treatment. As you see, the front line for a transplant, eligible patient now, if you see, it is quadruplet, which is DARA RVD. Before DARA, we use it when the patient is refractory or the patient failed or progression or these things. Now they frontline treatment because it is reach 95% CR rate. So the quadruplet treatment, DARA RVD. Before some doctors, because also DARA availability and disease, some people, they still keep the DARA second line treatment. So they give a triplet RVD, which is that before that what they use, which is decreased the CR rate to 78%. The old it was VD, so it's 45% the CR rate. So, and the autologous stem cell transplant is still a standard treatment for the multiple myeloma. He will finish the treatment, he will go for the transplant. As we said also, myeloma, you can take patients 70, 75 years if he is fit and he is comorbidity index, it's low, all of these, still we can take the patient for a transplant. The core inside, you need to understand, as I told you, the stem cell, it's not curative. It will not remove the plasma cell, but it will delay the progression rate. Survival rate. It will be delay. So can be survival 2 years, 3 years, 4 years, it depends. Before they usually saying, because they used to use the old VD, they said it's 12 to 18 weeks to 18 months post-transplant. They will be sure the patient will come as a relapse. But now it's coming after, it's becoming more. It's reached 5 years. Before also, if the patient relapse after auto, we used to take them for allo. But now there's a lot of new novel agent, a lot of treatment, and there is availability of the CAR-T. It's make allo, it is not really preferable. And actually what they transplant, all the myelomas, they found it is no benefit, no different in survival rate. It's still the same. So as we see, myeloma, usually we give them induction, 4 to 6 cycles. After 4 cycles, after 3rd cycle, they do assessment if the patient doing well. Then they will take the patient for stem cell collection. They collect the patient, cryopreserve. Usually, we're targeting 4 and above because this is, as you know, still until now, most of the myelomas physicians, they still believe they will ask you to collect for 2 transplant. As you know, tandem is 2 transplant, but even it is less, but it still will be do. Then auto stem cell transplant yield deeper, rapid response, and as I said, longer progression-free survival rate. Delayed transplant, actually, it still can be, but it will less the survival rate. Then the maintenance, all the transplant, post-myeloma, post-auto transplant, they need to be kept on maintenance, which is usually do lenalidomide. We will continue until the patient has progression or intolerance. This is about the, usually بالمyeloma, you don't need to reach the CR for prior transplant. Sometimes BR, sometimes they call VGBR, CR, and also sometimes minimum residual disease. I will be fast because my time is out. You see, now before they saying transplant, as now, thanks God, we have CAR-T. If the patient from the 1st to 3rd line, prior lines, he's relapsed, all the committee, they are suggesting to go direct to CAR-T. 70% they recommended to go for CAR-T, not even auto. If you see cell to cell, it's available now, and we can take the patient for the CAR-T. 15% is still they saying to go for auto, and 15% they are saying to biospecific or clinical trial. Okay, as we said, is allogenic is limited rule, and it doesn't change the benefit, and the mortality rate is higher. This is also, we already saying about tandem consolidation and maintenance. And the long term, usually day 30, we wait the patient for engraftment. Day 100, we stay the protocol. We start maintenance. For the myeloma, we give lenalidomide. For the AML, if he is FLAT3 positive, we will start IDH, and also the vaccination, and we send the patient after 2 years, we start searching for secondary malignancy and all over maybe hypothyroidism, endocrine, and these things, dysfunction, the other organism. For your nurses, you should CAR-T, you should be worried about the CRS and ICANS, GVHD monitor, and the cytopenia care. As we said, this is a universal principle. We should have multidisciplinary consultation is essential to decide this patient go to CAR-T, go for transplant, or he is not fit for transplant. Okay, as we said, this is the indication, as I mentioned earlier for you. And this is just as a discussion, like a geriatric assessment myeloma. How do you approach the transplant conversion with 72 years old, newly diagnosed multiple myeloma, demonstrated a good function status? As we said, age is not a matter, so he has a good performance, so I will take him for transplant. The risk-wise benefit in AML for patients presented with intermediate risk AML in CR, fully matched sibling donor, what specific factors influence your recommendation for or against allo stem cell transplant? As I said, I have a fully matched donor, why not to take him for transplant? If I don't have, no need to take him for transplant, the intermediate risk, okay? The cellular therapy distribution, it is an emerging availability also. There is a CAR-T therapy, there is biospecific antibodies, all of these alternatives to not reach to use that transplant. This is my reference, and thank you so much.
Thank you so much for the nice talk. Any question? Okay, I have one question for you. How do you see cellular therapy changing future in hematology? Future in hematology.
Actually, stem cell, it will be... okay. Actually, it seems stem cell, it will be less requirement with all of, as I said, we have CAR-T, we have gene therapy, genetic also now. So the auto, it's more or less. The allo still actually, it's still required, but also all of these coming environment. You don't know, every day we are seeing the biospecific sometimes of novel agent, they helping the patient instead, because as you know, stem cell, it's a lot of complication and the long-term survival with all the secondary malignancy, all the dysfunction, it still has really, it's not a good. Usually, I'm usually saying about the allo stem cell, free disease but miserable life, because long term, patient will, its whole life he need to coming these things. Okay. Anything else? Any question? Yes.
Suha, thank you so much for that presentation. 2 questions: AML and myeloma. For AML or leukemias, going for transplant, you have mentioned that it will be tackled in the multidisciplinary meeting.
Yes.
How strict is the compliance of your patient in here? For example, only like if they don't take their medication. We know the allogenic is a long process. It's a long journey. Do you really defer them for transplant if they show that they are not compliant with their medication?
Yes, actually the moment when because we have a weekly discussion, all the patient, the coordinator who is responsible to this patient, he will say this patient actually is not coming, not compliant with his medication, not compliant with his appointment. You need the patient to have a long survival, these things. If he's not compliant, 1 or 2, 3, talking to them, the doctor, the consultant, his MRD, they will talk to them, the coordinator, they will talk to them, stem cell consultant, he will talk to him. If he's still the same behavior, yes, we defer the patient.
Okay, so I'm impressed if the doctor listened to the nurse saying that this patient is not compliant.
Yes, we
They
are
take your
saying and we document. You know, it's not it's a big decision to defer, as the patient sometimes he require transplant. You show, and also we document that in the patient file.
Okay, all right. We will learn from that experience, Suha. Second one, on the multiple myeloma. So you mentioned about cilta-cel, the CAR-T for the multiple myeloma, rather than like for a plasma cell leukemia. Okay, so plasma cell leukemia, let's say you have a young adult female patient, let's say around 40, good performance status, have a good response, BGPR to almost CR after 4 cycles of DARA VRD. Do you, what does your organization does? Do you go to cilta-cel or you go to auto?
First of all, cilta-cell, he should have a disease.
Okay, so
multiple myeloma for auto, if he has BR or VGPR, I will take him for transplant.
Okay.
For the CAR-T, we put it for refractory or persistent disease.
All right. What about oligosecretory?
What is it?
Oligosecretory multiple myeloma.
Yes.
The patient have a stable disease, but there is a disease. Okay?
Yes.
Now, oligosecretory doesn't come out the biochemical markers, kappa lambda, no M-band, but in CT scan, and sometimes even in the bone marrow, hit that part of the marrow that there is the patch of the plasma cells, then you can say that there's an increase. Now, you're saying currently because it's very
I will
costly.
give you an example. We have a patient actually, biomarker improving significantly. Bone marrow, there's no plasma cell, but MRI is still showing he has lesions,
Yes.
multi-lesions. So we'll take him for CAR-T. Okay, so it is depends. Stable disease, that means he's not responding, but he's not reprogression.
Sahih.
So the decision will be, as I told you, multidisciplinary. We have CAR-T committee, all the physician with the myelomas physician. They will discuss what is the good, what is the benefit for the patient. The moment they will decide, well, which is actually CAR-T, cell-to-cell, it's a tremendous survival rate. Yeah, more than 95% for cell-to-cell. So I will give this patient for a chance, as he's young, as you're saying, young. Why not to take him for the CAR-T? And this is what actually doing. We take them for CAR-T.
Okay. So I guess we will refer to patients then here.
Welcome.
Thank you.
Yes, Mr. Bashir. There is a mic for Bashir. Sorry for the next. I take your break time.
Okay. Thank you very much for your presentation.
You're welcome.
As you know, BMT, the main purpose is for curative. So
Yes.
as I mentioned, for lymphoma and leukemia, we achieve complete remission. But what is the reason behind that the myeloma is not achieving complete remission? If they are not achieving complete remission, what is the extent of involving them in these difficult procedures, cytopenia, and later on, just a quality of life? Or else, why can't they not go direct for the stem CAR-T cell?
What is the last thing?
I said, if at all they cannot achieve complete remission.
Complete remission, I cannot take. Cell to cell, the cell is fighting the leukemia plasma cell. You know, there is no plasma cell, nothing for him. So why I should give him CAR-T? CAR-T concept of the CAR-T in ALL, in AML, in ALL, in lymphoma, myeloma, it's fight, they generate the cells to kill the disease cells. Not to just to give it and that's it. No, because this is the concept of the CAR-T. CAR-T, they make it smart, they generate it smart to kill the tumor cells. This is the concept of the CAR-T. How I will take the patient, he doesn't have disease. What is the CAR-T will do in this patient? Nothing. But why we said in myeloma, no need to reach CR prior transplant. But it doesn't mean I will take him with the full disease. Small burden of the disease. Small burden. If more than 75% of his disease is gone, that I consider him, he's really partial. More than 90% VGPR, I will take him. This is why my category. And this is before CAR-T. Now we are really, even if he has, we look to the case, the whole case. Now, if he is age young and he is 50%, let's say he responds. No, I will take him for the CAR-T if he has any benefit of the CAR-T. You get it? Actually, cell-to-cell, maybe CAR-T, it will be replaced, the transplant, if the patient, even if he has low burden of the disease. Okay? Because now it's considered after the first line of the treatment, you can take the patient for the CAR-T, because before it was considered after 3 lines of the treatment. But actually, I should not talk about the CAR-T. I have my other colleagues, they will talk about CAR-T therapy. Okay, thank you so much, appreciate it.
Well, we'll have 5 minutes break.
Maram Haddad. Maram Haddad is a detected clinical nurse specialist in King Faisal Hospital Research Center in Riyadh, specialized in oncology and bone marrow transplant. Maram received a prestigious DICE award in 2022, and she holds multiple certification in process improvement, patient experience, chemotherapy administration, and palliative care. She's commitment to advancing nursing practice and improve patient outcome across the complex care setting. She will present for us the enhanced transplant rate in a sickle cell disease patient. Welcome, Ms. Maram, mic for you.
Thank you so much. Thank you much. Thank you so much, Suha. Appreciated. Good afternoon, everyone. It's my pleasure to be here. I would like to thank the organizational committee for their invitation. To show our project, what we do with sickle cell disease patients, it's have significant impact to affect the transplant rate for our patient. So hopefully you have a benefit from our presentations. Okay, let's start with looking for and understanding the landscape of sickle cell disease patient here in Saudi Arabia. We know the sickle cell disease patient is a hereditary disease who affect the hemoglobin S mutation, which causes chronic hemolytic anemia, vaso-occlusive crisis, infection, and sometimes it can lead to organ damage. طبعا incident in Saudi Arabia, we know it's very high incident in Saudi Arabia because it's considered of the most common hemoglobinopathy disease in Saudi Arabia, which really it's make burden because we have higher career rate, so we have made big population, and most of them, they are really young. So we want to focus on that group because we know we don't have attention in that group really from other services. We know it's really burden in our country, or in the Saudi Arabia. So, okay, we say we are in highly demand, so always the highly demand, it means there is many of challenges. So we have many challenges how we transfer or do the transplant rate for sickle cell disease patient. With the challenge we face, actually, always we have imbalance between the demand and the capacity. Always we are facing, and we don't have capacity to accommodate this huge number of patients. So, we have a long waiting list. I don't know if the other hospitals do the same. Since I joined them, I started to log out all the patients to put them in the waiting list. We have more than 500 patients waiting list to be transplanted. Scheduling and constraints, طبعاً we know sometimes we don't have donor, some patients they have many donors, and the pre-transplant workup time. Really, we are facing problem with the pre-transplant workup time. Why? Because we have a limited time, and the patients, they have I will not say non-compliance, but when you book the patient for workup or PFT or some workup you need it for dental before you start, the patient will have vaso-occlusive crisis, and he will be going to emergency to take his painkiller, and his non-compliance. So that it make the time for we are doing the workup is really prolonged. More than like when you have a plastic anemia, when we transplant a plastic anemia, within 1 to 2 weeks, or the workup is done for them. But the compliance of that patient is really take more time with the workup. So we need also careful priorities for that patient. For some patient, we give them priority. Why? We have multi-acute chest syndrome, multi-admissions. They are really suffering a lot, sometimes admission ICU. So that patient, we give them priority to save them life. Also the cost. We know also when you do donor for workup, we already have a cost in the hospital. Our key messages to increase the sickle cell disease transplant demand require efficient priority, capacity planning, and streamline the pathway for the transplant. So, look like now where is the problem? We want to look where is the bottleneck. If we can focus about our problem is minimum hospital stay. We need higher transplant rate because we know we have a 500 patient waiting. So what we do, actually before we admitting a patient in the inpatient for 3 to 4 days just to do the line insertion, outpatient, RBC exchange in inpatient, then we'll start the patient conditioning. So what we do, طبعا that one is lead to prolonged hospital stay and higher cost على الhospital. So what we think about, we need to shift the modules as outpatient modules. So we know some hospitals, they are doing that. So we are facing no one to do this one for sickle cell disease patient because it's more safer to transplant them as an outpatient. So the outpatient modules, we want to discharge the patient early as well to be following in the BMT drop-in. So to put that, we want to put a smart aims to help us to achieve that goal we put. So we put to decrease the average length of stay for patient in inpatient, for eligible matched sibling donor. When we have a data and we collect the data, we find a patient's length of stay in inpatient 42 days. Imagine each patient, we transplant him and we admit him, he stay in hospital for 42 days. It's really so much long time, and we don't want to make it, and we put target to be at 29 days. So, and we started that one in Q3 of 2025, and we want to sustain for improvement. Any project or anything or any idea, you want to do it, you want a team, you want a strong team, multidisciplinary team to achieve your project. So really, we are building our team who really multidisciplinary, from nurse practitioner, from physician to modify our protocol. And we have also a coordinator, we have a nurses, we have a clinical pharmacist who help us to achieve that. So let's have a look for our the process when we had met the patient. In day 1, in level 19, day 2, we do the line insertion. Day 3, we do our RBC exchange. Day 4, we start the chemotherapy. Until the patient will reach day 42, patient will be discharged and having twice weekly appointment until reach 100-day post-transplant. See, it's so much longer process. It's so heavy on the patient, and really it's take long time and slow. Okay. If you want to achieve anything, we do the structural improvement methodology. We use that Institute Healthcare improvement modules to achieve our sustainable goal plan. So when we think, we analyze our problem, we analyze the drivers. What's the driver they cause to achieve our aims? What's the driver? First is insufficient pre-BMT process coordinator. So what we do as an intervention, coordinator will be assigned to do the line insertion outpatient, the RBC exchange will be done outpatient, a package ready with the roadmap, with everything to the inpatient upon admission. When the patient will be admitted directly, we'll start in chemotherapy. So we see 3 to 4 days minimum. So prolonged recovery post-chemotherapy, the patient can stay a long time in the inpatient after he receiving the chemotherapy. So to enhance that one, we measure hemoglobin S in day 0. If the hemoglobin S is good, we monitor the ANC and the platelet. If the platelet more than 20 and the ANC is more than 1 for 3 consequence days, we add GCSF in day +7. So this modified protocol we use as a standard protocol after then. So the patient will be easily fast recovery after the chemotherapy. So underutilization of the nurse practitioner in outpatient setting, we provide appointment before twice weekly. No, now if we discharge the patient early, we need to utilize the outpatient setting. So we book the patient's daily appointment with the nurse practitioner who cover post-BMT drop-in to see if the patient will need to be seen daily, they will give appointment daily with the consult of the MD. If the patient will be shifted twice weekly, they will shift the patient twice weekly up onto the patient condition. So great, let's have a look for our new process after we apply our intervention. Now, most of them is done as outpatient. We insert a line as outpatient. If the patient have a good pain, we insert a line in the ICU. If the patient doesn't have pain, if he have a vein, we will do the RBC exchange via his vein. When we admit the patient, if he have line, we already going for starting chemotherapy directly. If the patient doesn't have line, we insert line and we started chemotherapy in the same day. But most of the patient, they will not have a vein and they will go for the second way. So in the outpatient setting, when we discharge the patient earlier, we give daily appointment with the nurse practitioner until we can shift them to twice weekly, later until 100 days. So let's have a look for our data. When we put our data, we say our outcome measures, we have a process measures. If we have outcome measures, we put the target to reach 29 days. طبعا alhamdulillah, we reached 23, 24. Some of the patients, they have really early engraftment. Okay, our number, our process major numbers, we targeted to reach 70 transplant rate that year, 2025. Sorry. Okay. So our outcome, when I would tell you, it's go beyond the average length of stay really, because we increase also bed capacity, we decrease the cost, we increase the patient also experience our satisfactions, and really it's remarkable if you can see from our data when we go to November 2024, average length of stay for them is 45 days. And when we start to implement the ideas in June 2025, it's decreased from 32, 33, we reach also 26 in October. This is, I'm telling to you, is the average. It means some of patients, we discharge them in 20, sometimes 18 days. But when I tell average, because some of the patients, they have many complications, some GVHD, so they take long time in the hospital stay. But this is average, which is very good. Okay. This is, I'm telling to you, our project impact. See, it's really remarkable, the outcome, because when we go before in 2023, we transplant only 20 patients sickle cell disease. In 2024, we transplant 40 patients sickle cell disease patients. In 2025, we reach 72, which is great. It means we started just from the end of the year to implement that, and really the number is remarkable. Okay. If you want to sustain or make this success continuous, you want to put a monitoring method plan. So really we mention, and always our data is monitored and mentioned by BMT office team. We also sharing our quarterly report in BMT leadership meeting. A sickle cell disease waiting list is still, mashallah, it's moving now. This is one of the impact too. And our list started to be moved, and it's really good for satisfying the patient when they will come to ask you, what's my number? And last year, on my 150, your number is now 70, which is make them sense like their number is coming to do the transplant. Okay. So the sustainability is the key. Always, if you want to do anything, you want to sustain it. For us, we always look for improvement. We know this type of patient, they don't have too much focus on them, but really they are really very demanding patient. They need to look for their priority to do the transplant for them. So our modified protocol with adding GCSF now is a standard protocol. We use it for all patients. More and more patients, they are recruited in that project. We conduct a monthly meeting for resolve any clarity. We share our achievement in BMT monthly multidisciplinary meeting. We enforce also the new process among all physicians to sustain that plan. So our thinking now, inshallah, we will expand the project to do all the chemotherapy as outpatient. We are struggling with some issues, but this year, inshallah, we expect it to increase their numbers more than 120 to sustain this process and make this project is really remarkable. So in that, I will end, and I will thank all of you for your intention, for your collaborations. Really, that patients need to be focused on, because really you are not giving only an improvement for their process for transplant. We are giving and transforming their future, really, because this patient really, we are doing now research about the quality of life for that patient is really interesting when you saw how much you change their life. From hospitalization, they stay in the hospital, coming for a crisis many times, to normal people, you can see them, they are not coming for their follow-up because really they don't want to come to the hospital. So thank you so much. It's open for any questions.
Thank you so much, Maram, for nice presentation. Any question? Any? I want to ask you, when you do RBC exchange how long prior the conditioning?
Actually, we do hemoglobin S. We measure hemoglobin S. Is hemoglobin S less than 30? We don't do RBC exchange. But most of our sickle cell disease patients, hemoglobin S more than 80. So by default, we already book patient for RBC exchange 1 day before starting the conditioning. To be sure, in hemoglobin S is 20. Mm-hmm. Really, we are measuring, because some of the physicians, they will tell me, I will write the conditioning until I will see in the system hemoglobin S is less than 20. I prove all of them. When we do the exchange, really, it's decreased to 20.
Dramatically.
Yeah, dramatically after the exchange.
Do you increase the hydroxyurea 8 weeks prior transplant?
Actually, we give the same dose of hydroxyurea, but some of the physicians, they give sometimes steroid, prednisolone, 2 weeks prior to the transplant. It's not a protocol of all physicians, but some of the physicians, they give two-week prednisolone before.
Ah, okay. Because and I think you are giving myeloablative condition, right?
Yeah, we give ATG with the flydropine, busulfan.
Yes.
Yeah, and
because our practice is a little bit changed because we are not giving myeloablative, we give non-myeloablative because that we increase the hydroxyurea. Steroid, we give it if the patient have alloimmunization in RBC.
Yeah.
We do this actually. We give if the patient have alloimmunization or and high against especially the donor. At the time we give steroid and we give rituximab actually. Yeah. Any questions?
No questions because
no?
I finished
Thank
early.
you so much. Appreciate.
Thank you.
We will come for the second speaker, Mr. Bilal Al-Bloui. Bilal is a nurse professional specialized in hematology and bone marrow transplant. He has a PhD degree in nursing from the Hashemite University and master degree in nursing from Zarqa University. Bilal, he is a professional career at King Hussein Cancer Center while he's working for almost 6 years. As a BMT nurse and BMT clinical coordinator. He lately joined the King Fahd Specialist Hospital in Dammam, served for 9 years as a BMT clinical coordinator. Now he's working Johns Hopkins Aramco as a coordinator specialist. Throughout his career, he's also participated. He's participated in multiple research projects related to hematology and bone marrow transplant. We're honored to have you, Bilal. Mic for you.
Thank you, Suha, for the intervention. Thank you all. Good afternoon, all. I would like to, first of all, I would like to...
Excuse me, Bilal, your slides and your name.
The slide from... Okay, to consume the time, just let me just to thank the organization team to invite me as a speaker in this event, the SSBMT. This is the second time for me, and I appreciate it. Today, I would like to talk about the nursing experience and care for the patient receiving cellular and bispecific antibody therapies. When I talk about the nursing experience, I'm talking about the knowledge. I'm talking about the information that the nurse must gain to have a confidence work when he deal with a complex patient who will receive cellular therapy by specific antibody. This is me. And I will start with the first of all, I will just identify what the meaning of empowerment, because the empowerment, it will give us to, it provoke us to start with this complex patient. So the empowerment, it's referred to the process to give the nurse the authority and the resource and the confidence to support they need to make the decision, take initiative and lead in the healthcare setting. Without this component, without these three components, I don't think that we have experienced nurse or motivated nurse to deal with a complex patient who will receive cellular or bispecific antibody. All of us agree that without this component, without satisfaction, I don't think that that we can deal with like this patient. So what's the key and the aspect that we must have to have this empowerment? First of all, I will back to the knowledge, the information. Without knowledge, without information about the case that we are dealing, about the disease, about the complication, about the medication, about all of this, about the new generation for the medication, I don't think that we can deal with the patient. If I am a apheresis nurse, I know that when I did the stem cell collection or I did the lymphocyte collection, I will face the numbness. The patient, he will face the numbness. If the patient, he complains from the numbness, I will be comfortable because I know this is one of the complications of the apheresis process. If I don't know this information, I will be panic, and I cannot act with this incidence if I don't have the knowledge. So the education and training, it's with the complexity of the BMT patient, with the CAR T-cell patient, with the patient who will receive bispecific antibody, it's must for the nurses. So this is abstract, this research talking about the CAR T-cell therapy, and it's approved that nursing care and knowledge, it has power and it has impact for the patient who will receive CAR T-cell therapy, and it has positive impact for the patient. And another research talking about the impact of the nursing knowledge and nursing motivation to decrease the length of stay for the patient who will receive bone marrow transplantation and CAR T-cell. This is very important, and I think this is remarkable to you. If you have this, to do the research for your patient, if he has any scoring before, motivation score, if he has this motivation score, if there is any impact for this scoring system for the patient who will receive CAR T-cell or allogenic transplantation, the patient who has less marker, I think he has more length of stay and he has more complication. All of us knows if the patient has low appetite for the treatment or low satisfaction, he will has a lot of complication. Another key and aspect that I will mention, the resource. I will back to the resource, knowledge. And when I mean that, when I talk about resource, I'm talking about the resource, the tools, the physical resource. For the nurses, the equipment. If he has equipment, which means he can do his work. And another things, the evidence-based practice. When he did his work depend on evidence-based practice, he will do it with high confidence. And recognition and respect, it's valuable to do every time for the nurses contribution and to just motivate them to do their work. So the next, I will just mention the environment for the nurses, which means the nurse who handle the CAR T-cell and cellular therapy patient, who will deal with a lot of the teamwork. He will work with pharmacist, he will work with nutritionist, with radiologist, with all this team. If there is any failure in this process, which means there is failure with the quality of life for the patient, it will affect. And adequate of the staffing, if the nurse, he handle 5 patients, 6 patients, all of them, they are cellular patient or they are CAR T-cell patient, I don't think that the quality of work, it will be improving. So the manager, they have to follow the criteria of the patient ratio for the nurse who handle the complexity of like this patient. So all of these components, it will affect the improving patient outcome. As I mentioned before, it will improve the length of stay, higher job satisfaction. Like Magnet, I think a lot of hospitals here, they has magnet professionalism, and enhance teamwork and increase innovation for the nurses. Now I will just go to the very important topic in my slide. I will talk about what's the role of the nurses when they are dealing with the CAR T-cell or cellular or bispecific therapy. Now, the first of all, education. If you don't have that knowledge, you cannot do this part. You don't have the knowledge of the complication. You don't have the knowledge of the medication that you will give to the patient. So how you will give the information to the patient? If your patient asks you, he will see you. He will attend the clinic with the physician, and after that, maybe he will gain only 10% from the information in the clinic because he's confused. When he hear about the CAR T-cell, all of this complication, ICANN, CRS, all of this complication, so he will be confused. Maybe he will gain 5 to 10% only from the knowledge. After that, he will depend on you to provide with good knowledge. I remember we did a YouTube channel for the patient, and we make just a brief with the allogenic transplantation patient, with the donor, the process. And usually we give this YouTube channel for the patient. Please watch it in your home. Then back next day to ask the question. Because the patient in the clinic, he will not be concentrated. He will not be focused. So he will depend on your knowledge to give him daily knowledge, even every day. What's the schedule of today? Describe the potential of the side effects. Same. If you don't have the knowledge, you cannot. If you don't know what the meaning of the CRS, what happened? How can I prescribe the CRS? What's the grade of the CRS? How you will prescribe it for the patient? If the patient has a knowledge of the CRS and the grade, he will collaborate with you. Even okay, I feel that I have a grade 1, grade 2. If the patient he has good information. Psychosocial support. I think this is crucial, and this is also all nurses. They are creative to do this part. I think we have Daisy Award. We have all of these patients. He will write letter what they are doing with the patient. Apheresis and cell collection. This is the first process, I think, with the CAR T cell and the stem cell. It will be the same, the collection of the lymphocyte, but we have here challenge with the CAR T cell collection. Why? Because the number of the lymphocyte, it will be less than the usual number that we are facing with the donor, healthy donor. Why? Because the patient he is exposed to chemotherapy, he's exposed to a lot of therapy that it will deplete the lymphocyte. So it's challenging. So this is the first part, apheresis, administration of the CAR T or administration of the chemotherapy or bispecific antibody. So you will be sure that it's available and all the components, as we mentioned before, it's available, line available, consent available, pre-medication available. And if the medication of any complication that it might happen, all the medication, it's available around. The cell infusion, all of us knows the consent and the thawing, it will be in the door of the patient or inside the room. And you will check double, triple, 4 times with the consultant, with all of the body. You will check this cell, it's back to this patient, and you will verify with all of the team, and you will do the thawing. The thawing, because the cell, it will come from the manufacturer, it will be frozen. Then the thawing, which means back to the liquidity and to give it to the patient, and you have the IV access, because all of us know that it has special IV access. Or usually the patient, he has big line or central line. Cell infusion, as I mentioned, the cell infusion are infused as per cellular therapy administration policy. The patient vital signs are recorded during and following the infusion. All documentation is completed. The infusion is usually uneventful, but intensive care and neurological, they has to be on board, because all of us knows about the difficulty that maybe we are facing after the infusion. So the patient monitor, if I know all the steps And the monitoring, what I will do, this is me. I am panic. Why? Because maybe I saw some symptom for the patient, and this symptom, it's worsening now. This CRS, it's jumped from grade 1 to grade 2, and from grade 2 to grade 3. So the vital sign monitoring, especially during and after the infusion, it's crucial, and especially after the infusion. Why? Because the CRS, it's depends on the vital sign, if the patient has fever or hypotension or hypoxia, low oxygenation, or if there is any neurological event. The two most common toxicity, as we know, for the CAR T cell is CRS, cytokinase release syndrome, and immune effector cell associated neurotoxicity syndrome icons. How we can manage this, or how we can classify the CRS? All of us, we are familiar with the CRS parameter, the three parameter, the fever, the body temperature, and the blood pressure, and hypoxia, autosaturation. Grade 1, if the patient is has only fever, less than 38 Celsius, but he has normal blood pressure with normal oxygen saturation. Grade 2, the patient, he has still fever more than 38, but he start to have hypotension, but not require vasopressor. It's manageable with IV fluid, and regarding the oxygen saturation, require low flow oxygenation, not high flow. The grade 3, it will still patient has fever, and he require vasopressor, which means ICU onboarded now. And the ICU, they are onboarded from the beginning that we have CAR T cell. It's alarming for them because they have to have a knowledge for the CRS and how to can deal with the CRS management. Grade 4, the severity, patient has fever and hypotension, require a multi-vasopressor line, and the oxygenation, it will be low and require high volume with CPAP or BiPAP. So this is the monitoring that we are talking about. Icons also score. We are initial have ICE score. The ICE score, it must be done before the CAR T cell infusion. Why? Because it's baseline for us. Now we are, when we talk about the icon score, ICE score, we will know why we are doing the baseline before the CAR T cell infusion. We have to have the baseline before to compare it if the patient has deterioration from this score or not. If the patient has deterioration, which means he jumped from grade to grade, and he has each step he has a modality of the treatment and criteria to treat this patient. So what this usually the ICE every 8 hours after the infusion, I will check it, and BRN if there is any recommendation of the patient. If I see any change for this patient, I can repeat the ICE score for this patient. But usually, if there is nothing, I have to check the patient every 8 hours after the CAR T cell, and I will compare it with baseline that done before the CAR T cell infusion. This is the icon score. It's from 0 to 10. There is 4 score talking about the orientation for the patient. Orientation, which means I will ask him about the what we are in this year, which year, and it's by more specific the month, and what the city that we have, Dammam, Riyadh, or where we are, and what the hospital are you in, if more specific. So it will start with a big question, which year, then will we minimize it to be which month, then we can minimize the city, okay, and then more specific, you are in which hospital, okay? So if the patient, he answer me for this question, he will get 4 points. Then he will jump to if he can recognize the 3 objects. So any object around you, TV, bin, so it will be familiar object for all of patient. Don't give him object that he don't know about it. Don't give him like bad package of CAR T cell or modifier to give him what is this? He don't know. Of course, he don't know this object. Okay, so and if he knows this 3 object, he will get 1 point. And if he can following the command, he can also has another point and writing. And you will verify if the patient know how to write, because not all the patient knows how to write. If the patient he cannot write, just let him to draw circle or draw any
3 minutes
any
more.
shape.
3 minutes more.
Attention, if the patient he can count from 100 to 10, 119, 18, 70, he will get another point. So this is 10 out of 10 if he can answer all this question, and then I will follow this ICAN score each 8-hour IC score. So this is one of the our hospital, they are dealing with this questionnaire, and it must be filled by a nurse, by experienced nurse, professional nurse. So the toxicity and management, we are talking about CRS and ICAN, which mean treatment of symptom is key nursing rule in the management for bispecific antibody and cortisol toxicity. Patient with suspected CRS require maybe antibiotic and IV fluid. And as a first line treating with the CRS, they are treating with teclistamab and it's monoclonal antibody given IV. And we can give up to 4 doses can be given for the patient at least 8 hours apart. And the second line, corticosteroid, as all of us knows, but it will be the first line for the ICAN because the teclistamab, it's not penetrating the brain tissue, so it's the first line. But we have just to focus, to not just I will focus with this slide, and I just forget to focus before as a pre-medication. CAR T cell, we will not give corticosteroid steroid because the corticosteroid, all of us knows, it's lymphodepleted, and it's against our target, and it will just make a problem with our product. So corticosteroid, we will try to avoid the corticosteroid even, but if it's the complication, it will be grade 4 or severe. Maybe at that time we can give corticosteroid. So also another part for the nurse is coordination of the care, and this is one of the coordinator work to coordinate all of this with the patient, and finally discharge if the patient he has good shape and he's fit for discharge. And documentation and reporting, it's very crucial for this. All this reporting, they must fill the ICE report each 8 hours and before, and vitally it's crucial for all the patient, because it will maybe back to this documentation to know what happened with the patient and how we can deal with this. So this is me, the first infusion. It will give me the empowerment. This is first stem cell transplant, was done in King Hussein Cancer Center in 2010. Thank you very much for your attention, and if there is any question, I am here.
Thank you so much, Bilal. Any questions? Because Bilal, he needs to catch his flight. Any question? Nothing? Okay, thank you so much, Bilal. Appreciate it. Don't forget to take your certificate. Appreciate. We will go for the second. Yeah, clap for him. We will go for the second speaker, Mr. Bilal Abtoush. Bilal, he has a bachelor degree in nursing from University of Jordan. He has experience in nursing since 2005. He was working in King Hussein Cancer Center before he joined the King Fahd Medical City in Riyadh since 2007. He's a registered nurse in hematology and oncology nurse. Then he moved as a nursing supervisor after he joined the stem cell program in 2016 as a nurse coordinator. He's usually working now as adult stem cell transplant nurse coordinator and program team leader. Bilal has a lot of equality projects and also taking active research projects, include phase 2 trials. He has published with the adult hematology and BMT department more than 20 abstracts in international conference such as American Society of Hematology. Mike is yours.
Thank you, Ms. Soha and Ms. Mariam, for their kind welcoming words. Thank you, attendees. I would like also to thank SSBMT committee for their organizing this great event. I will start my presentation about CAR T cell therapy patient journey. This is my outlines. We'll go brief introduction about CAR T, then we'll go for patient pathway, assessment, leukapheresis, washout period, bridging therapy, lymphodepletion, then CAR T infusion. CAR T cell therapy is a breakthrough therapy that has dramatically changed the treatment of hematological malignancies. It's a type of treatment in which patient T cells are changed in lab, so it will attack cancer cells. Usually T cells are taken from the patient blood, then gene for special receptors that bind to the certain antigen of the tumor cells of the patient is added to the T cell. So the CAR T process is multi-step process. It needs coordination, communication between multidisciplinary team, including physicians, CAR T coordinator, frontline nurses, pharmacy, neuro ICU, neurology ICU, apheresis nurses, stem cell lab, and admissions office. In this slide showing that figure A showing T cells and CAR. Once CAR added to the T cell, it will be CAR T cell. So figure B showing the structures of the CAR T cell and how it recognizes the tumor cells. Usually the CAR T cell consists of three domains: antigen recognition domain, transmembrane domain, and signal domain. Once the antigen recognition domain attaches or binds to the antigen of the tumor cells, this leads to activate the CAR T cell as living drug, which leads to attack and eliminate the tumor cells. FDA approved till now 6 CAR T products for treatment different type of hematological malignancies. Like the first one, Kymriah brand name, generic name Tizacel, is for follicular lymphoma, diffuse large B-cell lymphoma, or acute lymphoblastic leukemia. It's for example, follicular lymphoma after 2 lines of if relapse or refractory. The other product is called Yescarta or Axicel. It's given for follicular lymphoma and diffuse large B-cell lymphoma. Then Tecarts or Proxicel. It's given for mantle cell lymphoma or acute lymphoblastic leukemia. Then Logicel for large B-cell lymphoma, and the last 2 products given for relapse or refractory multiple myeloma. Here, what steps are involved in the CAR T cell patient pathway? As we mentioned, the journey for the patient who is planned for CAR T cell therapy, it's a long journey. It's multi-step process. It started from referral centers. When they have one potential patient, they are thinking he's candidate for CAR T cell. So they will refer him for a treatment center. A treatment center, they will do a series of workup to assure that this patient is fit and he's candidate and fit to receive the CAR T cell therapy. Once the team decided that this patient, he will go for CAR T, he will be admitted to collect T cell of these patients. After collection of the T cell, it will be shipped for good manufacturing practice for engineering for the T cells. Usually it takes around 4 weeks. Once the T cells, the engineered T cells return back from manufacturing site, patient he will be admitted again to receive the short course of chemotherapy called lymphodepletion, just to prepare the immune system for the modified T cell. CAR T, it will be infused. The patient, he is inpatient. He needs closed observation. Usually needs 2 weeks, around 2 weeks after CAR T infusion, just for close monitoring, so to detect early symptoms or reaction of CAR T for rapid management and improve the outcome. After day 14, if the patient is clinically fit and he can be discharged but need close observation and follow up as outpatient. For the patient, they are developed significant toxicity, still he needs to extend the admissions. By day 30, we are doing the first tumor assessment. If the patient is responding to the treatment, this means CAR T is okay for him and he's outside Riyadh, he can return back to the referral center. He can follow there, but at the same time, he needs to follow a treatment center just to follow the progress of the CAR T, just to collect also more data or more information about the CAR T to report for the EBMT. This slide very important. we always advise the referral center when they have any potential patient, they are thinking he's eligible or he needs the CAR T therapy, try to refer him early. Why? Because early referral will give the treatment center time to book a suitable time for apheresis, give them the suitable time to choose the best bridging therapy for him. Also, this will avoid to give the patient extra chemotherapy. It can be avoided because sometimes if you are giving extra chemotherapy, this will affect for the quality of the T cells, which may lead to failed collecting of T cell and failed the CAR T cell therapy. Now we'll go for the patient assessments. We'll go from screening, eligibility, clearance. Screening, once the patient is referred, will confirm the initial diagnosis and the relapse or refractory diagnosis. We'll review the baseline information, review the risk status, the performance status. Then the patient will be discussed in multidisciplinary team to check if this patient can go for the CAR T. If the team decided, then the next step will eligibility. We'll review the age because different type of the CAR T, it depends on the age. We'll review the organ function to assure that the organs are adequate to receive this treatment. Then review the performance status. We'll review the neurological history. If there is pre-existing CNS disorder, this needs to be excluded. Infectious status to assure that the infections can be controlled during the treatment. And if there is a presence of CNS disease. So the patient can be cleared once the eligibility is checked and the organs are adequate enough to receive the treatment. No active disease or can be controlled. The patient has caregiver with him and it will be available during the treatment process. And then the patient can be scheduled for the treatment. A washout period. You know, before leukapheresis, before collecting T cells, we need to holding chemotherapy or radiotherapy or steroids, the treatment enough time, so to assure that sufficient number of T cells can be collected during the apheresis, which lead to success of the CAR T treatment. This is an example of washout period. For example, systematic therapy, usually 2 weeks before leukapheresis, we need to hold the treatment, or 5 half-lives of the drug, which is shorter, we can elapse before the T-cell collection. Radiotherapy, 2 weeks, corticosteroid, if the patient receives more than 5 milligrams per day, prednisolone or equivalent doses, we need to hold at least 1 week before collection. Immunosuppression therapy, it's around 1 week. There's special medications, it need a long period of washout period, like bendamustine, like ladrobine, around 3 months before schedule the patient for T-cell collection. Now we'll go for the next step, which is leukapheresis. We prepare the patient for leukapheresis from the beginning. Any patient is planned for CAR T-cell, we need to communicate with the pharmacy to reserve tuzilumab for this patient. Tuzilumab is a monoclonal antibody. It's block interleukin-6 receptors, so can reduce the inflammation. And this is emergency drug for the CAR T patients. Then we'll validity the workup need to be valid within 30 days before the CAR T collection. If the CAR T will be more than, we need to repeat like serology, we need to be repeated. Then if the workup it's within 30 days and all done, we admit the patient to secure central line for the T-cell collections. We advise the patient 24 hours before collection to try to receive good hydration, to avoid caffeinated beverages. We prepare the pre-medication like calcium gluconate. It will be given during collection to avoid, hypokalemia, to avoid numbness, tingling of lips. Then heparin, it will be given during collection to avoid clotted. Then once all this done, the patient can be proceeded for the collection. Next step, it will be T-cell collected. Now it will be shipped for good manufacturing for for genetically modified of the T cells. So it will be used viral vector to express the CAR. So once CAR is expressed, it will be need some time just to cell expansion to achieve the therapeutic dose of the CAR T. The next step it will be quality, safety, and testing. So needs require testing to assure that the safety, purity, potency of the CAR T. After that, it will be returned back to the treatment center. It's ready for infusion. Usually, this process takes around 2 to 4 weeks, especially if we are shipped outside the kingdom. As we mentioned that manufacturing it takes around 2 to 4 weeks. Some time of patients, they need to receive a treatment just to control the disease, not to cure, only control the disease to reduce the toxicity of the organ, to keep the patient healthy enough to receive the CAR T. So the type of a bridge, this treatment called a bridging therapy. It can be chemotherapy, can be radiotherapy, can be steroids, and not all patients needs the bridging therapy. It depends on the patient status. Next step, it's called lymphodepletion. Once the product return back, the CAR T return back from the manufacturing site, patient he will be admitted to receive a short course called lymphodepletion. Lymphodepletion just to prepare the immune system for the modified T cells. The goal of the lymphodepletion just to reduce the T white blood cells or T lymphocyte of the patient, so after infusion of the CAR T the CAR T cell expand and persist and attack the tumors. This is very essential steps for the success of the CAR T. This is the most common protocol or lymphodepletion, usually cyclophosphamide and fludarabine, giving 500 milligram per ml square and fludarabine 30 milligram. Started 5 days before CAR T infusion, given 5th, 4th, and 3rd day before infusion, then 2 days rest. After that, we'll infuse the CAR T. Now, CAR T infusion, as we mentioned, given after 5 days of the lymphodepletion protocol, it's single IV infusions. It must be administered within 20 minutes, not more than that. All the bag of the CAR T needs to be infused, and also it will need to be priming after infusion, priming with normal saline within 10 to 30 ml. Pre-medication is to be given before CAR T infusion. It depends on the protocol of each hospital. Usually, antihistamine, acetaminophen, this is the medication can be given. Once the IV given, patients need for close observations. Because he needs to be attached, he or she needs to be attached to the cardiac monitor, so we'll follow the patient frequently. The ratio, it will be 1-to-1, the nursing ratio 1-to-1, because these patients need close observation. The nurse, her role to monitor the patient in case of any reaction happen, it will rapidly inform the team, the primary team, so it can rapidly or promote management. Tocilizumab is the most important medications need to be given to treat the cytokine release syndromes happen. Then the other medication, emergency medication to be available. Monitoring and early complications. Patient, as we mentioned, the nursing ratio to be 1-to-1. So the patient requires close observation, especially the first 2 weeks after infusions. The key monitoring parameter or key monitoring parameter, we are following temperature, blood pressure, oxygen, immunological status. Here we'll focus for the major toxicity, it's cytokine release syndromes, which manifested by fever, hypoxia, hypotension, and neurotoxicity or ICANS, confusion, aphasia, or seizures. Toxicity timelines, usually once the day CAR T infusion, from day 1 to 3, the early signs of cytokine release syndrome can happen. It's managed by fever. From
5 minutes, 5 minutes, 5 minutes.
From day 3 till day 7, it will be the peak of CRS, like fever, hypotension, hypoxia, and possible neurotoxicity happen. From day 7 to day 14, it will be gradual resolution of symptoms and clinical improvement recovery. The post-CAR T-cell therapy side effect, we can dive into short the first 4 weeks, then the long after 4 weeks. It will be cytopenia, fatigue, neurotoxicity, cytokine release syndromes, infection. And the long term, it will be like hypogammaglobulinemia, infection, prolonged cytopenia, fatigue, secondary malignancies, CRS, and neurotoxicity. How often should patient be monitored in medium and long term? Usually patient from day 30 until day 100. We are talking for the patient who are responding to the treatment. We are following them monthly from day 30 till day 100. From day 100 till 1 year, we are seeing the patients usually from every 1 to 3 months. It depends on the patient. After from 1 year to the second year, we can see the patient 2 times per year. After that, yearly up to 15 years. Here the parameter we are doing or following the patient, we are doing routine CBC, chemistry, viral infection, quantitative immunoglobulin, peripheral blood immunophenotyping, and other investigation depend on the patient conditions. This is my last slide. How should long-term CAR T cells adverse event be managed? Hypogammaglobulinemia, we are corrected by giving immunoglobulin IV to the patients. Prolonged or delayed cytopenia, we're giving immunoglobulin replacement, preventive antibiotic, growth factors. Late onset infection, we do close monitoring and early detection of treatment. Late neurological and psychiatric event by supportive care. Secondary malignancy, if happen, we follow cancer screening recommendation for hematopoietic stem cell transplant survivor. Vaccination, usually the patient post-CAR T-cell therapy after 6 months, we refer them to infectious disease clinic so they can give the vaccines. Thank you.
Thank you so much for your talk. Our next speaker will be Mr. Mohammed Bashir, is an experienced nursing professional with a distinguished career spanning over 3 decades in clinical practice, leadership, and specialized care. Mr. Bashir also contributed to Saudi clinical guideline practice in sickle cell disease and has actively participated in advancing nursing knowledge. Currently, he serves as a clinical coordinator in the bone marrow biopsy, bone marrow transplant, and clinical trials unit at King Saud University Medical City, Riyadh. Mr. Bashir, mic is yours.
Thank you very much for the introduction. I want to use this opportunity to express my thanks and appreciation for the organizing committee to give me opportunity to perform this one. I'm sure some people will be surprised that why am I still talking about building a bone marrow transplant when others are far away from transplant making CAR T-cell and gene therapy. Anyway, as you know, all the bone marrow transplants is the cornerstone of all the transplants. So if you look at Saudi Arabia currently, there's only about 8 centers for bone marrow transplant, and 5 of them are concentrated in the central region. So therefore, bone marrow transplant should be expanded in order to meet the Saudi Arabia Vision 2030. In fact, before I start this one, I want to express my thanks and appreciation for our mentors. What moved us to do bone marrow transplant is that in 2010, we sat down and looked at that almost most of our patients, we referred either to King Faisal, we referred to National Guard, they relapsed before the transplant. In 2 years, we have about 15 patients that relapse. So we sat down with the committee, with the administrators, the coordinators, and the consultants. So our head of department at that time, Prof. Khalid Saleh, contacted the MAM, specialist hospital, Prof. Hani, and then they agreed that That time, I was the head nurse of the oncology center, along with the educator called Mr. Osama. So we went to Dammam and have intensive training for 1 week. On arrival, second week, our laboratory and pharmacy also went. So by 2016, we have started our first transplant. So I want to use the opportunity to express my thanks and appreciation for Annie, who is the BMT coordinator in Dammam that time, and Jennifer, the apheresis that time. So actually, before starting, we have to start with the need of the context. The need of context is what made us to go for the transplant. Why transplant matters? It matters because we have a lot of gaps inside the transplant. So the global need for transplant is so much. So that's why we insist that transplant should be covered. Before you start a transplant, there must be a standard. The standard should be with either the global certification, like GCI and FACT. So once we have the context, we go to the standard, then we move to the readiness. In the readiness, that we make sure we have a standard building material which is available in order to do the buildings and other things. So the next most important thing is the nursing core and leaderships. Nursing is one of the cornerstones of the, nursing is the fundamental and driving factors that make the transplant a success. Once you have experienced nurse, committed nurse, and well-educated nurse, the transplant and all other things will be successful. At the same time, bone marrow transplant, we like it, it's nice, but they have some risks and complications. What are the risks that we have? Sometimes there will be graft failure, there will be some cytopenia, there will be some needs. So therefore, once you have transplant also, you have to think forward. This is what in innovation. Innovation, what should I do in order to move forward? Then also we'll have the impact. The impact is about the quality of output which you will get. Okay, then why bone marrow matters? It matters because globally there's about 150,000 transplants every year. Well, in Saudi Arabia, based on the literature which I went around, it was about 1,000 to 1,200 patients have been transplanted in 1 year. So if you look at globally, there's more than 3.5 million patients living with hematological malignancies. Due to the deficiency of bone marrow transplant center, only about 5% of these patients are able to get transplants. So this one, it forces some patients to travel abroad in order to do transplants. This traveling abroad may cause a lot of financial strain to the family, cultural difference, and a lot of inconveniences. So if we are able to encourage and have enough bone marrow center in the kingdom, there's no need for anyone to travel abroad. Actually, the bone marrow transplant is not only just, it's a curative for most of the hematological malignancies. So therefore, it should be encouraged. So from capacity to credibility, the role of global standard. However, if we want to start a bone marrow transplant center, we have to contact the international body. This international body is that, what do? They ensure the safety and the quality of care for the patient. They make a standard of practice which we can follow in order to go in the straight way. Then competency-based, they will set up a competency whereby we will train our staff. Then the other also is continuing quality improvement program. You know, science and technology are evolving any year, so therefore we will have continuous improvement plan. The core requirement for the building bone marrow transplant center is one, we have to have a specialized infrastructure available before we start that one. Then we have to have advanced laboratory, we have to enough good multidisciplinary team. We should have also prevent infection control measures. Why it matters? The bone marrow matter and the accreditation bodies matters because they reduce the compliance and mortality, they improve transplant outcome, and they enable us to integrate with international benchmark to see whether our transplant is moving in direct or we have problem. And then it's our part of building capacity. So global standards transform BMT program from credible to safe, reliable, and international recognition. As you know, bone marrow transplants unit is not a unit, it is a complete ecosystem. So a successful bone marrow transplant program must have at least 6 of this interconnected system, although there's more than this one. One is the infrastructure which is available. The infrastructure is that it contains about a room, a HEPA filter room, with isolating room, with air filter and ICU. At the same time, also infrastructure, in the emergency units, you have to have a crash bed whereby any patient from post-transplant that can be accommodated effectively. Then we have to have a workforce. The workforce encourages specialized physicians, especially transplant consultant, the nurses, the competence-based training, and continuous education. In the laboratory also, we have to have standard laboratory like HLA typing, stem cell processing, and cryopreservation. So the clinical pathway should be that standard protocol, which will guide us before the transplant, during the transplant, and the follow-up. And we have to have a very good multidisciplinary coordination group. One of the factors that we have to be in condition about the group is that we have to have infection control prevention. That is, they are responsible for protection of the environment, strict isolation measures, and surveillance of any infections which we can expect. The governance and data are very important. The governance, what they normally do, they create a policy and procedures which will abide by it and follow strictly. Then we have to monitor the outcome of the treatment. The outcome of the treatment, the success on this one will help us to plan ahead of time in order to make the budget. For example, what happened to us, we started transplant is that, as I told you, that in 3 years, we maintained about 15 patients relapse when they need a transplant. So when we forward this one to the administration, they were able to accept, and we start our transplant center. Okay. So what is generally this bone marrow transplant and scopes? Yes, this bone marrow transplant is a replacement of diseased bone marrow with a healthy hematopoietic stem cell. So the common one which are available, we have the auto, which is patient-owned cells, and this has a lower immunological complication. And the other one is allogenic. This one has a potential cure, but it has a lot of complexity. Then haploidal also is available, but is not commonly used. The clinical outcome, the survival rate in bone marrow transplant is about 50 to 70%, depending on the patient's condition and the clearance and eligibility. Then the curative outcome as hematological malignancy. As I mentioned, the outcome depends on the disease, patient condition, and donor matching. So, however, there is some limitation. The limitation is that some of the patients are not eligible for treatments. Some of them also have required specialized system. So, as I mentioned, they are not only. So, bone marrow is a high impact, high risk therapy, but it required advanced care. Risks and complication of bone marrow, although it's mentioned by almost all the presenters, it is my pleasure that bone marrow saves life that's why it's created, but it carried a lot of significant risks. These risks demand a vigilant prevention, early detection, and expert management. The major risks which are already been presented by other speakers, however, as you mentioned, graft-versus-host disease, it may be acute or chronic. The earliest, based on the literature of BMT, of European Society of BMT, the GFV, the acute one, about 30 to 50%, and then the chronic from 30 to 70%. So infection also leading cause of mortality and morbidity, but the most important, it can be prevented, not continuously, but the first period that we have to consider is the pre-engraftment period, as well as the first 100 days. And then there might be some organ toxicity like liver, heart, and so on. This may be due to medication and also the condition therapy. Then, unfortunately, also there may be some relapse as also graft failure. So we have to bear this one in consideration. Then haploidal transplant also is another way forward for transplant. Unfortunately, Although transplant is a success, but it has some long-term effects like secondary malignancy, infertility, endocrine disorder, as well as quality of life problem. As mentioned earlier, mortality 10 to 30% depending on disease burden and factors of transplant. What will make us to get a better transplant? It depends on patient selection, that is from the clearance periods and the management, a proper donor matching, infection control prevention, and timely intervention. Then also complications are common. Complications are common, but prevention is early by early detection. The core service of bone marrow, the fundamental of the Safe Bone Marrow program, a high-performing bone marrow program relies on this integrated, high-specialized service, which work together hand-to-hand in order to improve the quality of life. Number one of the most important that we make is that apheresis, the stem cell collection and harvesting, the donor coordination and collection of the peripheral blood cell. Then other things is the laboratory, that we have to have a laboratory which is satisfied by international organization, especially the area of the HLA typing, processing lab, cryopreservation, storage, as well as flow cytometry, whereby we can know the cell viability. And also PCR lab is essential. Then transfusion service. Before having a proper bone marrow transplant, you have to be a proper blood bank, which help in blood components, like irradiated blood, as well as availability of red cell. Because of cytopenia, most of these patients will require a transfusion. As I mentioned, there must be an available ICU in case of anything. RRT would be available, because in our hospital, we are lucky that we have a crash bed, which is available for any transplant patients. So in an emergency also, we have a special card which gives to all the transplant patients. As soon as they come to the hospital, they have a fast track. Then you have to have a trained staff in order to manage in case of complication. And we have to have outpatient beds in order to manage some of the hydrations. The other important members of this transplant is clinical pharmacists. They are responsible for the chemotherapy agents, immunosuppression, and also they help in the drug monitoring in order to know the drug level of these patients. And supportive medication, like also antiviral, also is the duty of the pharmacists. BMT success depends on seamless, integrated, multidisciplinary approach. So one system, one goal, and get better outcome. One of the most important things is nursing role across the BM journey. As we mentioned before, because when we start the transplant, the first pioneers to go are the nurses. So the nurse is consulted with the patients in all the time. For example, during the pre-transplant period, patient preparation and education, patient preparation, family preparation, physical and emotional support of the patient is important. Emotional support of the patient is very essential, because anybody who mentally is not prepared, the physiology also will not respond. So therefore, psychological preparation of the patient is very essential. And more or less, these are done by the BMT coordinators. Care planning and coordination. Coordinating and multidisciplinary plan will be. This planning will involve, because for example, if any successful BMT group should have a WhatsApp group or email in order to share information and preparation. Infection control, optimize patient condition to reduce transplant problem. Venous access, also assessment of the central line, as well as therapeutic
3 minutes, 3 minutes.
Then during the transplant also, close monitoring and continuous vital sign monitoring is essential. All are done by the nurses. So early detection of intervention of this sepsis, toxicity, mucositis, or DIC also is done by the nurses. Medication administration and safe delivery of immunosuppressant also done by the nurses. Emotional support, providing empathy, reassurance, and psychological support also is duty of the nurses. So transfusion and fluid imbalance, ensuring that transfusion is maintained and accurately followed is the nurses. So you look at this journey, nurses are one of the key drivers in this transplant period. But also, not post-transplant, what will happen? Post-transplant, the monitoring of the patient, especially the acute graft-versus-host disease, infection control is essential. Patient's caregiver education also is not only the patient. Once as a nurse is a teacher to almost all. He will teach the patient, teach the relative, teach the cleaners and others. Promotes adherence to the infection control policy is essential. Nurse also is going to be responsible for rehabilitation of the patients and then long-term follow-up. So nursing cannot be just, nurse is not just supportive, it's a transformative. So our expertise, vigilance, compassion can make difference in patient treatment and healing. So patients joining pace of the nursing focus, as I mentioned earlier, pre-transplant patients assessment and risk education of the patient, care planning, infection prevention, venous access, and psychological support, all essential. During conditioning period also, the nursing focus is on safe delivery and conditioning of the infusion cells. So administering of the conditioning regime, monitoring of the vital sign, and assessment of the side effect, and system infusion are all the job of the nurses to be done. The early post 100 days, this is one of the crucial periods, so it needs a proper monitoring, and then notice to the physician. So during the post 100 days also, there's a possibility of chronic graft-versus-host disease. Also, the nurse will continue monitoring. Lastly, surveillance. After the patient discharge also, the nurse coordinator will be in consult with the patient, calling them, assessing them, following about the vaccination process, all this. So every phase is critical. Nursing excellence across all these save life, fewer complications, and better outcome. So infection control, as you know, infection, you know, is a successful invention of the body tissue by pathogenic microorganisms.
1 minute only.
Okay, so one of the most important that we are underlooking is hand hygiene. Although hand hygiene is a single thing that helps the patient in order to save. The patient protective isolation, very important. Environmental control, this is not only for the nurse, even the cleaner, which is cleaning should be educated. Then early detection and surveillance also is very essential. Prophylaxis antibiotics, which is to be given to us. And then engagement patient education is essential about this one. So innovation is very important. Innovation, it will help you to create and look for a chance of advancement in your transplant period. Then gap analysis, there's a lot of gap analysis. This gap analysis is clearly due. So a building a class sustainable bone marrow program should have a better patient care. As time is going, let me go. Sorry. So can I go? Okay. So patient impacts, as I mentioned about, the most important thing is that building a high-performing bone marrow transplant is not just an achievement. It is a transformative which saves life and shape the future of the nation. So therefore, with the Saudi mission of Vision 2030, bone marrow transplant would be very important to be important. Patient, it impacts quality of life, it improves the system, it keeps patients to be treated at home, and also it gives an opportunity for the young nurses to get a better future in advancement, because currently we have BMT coordinators and laboratories special in stem cell. So therefore, bone marrow transplant should be encouraged in all levels, so whereby we should have a sustainable system whereby our hematological patient can be treated without any delay. So these are my reference about the period. And these are the group which we set down in order to start our first transplant in the hospital. And this is our hospital. Thank you very much for your attention.
Thank you so much, Muhammad. Sorry, we cannot take the questions because we already ran out of time, so we will present next speaker.
Very nice presentation. Thank you, Bashir. Next speaker, Hamza Al-Quran, is a clinical nurse specialist with more than 15 years of professional nursing experience. He currently serves as a clinical nurse specialist at Ministry of National Guard, Health Affairs in Riyadh. Please let me welcome Mr. Hamza.
Thank you, Mariam, for the welcoming, and I would like to express my deepest appreciation for the organization committee and the scientific committee for giving me this opportunity to present our experience about outpatient transplant for lymphoma patient. So through this session, I will walk you through simply background about the lymphoma and outpatient transplant program, program outcome and statistic, lessons learned, and future direction and conclusion. So lymphoma is a type of cancer that begins in the lymphatic system, especially in white blood cells called lymphocyte. Lymphoma is the most common blood cancer, accounting for approximately 4% for all newly diagnosed cancer cases and 3.3% of cancer-related death globally in 2024. International statistic, approximately more than 800,000 new cases of lymphoma are expected globally in 2023. Lymphoma causes approximately more than 300,000 deaths globally each year. In US, lymphoma is the seventh lead cause of cancer death, and the age standardized mortality rate of all lymphoma is 4.7 per 100,000 people. The global prevalence of lymphoma is approximately 7.6 million. And in the US, there were an estimate more than 800,000 people living with lymphoma in 2023. 5 years relative survival rate for all lymphoma is approximate 73.1 in US, and 5-year survival rate for Hodgkin lymphoma about 87.3. 5 years survival rate for non-Hodgkin lymphoma is 74.1. In Saudi Arabia, as you see in the slides, the second in males, the second most frequent cancer is non-Hodgkin lymphoma, and for both sexes, male and female, fourth rank for the cancer in the Saudi Arabia. Despite there's a lot of treatment modality nowadays for treatment lymphoma, but still in one stage, in one lines of treatment for Hodgkin and non-Hodgkin lymphoma, the standard of the care, the treatment or the standard of the care for some cases is still transplant. So our program background. In National Guard, King Abdulaziz Medical City Al Riyadh provides comprehensive evidence-based care for adult patients require stem cell transplantation and cellular therapies. The program performs both autologous and allogeneic stem cell transplantation and other cellular type therapies. Since of the official establishment of the transplant program in March 2010, the division has performed more than 1,000 stem cell transplants, representing a significant institution milestone. The success has been supported by a multidisciplinary team that included transplant physician coordinators, pharmacists, nurses, and allied health professionals dedicated to delivering high-quality patient-centered care. The outpatient program, autologous stem cell outpatient program, started in 2010, and the outpatient transplant model launched in 2018. Temporarily paused during a COVID pandemic and returned back at the end of the 2022, then resumed after the pandemic. Primary population for our program, lymphoma patient receiving beam conditioning. So why outpatient transplant? Globally, we show improve patient experience and satisfaction, home environment, reduce inpatient bed utilization, lower healthcare costs, promote early mobility and family support. Outpatient transplant workflow pathway. Again, as mentioned in all the previous presentation, a multidisciplinary approach, a multidisciplinary team is milestone for every work or every success. So multidisciplinary team task force initiated to develop policies and clinical practice guidelines, consist inclusion and exclusion criteria for outpatient transplant, patient clearance for outpatient transplant, outpatient transplant and admission flow process, the rapid access beds inpatient unit, pathway after working hour and triage system for the rapid access beds, discharge from outpatient setting, the daycare. We'll go through the guidelines. We're starting inclusion criteria. By the way, this inclusion criteria not all for the lymphoma, for the whole program. It's covered for auto and allogenic. Under age 60 of the years, good performance status with echo 0 or 1, live within an hour drive from the hospital or willing to stay at housing close to the hospital, have a responsible designated caregiver who can be with the patient 20 hours a day, 7 days a week. Exclusion, fully myeloablative conditioning for the allotransplant, Thiotabia, busulfan, cyclophosphamide-based conditioning for auto, for CNS lymphoma excluded. Hablo, transplant, cord blood allogenic, history of liver, kidney, or heart disease, non-compliant patient. Patient assessment for outpatient transplant, we have two checklists major before to select the patient or the start the patient for our program. Checklist number 1, eligibility assessment, which is the inclusion criteria. The second checklist is compliance and social assessment. So one of the part or one of we did from the policy and guidelines is modifying the conditioning regimen. You know, the beam conditioning is the most conditioning protocol, chemotherapy protocol using for auto transplant for the lymphoma patient. And this protocol is consist for chemotherapy, starting from day 7, day 6 to until day 0. So the etoposide and RC, including the protocol, is most of the institution using by 2 or divided by for 12 hours. So in outpatient setting, we should modify this protocol to be suitable as outpatient setting. Again, the daily assessment for the disciplinary through the patient journey with daily nursing assessment, nurse coordinated flow-up, health educator involvement, and pharmacy support, daily communication across the team. So as the picture showed, the highly effective and integrated communication between healthcare providers is very important, and it reflects our outcome. Our program is starting from a pre-transplant nurse coordinator, which is responsible for the patient clearance, for a pre-transplant workup and clearance. Inclusion and exclusion criteria should be raised in that assessment, and the checklist 1, checklist 2, as we mentioned, should be done before the patient to start the journey of the outpatient. All of the clearance and inclusion should be co-signed and should be provided, and assessment with the most physician responsibility. Again, before the patient to start the outpatient auto-transplant journey should be assessed, and a special session for the education should be provided for all the patient by health educator, provided education material about the outpatient transplant, about the central line, about the chemotherapy protocol, and provide special card, which is called alert card, including the on-call, including all the contact number. The patient, if he needs any queries, he can contact 24 hours. And provided the special roadmap for an Arabic roadmap for the patient. Again, in our program, we had dedicated outpatient transplant coordinator, and she's responsible to review pre-transplant checklist and clearance form. This is a second checkpoint for the patient after already checked by first coordinator as a pre-coordinator transplant. Daily visit to outpatient oncology until full recovery or admitted. Check conditioning was ordered 24 hours prior, and check the roadmap to check the availability of the roadmap, to check all the clearance form and the other investigation. Daily assessment by SCT nurse coordinator and assigned SCT physician and consultant covering the outpatient service. Collected the lab order, administering the conditioning, make sure the patient received order medication. This will be help with the consultant and multidisciplinary team and the nurse team leader. As a type of continuity of the care pathway after working hour, as we mentioned before, we have on-call, physician on-call, and transplant coordinator on-call. Patient need medical attention after working hour. The patient will be directed to the rapid access bed in the inpatient unit or the emergency department, depending on the urgency of the condition complaint. The patient will call the on-call physician and the phone if she develop any symptoms. The SCT coordinator on-call phone will be a backup, a second contact number. The on-call physician will apply the triage system for the patient's symptoms. The on-call physician will guide the patient to either come to emergency department or come to the rapid access bed in patient unit, or wait until the next day to come to the clinic for assessment based on the triage system. If the patient is directed to come for direct admission, then the charge nurse for the inpatient unit receive the patient and active the patient as inpatient. The charge nurse will on call for assessment, and he will be on call the consultant for the assessment again. So, again, as a continuum of the care, the dedicated outpatient transplant coordinator should be daily endorsement by email the sheet, including the all active patient. She will send by email for involved teams, transplant day status, current clinical issues, recommendation for the on-call team, improve continuity and patient safety. And including each email, the provide a triage system. It will guide the on-call physician to classify the patient depending on their symptoms and query questions. 24 hours, 7 days on-call contact number for the patient. Patient report symptoms to transplant team, clinical triage performed by on-call physician, direct admission pathway available when needed, dedicated standby ER bed in patient unit, and rapid escalation for urgent complication. Program outcome statistic. We did, since we launched the outpatient autologous transplant for lymphoma, total 19 patients. Started in 2018, two cases, then in 2019, 4 cases, and paused during the COVID pandemic and resumed with high number in 2024 at 6 cases. The type of the patient, we did 15 cases with diagnosis Hodgkin lymphoma and 4 cases with non-Hodgkin lymphoma. Some characteristic of the patient: hematopoietic stem cell specific comorbidity index. You saw 9 patients with 0, which is one of the eligibility to for the candidate patient for outpatient transplant. 4 cases with comorbidity index 1, 2 cases with number score 2, 4 patients, and score 3, 2 cases. And as you mentioned, by experience, we can now feasible for to start the patient with comorbidity high, and we build our experience how we deal with these patients. From the total cases, 14 of the 5 patients completed their treatment as outpatient without need any admission, and 14 is hybrid, which is mean in their journey they need admission to complete their courses. Duration treatment, 14 patient, with average for the outpatient duration, the average days was 14, and for the inpatient duration, the average day is 19. And to complete the average duration for all the courses, it was 19. Reason for admission, 4 cases was admission due for reason for was bare protocol. When we start our program, you know, bare conditioning, it has complicated like GI toxicity and cytopenia, which is myeloablative conditioning. And like a global recommendation, after day 4 or 5, we'll admit the patient before to develop any complication. But when we start our program, we was admitted the patient. So 4 cases was admitted just as per protocol. 3 cases was admitted due to febrile neutropenia, and 3 cases with upper GI toxicity. 2 cases was lower GI toxicity, 1 cases for facial cellulitis, and 1 cases for non-compliance and no caregiver. In our journey, we saved a total of 255 business days was saved for outpatient transplant from the admission. Evidences from the literature, lower severe GI toxicity and infection reported, comparable engraftment outcome, improved patient satisfaction and quality of life, support careful patient selected model, challenging and lessons learned, need strong caregiver commitment, fast, effective communication is initial, a clear admission criteria prevent delays, education must be repeated and documented, nursing coordination is central to success. A future direction, expanded outpatient eligibility is safely increased fully outpatient completed rate, a formal patient satisfaction survey and cost analysis study, published institution experience. Conclusion, we conclude outpatient transplant, autologous transplant is feasible in selecting the former patient. A strong nursing coordination drives success, improve patient-centered care, optimize hospital resources. Our experience supported continued to expansion. So this is our team from the adult stem cell transplant behind any success. And again, happy Nurses Weeks. Well, thank you all for this attending.
Thank you, Hamza. Any questions? So we can finish a successful nursing 13 nursing conference, SSBMT. Thank you so much for the people who stay until the last minute. Appreciate it, really. Thanks a lot. Appreciate all of you, and have a nice end of week. Thank you.